tumor, then what is your differential diagnosis? And is there a definite diagnosis for this lesion?
Yes, actually, one patient said this may be a neural endocrine tumors.
Yes, neuroendocrine. Yes. Interesting.
And the margin just 0.5 away from the energy of the lesion.
Professor Wang, the rationale in using the robotic system is that you start with classic ESD, and then after finishing the circular incision, you will use the endofaster, right?
Yes.
So we can move to Al-Azhar University. We can move to Al-Azhar University. We will move to, like, for a few minutes, Dr. Wang, to another station till you start your ESD procedure.
Okay.
Just stay with us.
Morning, Shaima.
Good morning.
Good morning, everybody. This is Mohammed Al-Barai from Al-Azhar University in Cairo, Egypt. And I'm doing an endoscopy with my friend, Dr. Ahmed Maher. This patient is a 46 years old man who presented with iron deficiency anemia. He did endoscopy and colonoscopy, and they didn't find a source for the bleeding. So we are deciding to do a double balloon enteroscopy to see the source of the lesion. Now we are inside the proximal jejunum, and as you see, we have here angiectasias, and we will go to do the ABC for these angiectasias.
Good morning.
Sometimes when you do the enteroscopy, sometimes you see that the small bowel is moving, and we have some tips and tricks to do that. That we usually put a distal attachment cap to stabilize the scope, or to give the spasmolytics sometimes to also to stabilize the scope, to decrease the movement of the small bowel. We use the double balloon enteroscope from Fuji, and we use the RB Via 3. Do you see the picture with me, Shema? Hello?
Yes, Dr. Muhammad, we are hearing you, yeah.
Okay, okay.
Dr. Borai, what is the usual setting that you use when you do APC in the small bowel?
Hello?
Yes, did you hear my question?
Yeah, Shema.
The APC settings that you use, what do you use? Pulsed APC, forced APC, which what in the small bowel?
Good morning. Usually we do ABC using forced coag, pulsed, and the effect usually between 20 to 30.
So what about the use of a distal attachment cap? Do you prefer if you use a distal attachment cap?
Yes, we use it frequently to stabilize the position, and to spread to to open the folds to see more. If you have a challenging lesion in between the folds, the distal attachment cap is very beneficial. And also we use the spasmolytics to decrease this. As you see, there are a lot of contractions here, and we usually use the spasmolytics to decrease these contractions. Can we give Buscopan, please?
So what do you think, Dr. Bora, about the hybrid APC that you inject and then you do an APC? Have you tried this in the small bowel?
We usually do ABC injection is not beneficial in this. And also if the patient is having extensive lesions, we repeat it many times. And we can also consider the medical therapy if available. But I think it is not available in Egypt, like thalidomide. So we usually do frequent sessions of ABC.
So we will go to Al Nas Hospital, Dr. Borai, to start our third case, and then we will come
Okay.
back to you in a few minutes. Can we go to Al Nas
Thank you.
Hospital?
Okay.
مستشفى الناس?
Hello, everyone. Can you hear me?
Yes.
Hello, everyone. Can you hear me?
Yes, we are hearing you, doctor.
Okay, we'll start with the first case now. It's 52-year-old male patient, non-diabetic and hypertensive. The patient presented by recurrent attacks of abdominal pain 4 months ago. Abdominal ultrasound showed pancreatic tail cystic lesion 2.5 by 2.5 centimeters. The patient had CT abdomen with pancreatic protocol that revealed pancreatic tail cystic lesion 3.3 by 2.7 centimeters. There were no internal septations, no solid enhancing nodules, no calcifications. There is another pancreatic body cystic lesion 3.5 by 2.2 centimeters with few thin internal septations and few peripheral calcific foci. MRCP was done, showed multicystic lesion at the body of the pancreas, showing no solid component or diffusion restriction, resembling a bunch of grape. It showed not a connection to the pancreatic side branch. There is another unilocular cystic lesion is noted at the tip of the pancreatic tail, as you can see in the image. So this patient is a pancreatic body and tail cystic lesion for differential diagnosis for endoscopic ultrasound plus FNA/FNB by Dr. Saad and Dr. Ben Azouz.
Dr. Saad. Dr. Saad. Dr. Mustafa. Do you hear us?
With my colleague Suad from Algeria. Me, I am Dr. Benazouz from Rabat, Morocco. Thank you so much for the organizing team here. Everything is okay. Everything is fine. Thank you so much for all what you did to prepare this nice workshop. Today we have a patient with the cystic lesion of the pancreas. As you know, this situation is very frequent situation in our practice. This lady have, as you see here, a cystic lesion discovered on US and MRI. She had 2 cystic lesions, one in the body and the second one in the tail. Now, Professor Saad is looking for the lesion in the body.
Yes.
And as you see, this lesion is around 25 millimeter by 30 millimeter in the body.
Multilocular.
This lesion is multilocular. Can I have the pointer?
Has
to show
many
what-
lobulation.
This lesion.
Here's the
Yes, thank you so much.
Here's the penis.
This lesion, we will go to the system. This lesion, as you have a tubular aspect here with multilocular, with multilocular aspect here. We have some septa inside, as you see here. We have some septa inside. We check for mural nodule, but really we don't have it because, as you know, mural nodule is a good size. Yes, it could be high risk, some future stigma or high risk stigma. It depends on the size. More than 5 millimeter is high risk stigma. Less than 5 is worry some future. Here we are looking for mural nodule. We cannot find a mural nodule, so it is a kind of good sign. We don't have it.
No one
We don't have one thickening. Yes, the size is 30. It's limit 30. It's a
30
kind of
is a
work in some future.
Yeah.
Now we can also we asked for the clinic. This patient have not acute pancreatitis or jaundice,
Just
have
abdomen-
diabetes or not?
just
No
abdominal
diabetes.
pain.
She had diabetes recently diagnosed?
No, I don't think.
Because diabetes now is considered as some in future, yes. Diabetes, pancreatitis, jaundice. Jaundice is a high risk stigma. We don't have jaundice. Exactly. After that, we need to study the lesion well and the content, the wall, the mural nodule. But the most important thing is to look to MPD.
Yes.
Communication. Yes,
And
it
here's
is
the-
a cystic lesion from the main pancreatic duct or from branched duct,
Mhm.
and also
Is that
to see the size of the MPD.
Yes.
Now it is a challenge. I know sometimes it's not so easy
Easy to
to
find
see
the
the communication between cyst and MPD. And please try your best
Yes.
to show us this communication if you can. And after that, we will check for the size, because as you know, 10 millimeter and more, it is a high risk stigma. It means malignancy. More than 10, you have to operate patient if we can do. If it is between 5 or 10, it's some. Yes, rupture, and less than 5, it's okay. But between 5 and 10, it's still some concern. Yes, it's still some concern.
Mhm.
And here, really, I didn't see a dilatation of
No,
MPD till
no
now.
dilatation,
We see
And-
where you in the neck, we see it very well.
Yes.
It was not dilated,
no dilatation.
but in the body,
and
we have
tail-
some difficulty to
Yeah. Mostly this one is the PD. Mostly this one. I don't know how.
I will do some Doppler, please.
This one here, please.
Can Doppler, please, Doppler.
Can
No.
you see? No.
Okay.
Not this one. So as Professor Benazou said, in these cases, we need first to make the diagnosis, and the key of the diagnosis is to find this communication with the PD.
Exactly.
So we try to find it, and we think that this one with the cursor,
Yes. The
cursor
cursor is this one. To have the marker.
this one is maybe the PD, and the lesion is mostly communicating with the PD.
I will be quite nervy, like this, no.
And
To have the
the
marker.
thing is to, so if we find this communication, it's branch side IPMN, and then we look for worrisome or high risk stigmata, because these features will help us to choose,
Here we have the cyst.
okay, the management of this lesion. And the PD is right here, this one.
Maybe.
It can be this is the duct. And we can go inside,
دكتورة
just
سهيل
inside the.
دكتورة سهيل حد سمعنا هناك
Yes, دكتورة
صباح
شيماء.
صباح الخيرات
صباح النور.
بونجور
Bonjour. Bonjour. We will not talk French.
دكتورة سعاد I'm sorry I have to shift to China because they started to use the robotic device. Just give us a few minutes
Okay.
and we will back to you, okay? ادخل على الصين يلا يا درس.
Très bien.
Still looking for the beginning.
Yeah.
So Professor
Allez.
Wang, do you hear us? China? Professor Wang?
Yes, very clear.
Hi, how are you? We're back to you. So now you're using the Endofaster. Can you please explain more to the audience about your device?
Okay. And we can see the arm outside the work channel, and it grasps the tissue and lift the tissue. So we can see the submucosa level very clear. And we also can see and we can change the grasp side open. Okay.
Hi. So
We can change the side, other side, so we can,
Professor Wang, can we know the range of movement of the device? We can see the lady helping you. She has the handle in her hand. Can we see the range
Okay.
of movement?
看这个视频，给它切到这儿了。
Yes, we can see her. We can see her very, very nicely. We just want to know the
Okay.
range of movement, the angle. We move right to the left, up and down, the rotation angle.
Okay, we change the video. We don't need to, okay, we just turn left, 分左 turn left. 抓住它。
So, Dr. Wang, do you believe that the endofaster is
expert in ESD, but I just want to know what is the advantage for this. It's better than doing it manually. It's time saving or effort saving.
再加。
Yes, this is of course a perfect question. So everybody is turning to the endorobotics now. So the idea of what's the problem was the ESD, that you are a single-handed surgeon. So you need another hand.
再走。
So the presence of the endorobotics is that you need another hand to assist you. And there is already a very good device in Korea, but it has some advantages. First, it's the long hand. So it keeps you as a distance from the lesion. Second is that you're not able to use the cap. So the endofaster is a simplified device, and it's better because you can see we are close to the
回来一
lesion.
点点。
Second is that you still can use the cap. And the thing is about the rotation of the angle. What is your limitation? Is it only 30 degrees or it could be 90? Can I shift right, left, up and down, or I can do like a complex angle?
开吧。
So this is, I believe that the robotics, there are still more to give us just than just the traction.
算了，
So I
回来吧。
thank you for the
回来。
question. So Dr. Wang, there is a question from the audience about the add-on benefit of using the endorobotics for endoscopy. If we think compared to the classic traction techniques that we use.
Yeah, compared to traditional ESD, and it's hard to see the mucosa layer and the tractions. Maybe the most biggest challenge. Just like this, we can see the submucosal layer. We have to push the scope and to change the angle. We have to inject a solution. We still can see the submucosal layer. So we try to, and I think it is a difficult location for ESD. It is just a poster wall.
So we have a question here from the audience, Dr. Wang.
Yeah.
Good morning, sir. Thank you so much for this interesting case and this new device for us in robotic. But I'd like to ask you a question. Which one is better to use like third-handed for robotic or to use something like through the scope by Endomotion, by like for example by Fuji? It also add a third arm or something to do traction. So which one is better?
Which one is better?
Yes, he's asking about the traco motion of Fuji device. Also, do you think it's if you compare it to the Endorobotic, what's the advantage?
Sorry, I didn't try another device, so I can't compare the benefit.
Actually, I can answer this question because I've worked with both of them. Still, the tracomotion device from Fuji is a bit cumbersome device. It's and the range of maneuverability, yes, is limited, and sometimes you need the therapeutic scope to use. So it needs more modification. But this device, because I use this device is really a simple device, and it's from outside the scope, so you still can use the working channel. There's something comes in the way. And there is an interesting thing here that he left the lesion and he can catch it again. So this is one of the things about the Endofaster,
Okay.
that it's an easy, it's a customer friendly device. So when I was in China, it was easy for me to use it because once you're an expert in ESD, you find this very helpful. So Professor Wang, thank you. We'll come back to you. Can we go back to Al-Azhar to see Dr. Borai?
Okay, thank you.
We'll come back to you.
Okay.
Hello, Shaima.
Dr. Borai.
Yeah, we are going as deep as possible. As you know, the enteroscopy is a lengthy procedure. It takes like 2 hours to finish. And then we go as deep as we can and we ablate whatever we see till we finish the most of the lesions that we see in one session. And we follow up the patient later on. And then if we need to repeat, and this most probably happening, we need to repeat more than one time to get rid of all the angiectasias. Patients also mean
Finally, you find the Basco band for the patient.
yes.
My question.
It's now.
I'm greeting you, Dr. Borai. Thank you for the nice work. My question how far would enteroscope reach the maximum part of the small bowel from the oral side? Will you complete your work by colonoscopy and visualizing the most distal part, because sometimes you may find another angiodysplasia in the far small colon, in the ileum or something like that, or you will do it per oral only?
Okay, thanks, Professor Hussein, for this question. This very important tip here that we should do endoscopy and colonoscopy twice. At least I do one of them in my institute before doing the enteroscopy, and I go with the enteroscope as far as I can from bare oral. For example, if I'm suspecting a proximal lesion, but if we have a distal lesion in radiology, we usually go by rectal examination. For those patients with angiectasias, we do both approaches because most of the time you cannot reach the ileum by the upper or the perioral route. Rarely you can reach that if you have a patient who have short bowel or have resections, but most cases needs to be done from both sides, perioral and rectal, and usually in separate sessions, not in the same session.
In a separate session. Okay.
Yes.
في سؤال ليك يا دكتور بوراي.
دكتور بوراي ازي حضرتك؟
Morning.
دكتور فهمي معاك.
Yes, good morning, دكتور فهمي.
ازيك يا حبيبي؟ بالنسبه للسيتنج بتاع الاي بي سي في السين ستراكشر زي السمول باول والسيكم والاسوفيجاس، do you use forced ABC, pulsed or precise one?
It's better to use the forced one. Sometimes we use the precise. The precise makes the current is stable, whatever the distance you are having from the mucosa. As you see here, the small intestine is moving frequently, and when you use the precise one, you will keep the current stable all the time, whatever the distance.
Okay, thanks.
Dr. Borai, I have a comment on the APC because I personally prefer to use the pulsed APC, especially in small bowel because it's a bit protective. Because if you cannot control your pressing food, the pulse APC will control it for you because it's not continuous. So I prefer, and maybe I'm
That's
using pulsed
the very
APC.
thin.
Yes.
Very thin structure.
The what?
Yeah.
Very thin.
It's very thin.
Small
Yes.
bowel is very thin.
Semi.
Small bowel is very thin structures like cecum.
Yeah.
Yes, I use the pulsed APC.
Pulse.
تسأل على الوات ولا على ال
لا لا على السيتنج اللي هو البالسل والبريسايز one.
I use the pulsed.
Pulsed.
I love the pulsed APC because it's controllable. It's controllable a little bit.
Okay.
دكتور برعي آخر سؤال قبل ما نمشي. What do you
Yes.
usually do in the APC? Do you go deep and then do the APC while you're coming out, or you?
Yes. Deep as I can, and then I do the ABC while going out.
في
Good
سؤال.
morning. Good morning, Dr. Muhammad. I'm Dr. Muhammad Salah from the Military Academy.
Good morning.
Good work, sir. But I have a question regarding
Yeah.
the case you're working on. It's a case of obscure GI bleeding. And here you find the angiodysplasia that you do APC. I agree with Dr. Shaimat to use the pulsed APC
Yes.
to have better control on the pedal of the RB machine or whatever diathermy you are using. My question is, what if after the APC you do, the patient still has bleeding? Would you go for another session? Or if you are approaching now by the upper or oral approach, would you go for the transrectal approach to search for other telangiectatic patches in the same patient?
Yes. Usually we cannot finish all the angioperias in one session, and the patient will need multiple sessions. The issue here is when you treat the patients by ABC, you decrease the frequency of blood transfusions and the need for admission. So most patients after this session, they will keep stable for months. So if you follow those patients with hemoglobin and iron studies, and then if you need to repeat the session, you can repeat it. But usually patients needs a lot, many sessions to get eradicated from this. And many sessions means per oral and per rectal.
Okay, sir.
Dr. Borai, thank you so much. We will shift to Al-Nas Hospital with a new case. The session is 90 minutes, and so now we have only 35, so still have 1 hour. From Al-Nas Hospital, what's the next case? Ahmed معانا?
Yes, the next case presenting. Yes, doctor, I can hear you. The next case is a 54-year-old female patient complaining of alternating bowel habits 1 year ago. Colonoscopy was done. Colonoscopy was revealed transverse lateral spreading tumor about 1.5 centimeters. Granular homogeneous type. Paris 1S, Janet 2A.
مش ظاهرة يا جماعة. أيوة.
Can you see the slides now?
أيوة شايفاها يا أحمد، يلا كمل.
Okay, so this is the first lesion. The second lesion was seen in the descending colon. It's a pedunculated polyp with wide base pedicle. The pedicle is about 1.5 centimeter, and the head was about 2.5 centimeter. Paris 1B, Janet 2A. So this is a case of colon lateral swelling tumor and descending colon polyp for endoscopic mucosa resection by Dr. Mayo and Dr. Karim.
Okay.
صباح
Can you hear me?
Hello. Hello, good morning. Mayo.
Can you hear me?
Yes.
Hi.
Hi.
Dr. Saima, thank you. Thank you for inviting me to this wonderful conference, like the Cairo Endoscopy. And so we have many colleagues here helping me out. Actually, I'm working on the second lesion in the descending colon, which is a pedunculated polyp. And actually, I already put the loop, endoloop already at the scope, and I'm now trying to cut the endoloop first. I already did the ligation with the endoloop. So I will now start it.
So Mayo, good morning. So let me introduce you to the
Morning.
audience first.
Thank you.
Thank
So
you.
this is Dr. Maya Tanabe from Japan,
And you.
and really she's an expert in ESD. So Maya, you choose to put the endo loop, and then
Yes.
and then cut. Yes. So
Yes.
can you just explain to the audience why did you choose the endo loop? Why not direct hot snaring or EMR or even clips and polypectomy?
I think both is okay for this lesion, but I felt that this lesion has a little bit relatively large stalk for me at the first, and now I already put the endo. Sometimes I choose only clips. Maybe I can just put 2 clips on the stalk and then cut. And I don't usually choose direct polypectomy for this kind of pedicular lesion.
We were discussing the option, we can do 2 opposite clips as
Yeah, yeah.
pedicle,
Exactly.
or we can put endo loop. But we choose to put endo loop safer and for proper hemostasis before cutting the pedicles of the lesion.
Exactly. Thank you.
So Karim,
So now-
you already deployed the endo loop?
Yes.
Yes.
Now we are trying to cut it by endo loop cutter before polypectomy.
Yes.
So,
Because it can come.
So Karim, after you deployed the endo loop, you just want to cut the redundant part of the endo loop. Is it a common
Yes.
practice? Is this a common practice, or you just get your snare and get the polyp out?
Because sometimes this kind of loop can tangle when you're snaring with a snare. So I usually cut it before I put the snare the final cut for with the snare. Can you open it?
Yes, so for now, prefer to cut it before polypectomy. But I think if we leave it, we can also do direct polypectomy.
Yes, exactly.
It's better to cut.
Karim, I will go to the EUS case to see the case with Dr. Fahad and Dr. Ben Azouz, and then we will come back to you after you cut the endo loop.
Thank you. Thank
Okay,
you.
waiting for you.
So Dr.
Can you
Saad,
rotate it? Can you
Dr.
rotate?
Saad and
no.
Dr. Ben Azouz. دكتور سعاد بونجور، حد يكلمها فرنساوي طيب يمكن. الدكتورة ندى هي معانا ايه؟ بغليلو فرنسي.
يلا on est prêt.
Yes, Dr. Saad and Dr. Mustafa Ben Azouz, deep, sincere greetings.
Cystic lesion in the body.
Yes.
This lesion seems to have a tubular aspect with multilocular. Please, the
Multilocular cysts.
دكتور
pointer, please.
مصطفى، دكتور مصطفى بن
Yes,
عزيز،
please.
دكتور حسين.
Sama, this is Dr. Rajput from India. Congratulations for the great conference. Dr. Rajput from India. How are you?
How are you? How are you?
Yeah, I'm
Dr.
fine.
Sanjay, good morning. How are you?
Yeah, good morning.
Dr. Sanjay Rajput from Ahmedabad with us online. So do you have a comment?
Yeah.
Dr. Mustafa
Yeah.
Ben Azouz.
Yes.
We are looking for all the cases and I am enjoying. So just let me know. Thank you.
So Dr. Mustafa.
Shaiman, صباح الخير, good morning.
Good morning.
Now we have already done our exploration for this lady with the pancreatic cyst. Now with Dr. Suad, we have the lesion here in the body of the pancreas, and you see this lesion have a tubular structure with multilocular aspect with some septa. We don't have yes, this position is good. We have some septa, but we don't have mural nodule, even less or more than 5 millimeter. No intramural nodule, which is good. This lady have also no dilatation of MPD. We will show you the MPD now. This MPD is here. We will see it. Just wait, because it is not dilated MPD. It's anti-oral. We have it. Yes. Okay. Here we have the MPD. The MPD is not dilated, it's 3 millimeter, and we have a communication between MPD and the lesion. So it is a IPMN in
Side
the
branch.
body, side branch IPMN with communication with MPD, which not dilated. We don't have high risk stigma. We have only two very yes, some future. First one, the patient is have diabetes. This is one, and the second one is the size. The size is 30 millimeter. So only two some early futures, no high risk stigma. So this kind of lesion, we decide between us to do or not to do FNA. Our decision is not to perform FNA, just follow up by US and MRI. The second thing in this lady, MRI show us and find a lesion in the tail of the pancreas, which is IP male probably. But when we look in this lesion is a little bit far from the pancreas. And it seems to us that this lesion is not in the pancreas and maybe it is in the kidney. Here we have the kidney here, and the lesion is seen coming from the kidney and not from the pancreas.
And from the spleen.
Yes. We have here, please, just the spleen. Here we have the spleen now. And by doing anti-clockwise, we will find the lesion, and here we have the cortical and the medullary. So we are in the kidney. This lesion is coming from the cortical, from the kidney, and going extra development, not inside. So have some contact here because here we have the tail of the pancreas, and we are far from the tail. And it seems to us that this lesion is not belonging to the pancreas, but probably here we have.
Yes, Professor.
It is
Professor Ben Azouz, Dr. Hussein Okasha is sending his deep, sincere greetings to you. A nice suggestion that you are suggesting that it is not a pancreatic tail lesion. It is your suggestion that it is left kidney. Could you see us the view of communication of this cyst? It's suggested to be exophytic. Cyst. Could you visualize the relation to the left kidney, visualize the left kidney, and visualize the communication, even if small, between the cyst and the kidney? Because to me, I think it may also arise from the tail of the pancreas. So here we should be very meticulous in this view. Where is the left kidney? And this is the cyst, and where is the communication between the cyst and the left kidney? Can you remove the color? Can you remove the color?
Yes. حسين صباح الخير أولا. كيف حالك? Thank you so much for the invitation, and we are here so happy because we are working a very nice hospital with very nice team, and all people here are so kind with us. Thank you so much.
Thank you for everybody.
It is our pleasure and honor. It is our pleasure and honor.
Thank you so much, Hissine. Now I ask my sister, Suad, what you are asking for.
Yes.
We make image less we are decreasing the depth, and we will look for what we asking. Here we have the spleen. And please show us the kidney.
Yes, I'm trying to go to the kidney.
We try to have a good resolution in the point. Yes, we did pointer.
دكتور بن عزوز، احنا سعداء قوي
نعم
ان احنا شايفين المغرب والجزائر متعاونين على ارض مصر.
شيء جميل. هذا شيء جميل. Now here we have the splenic vein, we have the artery, and we have the splenic vein, the artery. Now here we have, we will go to the, yes.
I'm trying to find the kidney, but we don't have the good image.
The
adrenal gland.
We are looking for adrenal gland.
So Dr. Ben Azouz, we have Dr. Sanjay Rajpute from India. He wants to comment. Can you please turn the mic of Dr. Sanjay on?
Yes, please.
Dr. Sanjay.
Yes.
Dr. Sanjay Rajpute.
From India, who wants to come.
Can you turn on his mic, please? He wants to come back.
kidney.
Saima, can you hear me?
Yes, I can hear you. Welcome.
Yeah, thank you so much for inviting me for this grand conference. It looks like a huge success. And this lesion doesn't look like coming from kidney to me also, because we cannot see kidney. It is quite difficult to appreciate the kidney from here.
I agree. I totally agree.
Here it seems we have that image.
Yes.
Because it's so.
Yeah. Yeah, this
Like
looks
this.
like an isolated cyst, maybe coming from below the pancreas.
Okay.
Here we have the vertical of the.
I would like to congratulate Sam and his team.
Yes. So
Thank you. Thank you.
so احنا
Then we have discussed a lot about this lesion, but it seems to us it is not coming from the tail. It's coming from the left kidney, not from the tail.
It's too peripheral.
Yassine, you agree? Ustad Ukasha, you agree with us or not?
Agree that it is originating from the left kidney.
Yes, we believe that.
دكتور عكاشة احنا ما بنفهمش قوي في الاي او اس، بس واضح ان في خناقه اذا كانت دي من الكدني ولا من البنكرياس.
Sometimes it is very difficult to differentiate. Sometimes it is very difficult to differentiate. Be sure that it is originating from the left kidney. I should see the left kidney and choose a cyst and even the very narrow communication between both. So everything is possible. It may be arise from the the left kidney or the tail of the cyst. But now let us summarize the pancreatic body cyst. As you mentioned, there are no major high-risk stigmata, but there are two worrisome features. دكتور مصطفى بن عزوز انت معايا؟ انت
Here we have the tail of the pancreas, and the lesion is so far.
Yes.
It's very far. It's not from pancreas.
Here the pancreas, near the probe. Here we have splenic vessel, and the lesion is here. And when we do more clockwise, we have the spleen.
Yeah, the spleen.
More clockwise spleen. Anti-clockwise, we have the lesion. And the lesion is, it seems to us that is far from the
pancreatic parenchyma.
Our diagnosis, we can see again the MRI and the CT. We can perform also transcutaneous.
Dr. Ben Aziz, we will leave you for a couple of minutes and we'll go back to Dr. Maya Tonabi for the EMR case. ممكن نرجع.
Okay, maybe we can.
On la voix de là, regarde. On m'a pas l'habitude de.
لا مش عايزين خناق بقى.
Okay, Saima.
Dr. Mayo, how was your cutting the endoloop? Did you cut the polyp, ya Karim?
Yes. Actually, we finished with the first clip, and we are now facing the second one in the transverse column. And actually, this patient has, you can see the melanosis and a little bit slightly elongated sigmoid, so the maneuverability is not so good. But I will proceed with this lesion with the EMR in this case.
So Mayo, yesterday we were discussing about the option of underwater EMR. Can you explain to the audience which technique you are going to use?
Yes, I'm thinking of underwater EMR and here, but this patient has a slightly not a good preparation, so the water is a slightly I think I can go with this. Okay, here you can see it clearly. And I'm using a Olympus Easy 1500 scope, and which has a near focus mode, and you can see nicely this lesion has no malignant appearance or features, and I think the J-net is type 2A to 2B, so I have to change it to the NBI.
So Mayo, can you please, Mayo, explain to the audience how do you characterize the lesion, please?
Okay, so this is the lesion in the mid transverse colon, and this has a laterally spreading component, but I classify this as a 1S or LSD, maybe close to granular, but yeah, you can see that, yeah. You can see some parts like a granular part too, and those are almost homogeneous. So I will say 1S or an LSD. Okay. So but this region is not so big, so I think it's around 50 millimeters to 2 centimeters. So I think I can go with EMR with this region. Of course, if you want to be confident with envelope resection, I think EFT is was the best procedure. But you know, it's sometimes time consuming. In this kind of such a not a patient with not good maneuverability, so I would just go on with EMR in this case.
So
we
Mike,
can both.
when you use underwater EMR, do you inject or you just depend on the water in the colon?
Actually, I will inject to be more sure to for a safer protection. So I will add injection.
So you will inject as well. So this is a really good teaching point, because underwater EMR usually means that you depend on the buoyancy effect of the lesion.
Yes.
Yes, but as well you can still inject. As well you can still
Yes.
inject to be
Oh,
more
yes,
and more
yes.
safe.
Yes, exactly, and it's more safer, I think.
So now we
I think
want
you can
we
go
want
on
to see you
definitely, but-
removing the polyp. We don't want to go back after you cut the polyp. كريم عايزين نشوف
Sorry.
يا كريم الاي ام ار دي من المره. انت يا كريم ازاي تسيبها تقطع البتاع من غير ما نشوفها يا كريم؟
We put an envelope and the cut.
Yeah.
After
Sorry,
cutting,
We found it.
we discovered that we cut below the envelope, not above the envelope.
But
So we
yeah. Yes,
on the left.
but it was okay. So can you needle out and can you flush? I don't want air to be in the submucous. Okay, perfect. So now let's see how I can inject. The injection matters the most, of course. It's basic thing, but
And this when you go in MRI under the water.
I don't think so. You can, I think, because you can see the buoyancy effect, but won't
Okay.
take her.
Some
Yeah.
people don't do.
Mm.
That's
Can you- Okay. Yes, yes.
Use the bone.
I prefer safer side. Okay, I'll wait for a second. Let me say so slowly. No. Sorry, it's goes off. It's okay. Slowly. Okay. I think it's in the right place. Right place. Okay. Good. Thank you. Okay. Stop.
Very good irrigation.
See? Yes. And see this side. I wanted to inject at the other side, but in this case, a little bit difficult to go to other side. So yeah. So I just started with this anal side to inject. Sorry. Let's see. Out needle out, please. Sorry. Wait.
So what snare are you going to use, Mayo? Which snare?
Yes, but I think the underwater everything will float. Yeah, you can
Needle out.
direct it.
Needle out.
Without, without, yeah.
Can you slowly inject, please? Sorry.
We are using 27 centimeter snare.
Yes, 27.
Boston.
Okay.
Yeah.
Okay. More, a little bit more, please.
So we
Sorry,
have a
there was
question for you. We have a question from Dr. Islam.
Good morning, ma'am.
Yes.
Thank you so much for this interesting case, but I'd like to ask a question. Now you choose to do both submucosal injection and underwater EMR. I think from my perspective that underwater EMR, the advantage is we don't inject the submucosa, so we make the mucosa and the muscularis propria sliding over each other. So when we inject, I think we make the submucosa a little bit rigid. So did we lose the advantage of underwater, or it's not that rigid by injection the submucosa?
It why do we inject and we do underwater EMR.
Why you inject? As I told you, I think it's more safer to make a more efficient, yeah, protect the muscle. Well, of course, you can just choose without underwater EMR without injection, of course. But it is not
So the classic is to do underwater EMR without injection. But here, because the region is a little bit large,
Yes.
we are here to do any muscle injury, so more safe to inject
a little bit before cutting the lesion.
Yeah.
هو السؤال يا كريم بتاع دكتور إسلام he's asking about when you inject you lose the buoyancy effect, which is a quite reasonable point, because you know when you use the underwater you have this buoyancy effect. When you inject, so it becomes like less moving. So his question is, what is the advantage of underwater and injection? But it keeps
Underwater with injection. I think that you still have a buoyancy effect with injection because you know, underwater ESD is also with injection too, right? So I think it's more on the in this case I choose more the safer side. Okay, sorry with the bleeding, because the first injection that I tried punctured was mucosa, so not the submucosa. So okay, but I need more better view.
If the camera bring the hand of Dr. Mayo, she is controlling everything by her hands, even the snare by the left hand. She can push and pull the snare by her fingers, by her left hand.
Okay, thank you.
She is not removing her right hand from the scope. This is a very good point.
كريم معلش هسأل سؤال. I'm noticing that the scope is a little bit short. Are you using the gastroscope or colonoscope?
No, colonoscope.
Colonoscope?
Yes.
But I think we can. Sorry, in this situation, the underwater condition is not so good, so I will just snare with the normal EMR style. Okay.
Karim, can you tell us the audience about the type of snare that you're using?
Yes.
Boston snare, 27 millimeter.
Okay.
So you use
So you have to be
27?
Yeah,
Yes.
you have to be sure that the right side and the left side is totally yes. Oh, sorry.
The elevation with good safety margin.
Okay. Okay. So I will cut now. Slowly, please.
Intermittent coagulation and cutting. Coagulation and the cuttings. Yeah, perfect.
And Karim, معلش, I noticed that you press coagulation and cut. Can you tell us the electrosurgical settings that you're using?
RB Bio 3, ported coagulation 3, and the endocut 5, 2, 4, 2.
Sorry, I wanted to show the complete underwater EMR, but the condition was not so good with the bleeding, so I just changed it to normal CO2 EMR. But it's okay. I think you can see this is not a good injection that I did, but anyway, you can see the clear margin, free margin.
Yes, perfect.
So
we will just close the effect by one.
Yes.
So, do you like to control the bleeding point with the tip of the snare, or you just close with the clip?
I will close with clip because if you see a definite bleeding point or blood vessel, I will just maybe coagulate with the snare. But I think this is very minimal and minor, so I think I can just clip and close this defect with this region.
Just the clipping is enough.
Yeah, I think yes.
To protect the muscle.
Yes.
So Mayo is you. Do you usually close the defect or after EMR or what?
Yes, I routinely close the defect after EMR. Not with the close, of course, not with the port snare.
We have a question from the audience, Dr. Fahmy.
Yeah.
From Dr. Fahmy.
Thank you very much. I'd like to ask about as a bolivectomy, we must dry the field. If you have, unfortunately, you have a perforation after EMR underwater. What about the peritoneal soiling of this a large amount of fluid inside the lumen if you have a perforation?
He is asking about underwater EMR. If the patient is not well prepared and the perforation occurred, there will be a higher chance of soiling and peritonitis rather than under here.
Actually, but if you are not confident with if you have risk of perforation, I want to under the dirty preparation. So if it's only when it's clean.
When it's clean, yes. So don't work if the patient is not well prepared. You should clean the field before starting to do any procedure.
Wide open. One. Fully open.
Now we are using a rotatable slip, Boston Scientific 11 millimeter
Okay.
to close the defects.
So this patient have a long sigmoid, so a little bit
Yeah.
difficult to manipulate, but you can see the paradoxical movement I'm pushing the.
Yeah.
So
Yeah.
can you just tell the audience about the type of clips that you're using?
Boston Scientific 11 millimeter
11 millimeter.
rotatable clip. We can open and close several times, and we can rotate the clip.
So you're using a Boston Scientific high resolution clip?
Her belly, a little. Can you push her belly? Thank you so much. Thank you so much. Okay, perfect. So I asked him to push her belly a little bit. So open and rotate. Can you see? Rotate to 1 o'clock or.
The abdomen of the patient is a little bit redundant.
It doesn't rotate? Open? Open? Yes, that's perfect. I open please. Okay. Okay. And rotate.
We can rotate the clip and we can open and close
Okay,
several
perfect.
times.
Okay, perfect. Okay.
That's
And suction, make a suction with the suction. Okay, close please. Perfect. So fire. Fire, yes. Okay.
that's
And release it. Okay.
So
I will do a
Mayo,
second-
I want to ask you a question about the recent data published that post-bleeding EMR is a little bit worse than the post-bleeding ESD. And this is maybe to the fact that in ESD, the vessels are exposed. They are not shrinking like EMR. What do you think about this?
Yes, exactly. I think in ESD you can recognize each vessel and you make a hemostasis for each vessel. So it's clear that you already calculate every vessel. But in EMR, you know, you can see it can like appear, the new vessel can appear after this
Dr. Karim, can I
time.
ask question, please?
Yes, please.
Yes.
I'm Dr. Abdegawad Said. Is this area
Yes,
besides the resected polyp looks like a chicken skin appearance, which is mostly dysplastic? Why we didn't resect this area also?
on the left side. I think it's
Okay.
normal
Yes.
mucosa, but it is in. Which one? On the left side?
It's
No,
it's
these-
around 10 o'clock. This at the top of
Okay.
the lesion.
No, I think the bit pattern is normal. This is
This is only the
This
intestine
area.
and
This particular
yes.
area looks like a chicken skin appearance.
yeah, it's hematoma.
The first injection was the subepithelial, not submucosal. So a small hematoma occurred.
Yeah.
Makes this.
Yeah. So the injection matters the most. So sorry. Okay. Can you go?
So I can answer also, I can comment on your question, your doctor, about the chicken skin appearance.
Okay. I will
Because
rotate the both brilliant. Okay, can you also? Okay, perfect. Perfect question.
Comment on this part, yeah, Karim, about the chicken skin appearance is usually related to high-grade dysplasia.
Okay.
And this lesion actually looks like a low-grade dysplasia. And this is
Yes,
not
yes, yes.
like a true chicken skin appearance. هو ده منظر خادع من الانجكشن ومن submucosal hematoma. It's, I believe it's a low-grade dysplasia lesion. And even though if you have the chicken skin appearance, what do you do is you take a good safety margin, but you cannot resect the whole area of chicken skin appearance. And so so maybe the coagulation with the tip of the snare could be much cheaper than using two Boston Scientific clips.
Possible.
بس ايه الكليبسات دي البوسطن اللي فيها شيس؟ مش بطلنا الكلام ده من زمان يا باشمهندس محمد ولا ايه؟
But generally in the left side of the colon, we don't flow. We go forward in the right side.
ممكن نعمل coagulation بالتip of the snare والسنير يبقى بوسطن عادي برضه.
Not to read your flow, no defect. In the left, yes, not routine. Why do you do it now?
Because
Yeah, rejection area is a little bit on the right. Yeah, yes, yes.
Because generally we close in the right colon and when patient taking anticoagulant, isn't it?
for demonstrations.
The right side, right side.
Demonstration, just for
Demonstration.
Demonstration, yeah, demonstration. Yeah, to be safe, to be more safe. I have to leave the patient here, so to be more safe, I chose to put it closed. And actually, I usually use a more cheaper rotatable clip. Yeah. So
This one.
yeah. Okay. I think that's it for this thing.
Okay, perfect. Yes, we can do them the previous polypectomy. We remove the polyp with the vesicle and close the recess by one clip.
Professor
You can see
Inouye.
the elongated.
We should retrieve the region.
Oh, we do. Also, nice. It's where is it?
We notice that the patient has melanosis coli.
Yeah.
The
Elongated.
color, it's a lot of black. Yeah.
Also, if it's proximal and we have we don't then we.
Karim, I want to ask a question because this is this is a common scenario that after you resect the polyp, you lose the polyp.
Yeah, sometimes that happens.
So
Immediately.
yes, so what to do? Yeah, Karim.
I think you can find it.
Don't retrieve the scope except after you catch the lesion.
Yeah, exactly.
كريم ممكن تقرب المايك على بقك شوية عشان صوتك بعيد؟
You should retrieve the lesion once you resect it. Don't retrieve the scope except after you catch the lesion by snare or by roast net.
I hope we have here.
So so I want to ask Professor Inouye. Professor Inouye? Hello. How are you? Maybe I want to ask you a question about closure. Do you usually close after EMR? Because you know closure is a very rising topic. So do you usually close or you can leave it open?
So you're asking the colon?
Closure, yes.
The colon. So in the colon, bio is the responsibility in our hospital, and so our routine work is to close the defect. So of course, the risk of late onset bleeding after section or late onset perforation that I need anti-ESD. The potential risk we have. Then so we are keeping the safe side, and another point is if I will receive as a ESD in my colon, I would like to request the endoscopist to close the defect immediately after.
Yes, I totally agree. I totally agree because closure is about money. This is the problem, and this is really a financial problem. But I prefer if there is a chance you close, I go for closure. For me, from my person, who goes for closure after EMR? Who do closure after EMR? Who does not close?
Well, and of course, it should be decided the patient condition. So if the patient takes the anticoagulant or some poor risk situation, it's better to close.
دكتور شيماء بعد اذنك دكتور شيماء
دكتور ابو بكر دكتور اشرف اتفضل. Yes.
Dr. Shema, for your question, what we did in our clinical practice and daily practice, we close when the lesion is located in the right colon, and we close when patient have anticoagulation. If not, I'm speaking on behind Suad from Algeria. In North Africa, we close only in a right colon and in patient taking anticoagulation. If not, we don't close.
Oh yes.
To make the procedure cheaper. And it's also safe.
Yes, maybe we can find a solution with Boston.
Less than 3 centimeter defect.
After each. So we have Boston here with us.
This is our practice.
For each snare. Another question from Dr. Ashraf Abu Bakr.
You asked from the start if he used colonoscopy or upper endoscopy. When to select upper endoscopy in colonic lesion. I don't know when to select the upper.
This is a very good question from Dr. Ashraf Abu Bakr. Is asking when to use the colonoscopy and when to use the gastroscopy in resecting lesions in the colon. Can you please answer, Mayo, this question? It's a very important question.
Well, which type of tube you use in your practice for MRI? Gastroscope, slim colonoscope, long colonoscope, short colonoscope, which is preference?
I use normal colonoscope for every lesion in the colon. Also for rectum, because I like the channel position. The 5 focal position. It's more. I prefer more like a 5 focal position. And of course, for the rectum cases, I can choose for like the EMRC, for like EMRC for net. Yeah, we can just choose a gastroscope, of course, that I prefer. If it's deeper than sigmoid, I just prefer colonoscopy, not normal.
Only for rectal lesion.
So Karim and Mayo, thank you so much. I will be back to China because we finished the case very easily and very rapidly. This is for Nada's question about the add-on benefit. You can see he finished ESD, and we just did 3 cases while.
Thank you so much. So
Can we go back to
first-
China?
First, I will oversee. Thank you so much. Okay, let's see. Okay.
Professor Wang, are you with us? Professor Wang. لا هم طلبوا يرجع. مش قاعدين بيتصلوا. Professor Wang.
Yes, I'm here. Can you hear me? Yeah.
Yes, how are you? What a very
Yeah,
nice,
how are you?
very nice and very fast case. So,
Thank you.
everybody is asking about the device, and we want to know more about your robotic device. Can you just give a quick view about the device for the audience, because everyone here is looking for the device and what is the add-on benefit? So they want to see the details of the device and how you apply it. Just please, we are waiting for you.
Yes, okay. We just finished the surgery, and we use this device to help us to just 3 things. One is it can provide us continued patience and to lift the tissue to open the submucosal layer. And the second, it can help us to do our surgery more safely and more faster, and we can see the visual clearly, so we can coagulate it, and at last, and you can see this is a single arm, and it can be moved smoothly, mutual directions. And I hope, and I think there are some advantage. First is patience, and I think it's important, just like a third hand in the stomach. Second is stable, and my assistant, he operate these machines very carefully and very stable. So the traction is stable too. Third, I think it's very easy to operate this machine, and especially for beginner, and because it can lift the tissue and open the submucosal layer, so we do not too afraid of some complications, just like perforations or bleedings. We can easily to see the break grad point, and it can easy to close. And at last, we close the wound with this machine. We can grab one energy of the good and too close to another side, so the tension is weak, and we can close the bond by the clips just one by one easily. That's all. Thank you.
So, Dr. Wang, my question is about the endorobotic from Korea. It has some limitations, like it is used only in the gastric lesions. What do you think your device can go deep up to the cecum if we have a colonic lesion?
It can also be used in colon or duodenal, and there are different arms to apply to this machine.
Ah, yes. And what is the total outer diameter after you apply the endofasciar?
Maybe 1.2 centimeters, just like a cap you can wear on the scalp.
I mean the total diameter. I did not hear you. The total diameter from outside is
1.8 centimeter.
1.8. Okay, so thank you, Professor Wang, again for coming back to show the advantages of your device and how it was a very fast ESD for us. Now we can go for Al-Azhar to see another EUS case. هي الخناقة بتاعت البنكرياتيك تيل سيست دي طلعت يا دكتور حسين. Thank you so much. Thank you. الخناقة بتاعت الEUS دي طلعت الخناقة بتاعت الEUS دي طلعت ايه؟ يعني هي
everything is possible. It may be from the pancreatic tail, it may be from the left kidney, and then the very important notice that we should differentiate between both. But I am not, I will not be convinced except if I had the view of the cyst, the kidney, and the minute communication between both. Because sometimes here that it may be very difficult to differentiate.
نعمل CT وخلاص ماشي.
No, CT will not add too much after EOS.
Actually دكتور حسين I do agree طبعا مع حضرتك في ان هي في الديفرنشيشنز، لكن ممكن برضو في اذر اعتقد ديفرنشيشنز في حاله زي كده، ممكن ميزوثيليال سيست او حاجه تكون بره خالص الكدني والبنكرياس، انا شايفها بعيده فعلا.
زي ايه؟
ميزوثيليال سيست.
ميزوثيليال؟
بريتونيال. ميزوثيليال سيست.
ميزوثيليال؟
ميزوثيليال.
in what anatomical region؟
بتبقى دايما موجوده حضرتك اكسيدنتال ديسكفرد مع السي تي والام ار اي، وساعات بنشوفها في الاي اس، هي بتبقى ريليتد شويه بعيده طبعا، طالعه من الميزوثيليال وول، من الوولز بتاعت الاورجانز وات ايفر بقى، سمول انتستين اور اي حاجه ثانيه.
يو مين بريتونيال؟
دكتور حسين معلش احنا هنوقف دقيقه الدسكشن عشان احنا واقفين على الحاله لايف. another EOS case. دكتور برعي معانا مين؟ دكتور فيومي. Can we start presenting the case?
Yes, I am Dr. Sadek, and with me Dr. Mohammed Al Fayoumi.
أيوة دكتور.
It's our to share with you this EOS live transmission from Al Hussein Hospital, Al Azhar University. I will present this case. It's a female patient, 55 years old, presented with 4 months duration of abdominal pain and weight loss. Laboratory investigations revealed high CA19-9, about 3,000, and the imaging is done. CT with pancreatic protocol revealed pancreatic head mass about 7 by 10 centimeter, infiltrating the portal vein with portal vein thrombosis and encasing the superior-mesenteric vein, and there is also bilobar multiple hepatic focal lesion. So Dr. Mohammed Al Fayoumi will perform this EOS assessment for more assessment and for FNB to take FNB for tissue diagnosis.
Okay, now we have this case with a large pancreatic mass, but some people say that the large pancreatic mass is easily to be assessed. But unfortunately, the large pancreatic mass making a distortion to the anatomy of the abdomen, and at this start point during introducing the scope, we found here varices, paraesophageal and perigastric varices here. We can see it here. So when we see varices during introducing the scope at this level, we expect that we will find portal vein thrombosis. So when we introduce the scope, we usually use this technique to introduce the scope to the antrum, and we also make a suction and withdraw the scope to us, and we will find the left lobe of the liver. And when we find the left lobe of the liver, we follow one of the portal or bile duct branches, and we tracing this. Also at this level, we can see here a minimal ascites surrounding the liver, denoting the omental infiltration. Also here we introduce a scope. We can find the left lobe of the liver here. We can find some heterogeneous echogenicity here, like hepatic focal lesion. We can see here some hepatic focal lesion, isodense and hypodense. Hypoechoic here focal lesion and isoechoic focal lesion. Here we can see also another one at segment 2. So we tracing one of the portal branches, and we will follow it to the fish eye of the left portal vein. Here we follow the umbilical portion of the left portal vein here, and we will trace it till we find the portal confluence here at this area. But unfortunately, we can't tracing the portal vein anymore, so it may denote the portal vein thrombosis here due to large mass. So here we will transform it to the aortic approach.
Dr. Mohammed Fayoumi, thank you very much for sharing. The hepatic focal lesions looks like metastatic focal lesion, or what do you see?
It is multiple bilobar hepatic focal lesion, and it is likely a metastatic hepatic focal lesion. And the most of us said that the multiple hepatic focal lesion with cancer head of pancreas, about 99% it was a metastatic cancer head, and really it may be another cause. So here we will also find a hepatic focal lesion, para-aortic lymph node during introducing the scope. So here the celiac trunk and follow the structure of the aorta by celiac trunk and SMA. Here we can introduce it through it.
Dr. Fayoumi, what about the PET scan report?
No, I don't know the report.
It's not done. No. CT scan?
No,
CT
PET scan.
PET scan not done. Done? No.
يا دكتورة ندى، ما تقولي لنا اي حاجه، مش فاهمين اي حاجه من الابيض واسود ده.
You can see the celiac trunk and superior mesenteric artery here, like two fingers. This celiac trunk we were tracing it.
طب دكتور فيومي، معاك ندى الدمياطي. صباح الخير.
So we will follow the celiac trunk the sphenic artery, and we will see the mass here at this area and replacing the whole pancreatic parenchyma. We can see it here. This mass is heterogeneous echogenicity with hyperechoic and hypoechoic area, which is denoting multiple differentiation from poorly differentiating to well differentiated, associated with very mass fluid collection here. Also, so we will introduce, because the station is distorted, so we will introduce to bulb station or bush station, which is called by another schools.
دكتور محمد صباح الخير، حضرتك سامعني؟
Yes, I hear you.
صباح الخير، معاك ندى الدمياطي. جاست بنسأل البيشنت كام سنة يا دكتور محمد؟
55 years old.
55.
Yeah.
Okay, here I can see here the portal confluence and superior mesenteric vein, and the portal vein is totally occluded here. No portal vein at all.
Can you
Also
apply
here,
Doppler? Can you apply Doppler, Dr. Mohammed?
This is a superior mesenteric vein.
Can we have the Doppler
Here.
يا دكتور? Can you apply the Doppler?
Yeah.
Doppler, yes.
Yes.
Appears that the superior mesenteric is patent, but the portal vein I think it may compressed by the mass, maybe a thrombus inside.
I think it is infiltrated here, not only compressed, because there is no interface line here at all, and I can't tracing it anymore because
You are
of
now
this.
nicely visualizing us the arterial confluence of common hepatic and hepatic artery proper and gastroduodenal artery. You just saw it now. Just apply Doppler. Just apply Doppler. Yes, just apply Doppler. And slide anti-clockwise, slide anti-clockwise. You can see very nicely. Yes, apply Doppler now. Yes, this is the common hepatic artery. And bifurcation, it's two terminal branches, gastroduodenal going to the right and the hepatic artery proper going to the left to the liver highland. So I think the arterial sigil is also engulfed by the mass. What do you see?
يعني العيان ده inoperable يا دكتور حسين؟
Yes, I think it is now it is inoperable. It is compressing the portal vein, the main portal vein for a long distance, and also in contact with the arterial sigil, which makes it T4. And of course, if the hepatic focal lesions are pancreatic metastases, that makes it inoperable. The question here, do you agree with me that it is unresectable because it's involving the arterial sigil and the venous sigil, and also inoperable due to the presence of liver metastasis? The question here, would you sample the head mass only or plus the hepatic focal lesions?
Is this what I talked from the first point? That most of people recommend that. I think most of people recommend that the hepatic focal lesion is considered a metastasis from the original tumor. But actually, we here in our school we usually do biopsy or USF NB from the hepatic focal lesion here in our school. What is your opinion, Dr. Hassin? I think you make the both biopsy from the mass and from the hepatic focal lesion?
Yes, for my practice, if the mass is resectable or amenable for resection, then we should sample the hepatic focal lesion to be sure that it is metastatic. But here in this case, it is already unresectable. So no matter if the hepatic focal lesion is metastatic or not. But even in this case, I do both. Why? Because I should have many samples. If the pancreatic head aspirate is borderline or suspicious or something like that, the hepatic focal lesion may be metastatic, and this confirms the diagnosis. Just to increase the number of biopsies to have how to increase the chance of giving definite diagnosis at the end. Do you agree with me?
Which lesions, Dr. Hassin, do you prefer to start? The hepatic lesions?
A very important question.
Yeah.
It is
here
advisable to start with the hepatic, with the
second.
second.
Yeah.
Because if it is, if you start with the head
malignant and the other
head
lesions is
focal
benign.
lesion,
Yeah.
then you contaminate the needle with malignant cells from the pancreatic head.
Yeah.
Then if you go then to the liver, if the lesion is benign in the liver, then you will implant the malignant
cells.
focal lesion inside the liver. So you increased the grading into M1. But the opposite, if you have from the liver first, if it is malignant, then even it contaminates the first.
So you start from liver and the lymph nodes.
Yes.
And only flushing with the normal
Yes.
saline.
If you in the opposite, if you start with the head mass and then after that discover that there is a hepatic focal lesion, then you should flush the needle and flush the endoscope.
Yeah.
With saline.
Yeah.
But the reasonable or the logic practice is you start with the secondary site, not the primary site.
Yeah.
Yes, with normal saline, but you should flush the scope also, not only the needle. Or if you are in a rich country, you can use 2 needles, which is not the case.
Dr. Okasha, yesterday we had a discussion about the approach for locally advanced lesions, about using radio frequency in the locally advanced cases after neoadjuvant. Can you comment on this? Because we had a very nice discussion yesterday.
Yes. Now all over the world, all over the world, it's starting investigating the role of radio frequency ablation in borderline resectable and unresectable pancreatic head masses. In the borderline resectable, they are aiming or wishing that it can downstage the mass from borderline to resectable for possible radical surgery after that. But it should be combined with chemoradiation, not radiofrequency ablation, because you cannot deprive the patient from the routine chemotherapy. But for locally advanced tumors and metastatic tumors, it is just palliative, like chemotherapy. But many searches, and we start our project in Cairo University and did till now 4 cases. No, it should be 1,000, 2,000, thousands of cases to prove its effectiveness in combination with chemotherapy in borderline resectable for downstaging and in unresectable for palliation.
And now we have many publications regarding radiofrequency ablation may increase the efficacy of chemotherapy. And
Yes. The theory here is not just summation.
Enhance immunity.
It is augmentation.
Yeah.
Not only summation, not only the benefit of chemotherapy, plus the benefit of radiofrequency ablation.
And not the
It is
alternative.
augmentation because heat sublethal
Excuse me.
before 60 degrees induce hyperemia, increase sensitization of the malignant cells to the action of chemotherapy. So at the end, it is an augmented effect, not just summation.
Yeah.
ممكن دكتور فيومي دكتور حسين دكتور فيومي now we want to show us and I want to welcome Dr. Vinay Dir, one of the pioneers of EOS worldwide. He's here يا دكتور حسين.
Yeah.
Oh.
Hello, sir.
Yes, sir.
Yes.
Okay.
Hello, how are you?
Here- We hear you.
Nice to see you. Thank you.
دكتور فيومي سامعينك اتفضل.
Yes, here we use the USFNB by slow ball technique, and we yield this yielding of the biopsy here by USFNB, and we have a good core here from the first attempt.
Good
So
core,
you can use
Good core.
Yes, you use FNB 22G needle.
Yes.
Congratulations دكتور فيومي, but I have to shift back to Al Nas Hospital. Can we go to Al Nas Hospital? We are having our next case. Very nice cases. I want to congratulate all the faculty really and a huge number of cases in a single session. Can you please go for Al Nas Hospital? طيب دكتور
Yes,
كريم.
hello.
دكتور كريم صباح الخير. دكتور كريم.
Hello, Emma.
Yes. Ahmad, can you
Yes, hello,
present the
Dr.
case, please?
Yeah, we'll present now the third case for today. It's a 30-year-old female patient, the history of dysphagia for 2 years. The patient had Eckert score of 10. The EGD was done that revealed the esophagus was mildly dilated with retained fluid, and the cardia was spastic, as you can see in the images. The patient had barium swallow that showed dilated esophagus with smooth distal tapering end. High-resolution manometry was done, revealed pan-esophageal pressurization with IRP 25. Conclusion, it's a type 2 achalasia. We perform now a case of POEM by Dr. Karim and Dr.
يا دكتور كريم. دكتور كريم، حد سمعنا من مستشفى الناس يا جماعة؟ دكتور كريم، عايزة أسألك إيه انطباعك وأنت بتعمل بويم قدام الراجل اللي اخترع البويم؟ أنا يعني أتكلم بالعربي. So we're just asking Dr. Karim how he is going to perform poem in front of Professor Inouye. Are you nervous يا كريم؟ خالص أصلا مش معايا. يا كريم are you nervous؟ طب حد ينرفزه طيب. يا عمرو يا كرولوس، حد يرد علينا يا جماعة، مش سامعين حاجة. هو بيضحك بس. هو سمعنا بيضحك بس.
ارفع صوت القاعة لو سمحت. دكتور كريم discuss.
The luncheon at 44 centimeter. We will start at 34 centimeter. We will do 10 centimeter funnel.
We are We are using now the AURA system scope, AQ30 series. Okay, تمام, therapeutic scope. And we will use the hybrid knife T.
We did the mucosal bleb at 34 centimeter. يلا اديني السن.
Now we are doing the tunnel opening.
We are cutting the mucosa. In the tunnel, we should do proper trimming of the submucosa. We just open a small the scope.
يا كريم.
I think this opening is enough. We will try to introduce the scope in the submucosal space.
Now we are inside the beautiful view. The mucosa is above and the muscle is below.
Yes. We are using RB knife, T5. We are using Endocut Q modes, effect 3. And we are using coagulation mode, forced coagulation mode, 50 watts. We should be very close to the muscle to protect the mucosa.
Karim, so
Yes.
your approach is the posterior approach. Can you tell us why did you choose the posterior approach, not the anterior approach?
Usually, posterior approach is easier because with the scope and no important mediastinum, in contrary to the heart and the grave vessels. However, in the posterior approach, and there is more than anterior approach. So usually we do the posterior approach, but in the current cases we can do anterior approach.
So Professor Inoy, do you want to comment on choosing the anterior versus posterior approach? He's very nervous, by the way, because he's performing poem in front of you.
No. Yeah, nicely done, nicely done. So you are doing very well. So one of the point is you're now approaching the posterior wall and then create a submucosal tunnel. Some energy is closely approaching to a muscle layer. It's a very good sign. Sometimes if we make a tunnel like a ESD, a little bit distance from the muscle layer surface, so it's not good for POEM procedure. In the POEM procedure, the most important point is to preserve the submucosal tissue or mucosal layer intact. So he is doing very nice. Some coagulation onto the muscle layer surface. Now he's you are coagulating the vessel, breathing point, and the inner circular muscle layer is exposed. This is a very good sign. So, and like that, using the hybrid knife, he is doing very well. And then the question is anterior myotomy or posterior myotomy. So generally we can say we accept both. So in our unit, our initial 500 patients, we did it in an anterior myotomy. And then after that, 1,500 patients receives a posterior myotomy. And then after that, now we perform more than 4,000 patients the POEM in a hospital. And then, so we are coming back to anterior myotomy. So reason why of course, we can accept the posterior myotomy, but when we approach posteriorly, at the very end of the dissection, we have to dissect the 2 o'clock direction. So now operator dissected 6 o'clock directions very nicely. But very end of the procedure, the operator have to go to the 2 o'clock direction in order to preserve the collar swing muscle. So sometimes we have to dissect the lateral wall of the esophagus. So that is a potentially has a risk of becoming the blown out myotomy after the procedure. So in order to avoid that, so now we prefer the anterior myotomy. But most important is that we have to we never approach to the lateral wall. So because anterior wall is of course everybody knows that there is a hard to avoid the ballooning, and then the posterior wall there is a supine which can avoid the becoming the balloon. So point is the avoiding the lateral myotomy. So we can accept both. Anyway, so he's doing very well. Thank you.
So thank you. Karim, Professor Inouye بيثني عليك وبيقول you're doing very well. And by this, I want to congratulate all the faculty and all the operators because you really did a very, very nice demonstration. And I have to close the session now. And I will be moving with Professor Okasha to speak about the new advances in EUS, how it can improve our performance. So welcome, Dr. Okasha. And I would like to invite the chairpersons for this session, please. خليكي يا ندى. ندى خليكي. دكتور أحمد الزمزمي، دكتور أحمد مراد، دكتور أشرف أبو بكر، دكتور إياد غدور. هو فين إياد؟ أنت إيه اللي أخرك؟ دكتور إياد غدور، دكتور حسام غنيم، دكتور محمد صلاح شيحة، دكتور نرمين عابدين، الدكتور محمد نجيب ويفي will be maybe joining online. ومعانا دكتورة ندى الدمياطي قاعدة مكملة الإي يو إس. ممكن هنا تكنيكال يا دالاس.
I guess Dr. Hussein Okasha is a name that speaks for himself and does not need much of an introduction. It's enough to say that Dr. Hussein Okasha is not just the eminent professor and US eminent physician, but also a pioneer. He was the first to introduce many techniques, and we'll hear from him today about new techniques again. Thank you, Dr. Hussein.
الرحمن الرحيم. ممكن نبتدي المحاضرة enable content. Yes. Bismillahirrahmanirrahim. It is my pleasure and honor to share in this very prestigious Cairo Life endoscopy, and pleased and honored to welcome great professors throughout the globe. Today I will talk about one of the important topics in the field of endoscopic ultrasound, which is EUS in esophageal, mucosal, and submucosal lesions. Conventional high-resolution upper GI endoscopy identifies mucosal abnormalities, but fails to assess the deeply seated lesions. EUS has a great role in the workup of mucosal and submucosal lesions, as it can determine exact layer of origin, depth of invasion, relationship to surrounding structures, presence of regional lymphadenopathy, and malignant potential. This is a very famous anatomical wall layers from the esophagus to the rectum, 5 distinct layers: mucosal hyperechoic, muscularis mucosa hypoechoic, submucosa hyper, muscularis propria hypo, and adventitia or serosa. However, with high resolution echo endoscope, this is a picture by Olympus UM3, the new processor, we found that the fourth layer, which is the muscularis propria, is not only one layer, it is actually 3 layers: inner circular, connective tissue band, and outer longitudinal. This may be of importance because if you have lesion from the fourth layer, which is the muscularis propria, if it is from the circular, if it is from the circular muscle layer, then ESCD can be done. But if it is in the longitudinal muscle layer, then it will be better, more suitable for stare. Like in this video. ممكن نران الفيديو ده. شغل الفيديو. Yes, this is a pitfall or a trick in EUS assessment of submucosal lesion. This is the first hyperechoic and the second muscularis mucosa, and this is the submucosa. And here, this is the muscularis propria. It is actually 3 layers: the circular muscle, from which the tumor arises, connective tissue band, and then longitudinal muscle. This tumor is arising from the circular muscle, so we are protected by the longitudinal muscle layer. So here, ESCD with intermuscular dissection may be suitable. But if it is originating from the longitudinal muscle layer, then it is just protected by the adventitia or the serosa. So here, stare may be more suitable. Let us discuss the role of EUS in mucosal lesion first. It has a great role in early pancreatic carcinoma, assessment before EMR or SCD, Barrett's associated dysplasia, EUS FNA, FNB, in biopsy negative diffuse gastroesophageal wall disease. Let us start one by one. This is the staging of esophageal carcinoma. If it is involves the mucosa only, then it is carcinoma in situ. If it involves the muscularis mucosa, then it is T1A. If it involves the submucosa, then it is T1B, and this is very important. If the submucosa is involved, then it is T1B, will be more suitable for surgery. If it is involves the muscle layer, then it is T2. Now for surgery. If it is involves the outer layer, involves the whole layers of the esophagus, then it is T3 now for neoadjuvant chemoradiation. And if it is involves the outer extra esophageal structures like the pleura, then it is 4-1A. If it involves the aorta, it is 4-1B. So here I should emphasize the importance of classifying T1 into 2 subclasses. T1A involving the mucosa only, not the submucosa. It involves the first or second layer. These tumors are usually not accompanied by lymphatic or nodal involvement, could be managed by local endoscopic resection, whether EMR or ESCT. But if it is T1B involving the submucosa, unfortunately, lymphatic or nodal metastasis will occur in up to 40% of cases. So it is better managed by surgery and chemotherapy. This is a nice example of T1A. This is the echoendoscope inside the lumen, and this is the mucosal break invaded by the tumor, and this is the muscularis mucosa in which the cancer is invading it. But here the submucosa, this white line, and the muscularis propria are free. So this is very suitable to ESCT. This is, of course, T2 tumor. Can we run the video? Okay. A major meta-analysis evaluated 19 studies, including over 1,000 patients with superficial esophageal cancer. They found that the sensitivity in accurately diagnosing T1A was 85%, and for T1B is 86%, a good percentage. And the specificity were 87% and 86%, respectively. So these findings established EUS as an accurate modality for local staging. Before endoscopic mucosal resection or endoscopic submucosal dissection, EUS is valuable for evaluating the target area. It accurately assesses how deep the lesion extends into the esophageal wall. And of course, muscularis propria involvement rules out endoscopic resection suitability, and it also very importantly evaluates the adjacent lymph nodes for signs of lymph node metastasis. However, European Society of Gastroenterology does not recommend routine performance of endoscopic ultrasonography, CT or MRI or positron emission tomography prior to endoscopic resection. This is a strong recommendation and moderate quality evidence. They also recommend that evaluation of superficial gastrointestinal lesion should be made by experienced endoscopists using high definition white line and chromoendoscopy. But the European Society suggests that when suspicious features of deep submucosal invasion are present, complete staging should be considered in order to exclude stage T2, T3, and lymph node metastasis, but this is weak recommendation and low quality evidence. So, finally, to conclude, EUS is recommended and particularly useful when suspicious features are present. Number one, large lesions more than 2 centimeters, nodular Barrett esophagus or elevated border, suspected submucosal invasion in case of the presence of deep ulcers or markedly elevated borders. For Barrett's esophagus, EUS has an adjunct role in Barrett's esophagus with high-grade dysplasia or intramucosal carcinoma. For detection of occult submucosal invasion, can identify suspicious lymph nodes and exclude advanced disease. But an important note that high-resolution endoscopy with EMR may outperform EUS in very superficial lesions. Limitations of EUS include overstaging due to inflammation, especially in Barrett's esophagus, and distinguishing fibrosis from deep invasion. So, the European Society here is to do high resolution in Barrett's esophagus, is to do high resolution endoscopy by expert endoscopists with virtual or acetic acid chromoendoscopies. EUS is indicated only if there is suspicious of deep invasion like deep ulceration or markedly elevated borders. And another value of endoscopic ultrasound in a special situation in patients with diffuse esophageal gastric rectal wall thickening after failure of standard biopsy techniques. The lesion is highly suspicious of being malignant, but repeated upper endoscopic biopsies were negative. So here, EUS has a great role. It can nicely taking deep biopsy. This is the gastroesophageal wall, markedly thickened. The very nicely 5 wall layers are no further demarcated, amalgamated, and the thickening is not 4 centimeters, it is about 1 point something, centimeter. So, and repeated endoscopic biopsies were negative. And here, this is nicely seen, very safe, very effective to do FNB for possible immune staining in cases of lymphoma. But in these most of the cases will be turned to be adenocarcinoma, sometimes lymphoma, sometimes menetrier, sometimes eosinophilic gastroenteritis. In our study in Cairo University, we did 109 patients with endoscopic biopsy negative GI wall disease. Our sensitivity was 87%, very nice. You can diagnose 87% in patients which were not diagnosed by upper endoscopic biopsy, and specificity, of course, 100%. Now to the other part of the lecture, which is the role of EOS in submucosal lesions. Submucosal lesions are located deeper to the mucosa. This term is used by endoscopists to describe any bulge covered with normal mucosa. It cannot be definitely determined by upper endoscopy or imaging examination, and endoscopic forceps biopsies are usually inconclusive because they are taking biopsy from the superficial mucosa. Mostly asymptomatic, minority presents by symptoms like vomiting, anemia, or dysphagia, and so on. Esophageal submucosal tumors are many. Benign lesions or malignant lesions. Benign lesions, the commonest in the esophagus is leiomyoma, but there may be granular cell tumor, apricosoft tumor, lipoma, varices, hemangioma, and duplication cysts, and the malignant submucosal tumors are leiomyosarcoma, which is very rare. GIST is extremely rare in the esophagus, less than 5%. It is much more common in the stomach and the small bowel, and of course, metastases are very rare. EOS has a great role in diagnosis of submucosal tumors. Its sensitivity is near 100%. Its accuracy is in predicting the pathologic diagnosis ranging from 45 to 82%, a good percentage. With guided FNB, now FNB, the accuracy increases to 98%. We are always saying, and tissue is the issue. There are many items to examine by EOS during EOS examination, but I think the most important is the layer of origin and the echogenicity. This is the tumor arising from the esophagus, submucosal tumor. The commonest is leiomyoma arising from the second layer and also arising from the fourth layer. Granule cell tumor, apricosoft tumor is less common, arising from the second layer. Lipoma from the third layer, and it is hyperechoic, classic lipoma. Fibroma and cyst is anechoic avascular lesion, which mostly be duplication cyst. And of course, GIST is very rare in the esophagus and located in the fourth layer, and also schwannoma. Let us talk about the most common tumor, which is leiomyoma. It originates from the smooth muscle layers, typically the muscularis propria. Tumors smaller than 5 centimeters are usually asymptomatic and generally require no treatment and can be safely monitored. Because malignant transformation is extremely rare. Larger tumor may cause dysphagia, retrosternal pain, and regurgitation. And here the gold standard is surgical enucleation, but here local endoscopic resection, whether STER or ACD, can be tried. This is an example is a very large leiomyoma in the esophagus. It's more than 10 centimeter, even compressing the right pulmonary and the left atrium, the right pulmonary and the left atrium. And here it is well seen that it is originating from the muscularis propria layer, the circular muscle of the muscularis propria layer. I should see it from its upper aspect or lower aspect. Yes, very nicely seen, as I told you before. Mucosa, muscularis mucosa, the circular muscle layer of the muscularis propria, connective tissue band, and the longitudinal muscle layer. But I think it is too large for local endoscopic treatment, and this patient was referred to surgery with a very good outcome. Now, GIST is very rare in the esophagus, much more common in the stomach. It is hyper-enhancement pattern, vascular tumor with cystic areas of breakdown, leiomyomas in contrast to leiomyoma, which are hypo-enhancing, hypovascular, and hypoechoic. The malignant risk stigmata are tumors larger than 5 centimeters, heterogeneous perfusion pattern, irregular extraluminal margin. Yes, use all your capabilities, use all your facilities. You can use contrast-enhanced ultrasonography. by injection of contrast, which is bubble in the form of bubbles. This is a hypervascular tumor, of course. GIST is hypervascular in contrast to leiomyoma, which is hypovascular. So contrast enhanced sonography is very valuable. We can use elastography. Elastography is determination of the hardness of the tissue. This is strain elastography. It measures the degree of deformability in relation to external compression by external vessels. This is the blue color, means it is hard, so it goes with GIST tumor. Now the newly introduced capability of shear wave elastography, very nice advanced technique. The strain elastography is subjective, but here it is quantitative. It measures by kilopascal, which is very accurate in determination of the hardness or softness of the tumors. Now, coming to my conclusions, EUS is an accurate modality for local staging. However, European Society does not recommend routine use prior to endoscopic resection. It recommends EUS only when suspicious features are present, like lesions larger than 2 centimeters, nodular Barrett's lesion, suspected submucosal invasion, especially with deep ulcers or markedly elevated borders. EUS has a great role in detection of submucosal tumors. Its sensitivity is near 100%. Its accuracy in predicting the pathologic diagnosis ranging from 45 to 82. But with EUS-guided FNB, the accuracy increases to 80 to 98%. We are always saying tissue is the issue. So my conclusion, try to provide the best options in your device, high image resolution, contrast enhanced endoscopic ultrasound, strain elastography, and shear wave elastography. And thanks for your attention.
Thank you, Dr. Hussein. Thank you so much for this very nice informative lecture and the new technology in endoscopic ultrasound. أنا عايزة أدعو بقى كل الناس يا جماعة عشان إحنا هنبتدي الأوبننج سيرموني وممكن كل الناس بقى تدخل قاعدة بره بترغي والناس اللي بتاكل والحاجات دي كلها. طبعا يعني we are so happy and delighted to welcome you all in this very first event of Cairo Life Endoscopy. We are focusing, as you can see, mainly on the live cases. And I really want to congratulate everyone for the efforts. And let me invite the chairpersons for the opening ceremony, Dr. Professor Hussein Okasha, Professor El-Fadda, Professor Inouye. Can you please join? Professor Hussam Ghunaim, Professor Ibrahim Mustafa, Professor Sharif Megawer, Professor Tariq Youssef, and Professor Vinay Dir. Can you please join the stage, please? ممكن يا جماعة كل الناس تيجي عشان الأوبننج سيرموني بعد إذنكم؟ ممكن نقعد يا جماعة، ممكن نقعد. ممكن فوجي واولمبس يقعدوا، يعني انتوا صحاب عادي، يعني عادي مفيش مشكلة. طيب ممكن نقعد يا جماعة، في كراسي هنا اهي، في كراسي على الشمال فاضية، بدل ما انتوا واقفين كده. الشباب في اماكن على الشمال هنا يا جماعة.
عندي حلاق بقى، كان عندي كده حالة
واحنا سعداء جدا بتشريف استاذنا استاذ دكتور اسامه عبد الحي نقيب الاطباء. شكرا جزيلا على وجود حضرتك وعلى المجهود والوقت المبذول.
ممكن يحصل سكند انفكشن وهي
اتفضل حضرتك نورنا.
الجراحه بقى بيطلعوها.
طيب طيب هي يا جماعه دقايق ان شاء الله، مش دقايق، ثواني وهنبتدي الاوبننج سيرموني. سعداء جدا بكل الناس اللي موجودة، بكل المجهود المبذول، بكل الشركات اللي يعني مرحبيننا. طيب ممكن بقى ممكن أدعي دكتور محمد الشربيني رئيس المؤتمر، my partner, my lifelong partner، عشان هيقول كلمة بمناسبة الأوبننج سيرموني.
بسم الله الرحمن الرحيم. السيدات والسادة الأساتذة والزملاء الأعزاء، ضيوفنا الكرام من مصر ومختلف دول العالم، السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بكم جميعا. يسعدني ويشرفني أن أرحب بكم جميعا في القاهرة من مصر، أرض الحضارات ومهد المعرفة والعلوم والفنون عبر التاريخ. فمن هذه الأرض التي هي دائما منارة للعلم ومقصدا للعلماء، نلتقي اليوم لنكتب معا فصلا جديدا من التعاون العلمي والابتكار في مجال مناظير الجهاز الهضمي العلاجية المتقدمة. إنه لشرف كبير أن تستضيف القاهرة هذا الجمع الكبير والمتميز من نخبة من خبراء العالم في مناظير الجهاز الهضمي، ليجتمعوا في مكان واحد من أجل هدف واحد، وهو تبادل العلم والمعرفة والخبرة وتطوير ممارسات المناظير العلاجية بما يعود بالنفع على مرضانا. أرحب بكم جميعا في افتتاح كايرو لايف اندوسكوبي 2026. وأرحب بضيوفنا الدوليين وبالسادة الخبراء والمتحدثين وبجميع الزملاء الذين حضروا من مختلف الجامعات والمستشفيات والمراكز داخل مصر وخارجها. وجودكم بيننا شرف كبير، وتشريفكم لنا يمنح هذا المؤتمر قيمته الحقيقية. والآن قبل أن نبدأ فعاليات مؤتمرنا، أدعو حضراتكم جميعا للتفضل بالوقوف احتراما وتقديرا للسلام الوطني لجمهورية مصر العربية. Please all stand for the Egyptian national anthem. شكرا لكم جميعا. Thank you. Thank you. As we are honored to welcome participants and experts from around the world, I'll continue English so that everyone can fully engage in today's opening session. Hello everyone, it's my great pleasure to welcome you all. Your presence here reflects our shared commitment to innovation, collaboration, and excellence in patient care. We are truly honored to host such an outstanding international faculty and participants from around the world. Today, we come together for one of the most anticipated educational activities of 3SCE, Third Space Endoscopy and Endoscopic Foundation. It's Cairo Live Endoscopy. 3 years ago, 3SCE Foundation was established as a global educational initiative foundation that brings together more than 70 international expert endoscopists with a shared mission of advancing gastrointestinal endoscopy through education, collaboration, and innovation. Since its establishment, the foundation has organized numerous educational activities, including multiple waves of KEBIC course. KEBIC, it's Qasr Al-Aini, ESD, and third space basic course. Also, GATE, Global GATE for Advanced Therapeutic Endoscopy, which was held last year in Saudi Arabia in collaboration with our friend and brother, Professor Abdurrahman Al-Fadda. And also, we have many other successful scientific events. Cairo Live Endoscopy is built on the belief that education is most powerful when knowledge is shared openly and experience is exchanged across borders. More importantly, this meeting serves as a platform to strengthen international collaboration, bringing together physicians from all over the world to exchange expertise, discuss challenges, and learn from one another. Cairo Live Endoscopy serves a heavy but healthy meal, so please enjoy it. Cairo Live Endoscopy 2026 is accredited international from European Accreditation Council, from continuous medical indication by 16 European CME credits. Over the next 2 days, you will experience an outstanding scientific program featured in 6 live endoscopy sessions with live case transmission from 15 leading endoscopy centers across Egypt and international centers around the world. The conference brings together more than 50 experts from all over the globe, offering a unique opportunity to exchange knowledge, share expertise, and discuss the latest advances in therapeutic gastrointestinal endoscopy. In addition to the live demonstrations, the scientific program includes 8 specialized master classes dedicated to advanced therapeutic endoscopy procedure, providing participants with in-depth hands-on educational insights. We are also proud to offer a dedicated training course for endoscopy nurses, reinforcing our commitment to comprehensive education and excellence in endoscopy practice. Before we begin our conference, I'd like also to extend a warm welcome to our distinguished national and international experts, faculty members, colleagues, and attendees. We are truly honored by your presence and grateful for your support of this meeting. Just a novel advanced therapeutic endoscopy continue to open new pathway within human body. May this conference open new pathway for human knowledge. Our sincere thanks go to conference board, the scientific and organizing committees, our sponsor partners for their valued support, IRIS for the excellent organization of this event. On behalf of the organizing committee, I warmly welcome you all and wish you an inspiring, productive, and memorable conference. Welcome to Cairo Live Endoscopy 2026, and thank you for being part of this exceptional journey. We wish you all an inspiring, productive, and successful conference. Now, we will watch a short video about our conference.
Welcome to Cairo Live Endoscopy 2026, where innovation meets experience and the future of gastrointestinal endoscopy comes to life. This year's conference connects 15 live transmission centers, leading hospitals and distinguished international faculty, delivering real-time education across borders. Cairo Live proudly connects with internationally recognized centers of excellence from India, China, Tunisia, the United States, Greece, and the Kurdistan region of Iraq, demonstrating the power of global collaboration. Our international journey begins in India with Artham Hospital, and from Beijing, China, we welcome Beijing Friendship Hospital. From Susa, Tunisia, Clinique Les Oliviers joins us, followed by Henry Ford Hospital, in Detroit, USA. From Athens, Greece, we are honored to connect with Mediterranean Hospital. And from Suleymaniye, Kurdistan region of Iraq, we welcome the University of Suleimani. And across Egypt, our leading medical institutions proudly contribute live procedures and scientific expertise, reflecting the country's commitment to advancing endoscopic excellence. From Al Hussein University Hospital, Al Nas Hospital, Alexandria University Hospital, As-Salam iScope Center, Asyut University Hospital, Cairo University Hospitals, Egyptian Liver Hospital, Mansoura University Hospital, and Theodore Bilhard's Research Institute Hospital, TBRI, together showcasing the strength of Egypt's medical expertise and its dedication to innovation, education, and excellence in gastrointestinal endoscopy. Today, Cairo Live proudly brings together many of the world's most distinguished pioneers and experts in gastrointestinal endoscopy. It is our great honor to welcome our guest of honor, Professor Haruhiro Inoue, the pioneer of peroral endoscopic myotomy, whose groundbreaking work has transformed therapeutic endoscopy worldwide. Our distinguished faculty represents some of the world's most respected institutions, bringing decades of experience and innovation to Cairo Live. Today, we are proud to welcome these exceptional experts from around the world, united by a shared commitment to advancing the science and practice of endoscopy. We extend our sincere appreciation to our partners for their unwavering support and commitment to advancing medical education.
And now, I'd like to invite the members of the conference board to the stage for special honoring. Please come. Dr. Al-Fadda, Dr. Hussein Aukasha, Dr. Shaimaa El-Foli, Dr. Muhammad Nabil Al-Qadi, Dr. Kareem Assam at Al Nas Hospital, also Hani Haggag and Krollos. Dr. Abir Awad is here. So please come. First of all, I'd like to thank Professor Dr. Osama Abdel Hayy, President of the Egyptian Medical Syndicate. I'd like to thank him for his continuous support of medical education, scientific advancement, and professional excellence. Please, Dr. Osama.
بسم الله الرحمن الرحيم. صباح الخير على حضراتكم جميعا. First of all, I would like to thank Dr. Mohammed Sherbini and all the organizing committee for their invitation. And it's really a great pleasure to be with all of you, and especially the distinguished and esteemed professor from abroad. And let me say a few words in Arabic from my heart for you. الحقيقة أنا سعيد جدا بدعوة الدكتور الشربيني إن أنا أشارك حضراتكم النهاردة، لأنه أنا عندي 3 نقط صغيرين كده وبسرعة قوي عايزين نتفق عليهم. نمرة 1، أحسن حاجة في إيدينا كأطباء في مصر هو الإديوكيشن، لأن ده مننا فينا، ده مش محتاج كلام مع المحافظين أو مع الوزراء زي ما شفتوا امبارح أو مع الإدارة التنفيذية أو كده، ده حاجة مننا فينا ونقدر احنا نوفر ده لزملائنا ونتبادل الخبرات مع بعض ونعلم الشباب. نمرة 2، انه كل الكورسات دلوقتي should be accredited او تاخد credit hours علشان الشباب اللي هيبقوا مطالبين بالري لايسنس كل 5 سنين. فكل الدفعات اللي بعد 2021 هيبقوا مطالبين بالري لايسنس. الري لايسنس بيستوجب انه يجمعوا كريدت اورز او بوينتس. فاحنا بنشجع جدا ان اي كورس او مؤتمر زي ده ياخد كريدت اورز من المجلس الصحي المصري او انترناشونال كريدت اورز. الحاجه الثالثه، احنا عندنا عملنا مركز تعليم طبي جديد في النقابه في القصر العيني في المبنى الجديد اللي ورا النقابه، وخلينا الفروع بتاعتنا في كل المحافظات يبداوا يعتمدوا المراكز التعليم الطبي اللي عندهم. احنا المركز بقى معتمد المجلس الصحي المصري، في اي كورس بيتاخد فيه هيتاخد عليه كريدت اورز للشباب. وفي يعني كورسات مناظير في كل الكورسات تقريبا دلوقتي الحمد لله. الحاجة الأخيرة بقى اللي أنا عايزها من الجمعية إنه نبدأ نهتم. دايما الأساتذة كلهم مهتمين بشغلهم وبالعلم وفي المحاضرات بتاعتهم والقاعات. لازم وسيبنا السوشيال ميديا. السوشيال ميديا ظهرت وبعدين سيبناها لناس تبرطع في السوشيال ميديا شمال ويمين، زي اللي بيعمل نفسه خبير تغذية قبل كده يعني وانتقل إلى رحمة الله، أو اللي اسمه جود عواد اللي بيقول يعني ما حدش يغسل كلى وهيعالجه هو الظواهر دي كلها. فإحنا أنا عايز من الجمعية تعمل كوميونيتي بيج زي الجمعيات في اوروبا وفي امريكا. معظم الجمعيات العلميه بتعمل صفحه للجمهور، مش صفحه للاطباء الزملاء، صفحه للجمهور والاكسبرتس هم اللي يكتبوا فيها ويوجهوا كلامهم للجمهور باسلوب مبسط، عشان ما يطلعش واحد يقول انا اول واحد يعمل في مصر كذا، او انا بعالج اخر حادثه كان من اسبوع، اللي هو الطبيب اللي قال انه بيعالج السكر بيزرع خلايا البنكرياس بالمنظار، بيزرع خلايا ستيم سيلز بالمنظار في البنكرياس. طبعا احنا خدنا موقف قوي جدا ساعتها واستدعيناه لاداب المهنه وبلغنا الوزاره، والوزاره راحت قفلت له المركز. بس طبعا كل دي ردود فعل. احنا عايزين، انا رايي ان لو نجحنا في ان نعمل كوميونتي بيجز قويه على السوشيال ميديا، أنا مؤمن بالمبدأ العام اللي هو العملة الجيدة تطرد العملة الرخيصة من السوق. فالسوشيال ميديا لازم دكاترة محترمين يتكلموا علشان يغطوا على الناس اللي الكواك والكلام. يعني أنا مش عايز أقول بقى قدام الضيوف الكلام اللي بيحصل خارج يعني السياق تماما وبدون أي سند علمي. أنا بتمنى للمؤتمر النجاح ومش عايز أطول أكتر من كده، وكل سنة وحضراتكم طيبين، واحنا ملتزمين في النقابه بكل القضايا اللي تهم الاطباء. الف شكر والف مبروك للمؤتمر. شكرا جزيلا.
Thank you, Dr. Osama, for your nice talk. Thank you. Definitely the first one, Professor Dr. Mazen Naga. Dr. Mazen Naga is our godfather and founder of Endoscopy Unit, a brush unit, internal medicine hospital, Faculty of Medicine, Cairo University, in recognition of his lifelong mentorship, unwavering support for generation of endoscopists, and for his invaluable contribution to the advancement of gastrointestinal in Egypt. The award will be received on his behalf, Dr. Hussam Ghunaim. دكتور مازن بيعتذر، هو he will join بكره ان شاء الله، فبيعتذر ليكم جميعا ان هو ما قدرش يجوين في الوقت ده. Also, I'd like to thank Mr. Ayman Abbas, Chairman of Annas Hospital, in recognition of his continuous support for the advancement of endoscopy services and education at Annas Hospital. Dr. Abir Awad will receive the award on behalf of Dr. Ayman Abbas. And now, with the master, Professor Dr. Inouye. Dr. Inouye is the chairman of Digestive Disease Center, Tokyo, Japan, and president of Japanese Gastrointestinal Endoscopy Society, in recognition of his distinguished presence at Cairo Live Endoscopy and for honoring us with his first visit to Egypt.
So, congratulations on the great success of the Cairo Live Endoscopy 2026. And I really appreciate all the faculty members and the organized committee and all the attendees in this room. So, such a great success. So, and also I received some token. It's a great honor for me. Thank you very much.
I really want to thank everyone here because we would not be here except for your efforts. When it intermingles together, it really brings something special. So it's a real honor and pleasure and a very, very close to my heart invitation that was finally been accepted by Professor Inouye for the first time in Egypt, in Africa, in the Middle East. He finally could make it and be here in Egypt with us, the godfather of the third space endoscopy all over the world. I believe that he is one of the reasons why the practice has changed in endoscopy a lot in the last 10 years. So please, all of you, welcome Professor Inouye and enjoy his state-of-the-art lecture, please.
Thank you again, the Sharmi and the Chaima and all the faculty members. I really appreciate this invitation. It's my great honor. First time to Egypt. It's amazing. So can I please show the slide to the monitor, please? Okay, thank you very much. I'd like briefly talk about the how the third space endoscopy has been established. And then now moving forward, the other advanced flexible endoscopic surgery. Actually, POM opens the door of APES, what we call. So my name is Haru Inoue. So please call me Haru. So Inoue is a little bit difficult to pronounce it for you. So easy way to remember my name is I know you. So Inoue is a very difficult to pronounce it for you. So I know you is better. Anyway, so first step is treatment of the achalasia. 100 years ago, Dr. Ernst Heller from Germany, so he reported the Heller myotomy. Of course, at the time, the open abdominal surgery. And then a guy, he's an Indian American, the J. Pasuricha, so he reported the possibility of endoscopic myotomy of the esophagus using a pig model. Then our team successfully performed the POM procedure. The world first POM case was the September 8th, 2008. So please note the date of the procedure. it was 18 years ago. That was a Lydia first case. So anterior myotomy after injection and place the small mucosal incision, and then getting a submucosal space and create a submucosal tunnel until the proximal stomach. And then now we perform the circular selective myotomy. And then after completion of the procedure, just close the mucosal entry using clips. That's all. So, okay. So this the world first home patient. We follow this patient 80 years. And then 80 years after procedure, his satisfaction is 100%, and he gained weight 20 kilograms, and no GERD. So this is an actual video clip at 80 years after porn. So he has nicely opened up the lower esophageal sphincter and the no GERD. Then we report our initial 500 data to the Journal of American College of Surgeons. Okay. And then so far we performed more than 4,000 POM procedure in our hospital. I have that here that also from the 3,000. So it's an amazing number. We never imagined why so many achalasia patients we have. It's a big surprise because before POM, so number of surgery is not so high, even in a esophageal surgical center. So it's a big surprise for us. Anyway, so very important milestone papers we have. So one of the very important paper is the RCT of the POM versus laparoscopic helamyotomy. The red column demonstrate the POM procedure. So success rate, satisfaction rate is higher in a little bit higher than conventional surgery, almost equal. And then another important RCT was the POM versus pneumatic dilation. So success rate is far beyond than the pneumatic dilation. So POM is better than PD. So we follow the patient more than 10 years, and then almost all patients continue the good eating habit after procedure. So one of the remaining concerns is POM induced the reflux disease or not. So the answer is no, not a major issue. So one of the actually the additional surgical complication after POM is very low, 0.06%. Two cases among 3,000. So very unusual. So we are steadily following the concept of the Portuguese doctor. This is a report by the Portuguese doctor, the double scope control of the gastric myotomy rings. So we insert the double scope, and then we can identify the distal end of the submucosal tunnel using the lightning from the submucosal tunnel. Okay. Then, so we also induce the RCT, and then in order to reduce the GERD after POM, the 2 centimeter gastric side myotomy is the optimal. Okay, I will skip this part. Okay, so like this way. And the reason why we perform the double scope method is, for example, in the case of Jackham esophagus, we perform the LES preserving form procedure. So in order to control the length of myotomy, the double scope check is mandatory. Okay. Okay, this is a lateral flex view. The control, try to preserve it. Anyway, so POM opens the door of the other submucosal endoscopic procedure, surface endoscopy. So this terminology was reported reported by the Indian guys. But anyway, so now it's split from POM to STAR procedure, G-POM, and Thinker POM, and diverticulum POM, and some other. So I'd like to demonstrate the case of a par-oral endoscopic fundoplication. After completion of the myotomy, so this endoscope is passing through the mouth, the submucosal tunnel of the esophagus, and then distal end of the tip of the endoscope getting the abdominal cavity. And then, so now you can see the back side of the left liver lobe. And then now we are trying to make a suture onto the surface, anterior wall of the stomach, and then make application. It's a dual fundoplication, the anterior partial of fundoplication. We can do, if we want, we can do it endoscopically. Okay, so we use a V-lock or suture thread, so not necessary to tie over. Anyway, we place several stitches like this way. This is a submucosal tunnel and the distal end of the esophagus. We we place the second suture. Okay. Anyway, this is the end of the procedure, and then you can recognize the anterior partial fundoplication was completed. Just one scope from the mouth. That's all. So another application is a G-POM. This is a treatment for the gastroparesis. So we did the first case in Johns Hopkins University Hospital in Baltimore. Myself and the Professor Moen Kashav and Professor Stavropoulos, we are together, and then we did the world first case of the G-POM. After that, so this procedure becomes a standard procedure for the endoscopic treatment for gastroparesis. Okay. So another application of the POM procedure, extension of the POM procedure, is the POET, what we call, and the STAR procedure. Okay, so I would like to demonstrate a very interesting case. This is an aberrant pancreas in the distal esophagus. I hope you can see the opening of the pancreatic duct. In the pancreatic juice is coming out in the esophagus. So this is the first ERCP performed from esophagus. So anyway, you can see a pancreatic duct. Then we decided to do the resection of the aberrant pancreas using the tunneling technique. Okay, this is the actual procedure. Mucosal incision, and then get in a submucosal space, and then export the aberrant pancreas in a submucosal tunnel. And then actually the tumor passing through the muscle layer, then we resect everything out using the flexible endoscope. Okay. And then after that, just close the mucosa entry using clips. The same to POM procedure, aberrant pancreas. So of course, good application of the STAR procedure is a less than 3 centimeter submucosal tumor. If the tumor size is too large like this, so it's better to do the trachoscopic resection. And then another extension of the POM procedure is a DPOM. So this is a case the patient had the epiphrenic diverticulum. And the strategy is like this. So after placing the LES myotomy, now we are approaching the submucosal tunnel and then through the muscle defect, and then try to dissect the diverticulum from mediastinum. Behind you can see lung. Okay. And then after complete inversion of the diverticulum to the esophageal lumen, now we are trying to close the muscle defect using the suturing needle. This is everything done in a submucosal tunnel, inside the tunnel. Okay, then inverted diverticulum was resected and then closed the defect using several clips and loop 9, what we call. Anyway, so POM had the several extension, and then so now another further advancement of the therapeutic endoscopy is a full thickness resection in the for the GIST tumor. So this is a GIST tumor in the esophagus. So you can see submucosal tumor there, and the first place the marking, and then we are approaching directly to the muscle layer. Now the mucosa cut, and then you can see a submucosal tissue. And the vessel should be coagulated. Okay. Anyway, so directly after that, we straightly approach to our circular muscle cut, step by step. And then after circular muscle cut, we also dissect the longitudinal muscle cut. So finally, whole the tumor, including esophageal wall, was mobilized. So this is a connective tissue in between epicardium, pericardium. So we dissect the whole this area out, just the endoscopy alone. And then this tumor is completely out through the esophagus. Okay. So after removal of the this tumor, full thickness, you can see the mediastinum and the pericardium at the bottom of the observation. Then the first step is to remove the resected tumor, and then we have to close the this defect tightly. So using a loop 9 technique, we close this defect. Okay. So okay, I will skip this part. And then finally, I would like to mention about the how to perform the full thickness resection in the stomach. The point is the esophagus, when we perform the full thickness resection, there is no collapsion of the lumen. But in the stomach, we perform the full thickness incision, place the full thickness incision, the gas leakage happen. So like this. So in the ESD, no gas leakage during procedure, but full thickness resection causes a gas leakage, and we lose the endoscopic vision. So in order to save it, we perform the tactics. Tactics is a abbreviation of the traction-assisted closure with tandem incision and cutting strategy. So that means the this is the application of the tactics. So white allo demonstrate. This is the last case. White line allo demonstrate the submucosal tumor. So it's very slight elevation toward the esophagus, but ultrasonography identifies the GIST tumor outside the stomach. So in this case, we perform the endoscopic resection. So first, place the mucosa and the gastric wall incision, and then we pull the gastric wall with a strong tension. And then, so this is a exophytic outgrowth of the GIST outside the stomach. And then we pull the tumor directly with a snare, putting it inside the stomach. And then after that, we close the defect using the loop closing technique. Okay. The point of the procedure is we are taking it out using a loss net. But anyway, so this case was exophytic tumor, but we can successfully resect it endoscopically. So like this way, short space endoscopy started 18 years ago as a form, and then now we extend its application gradually, and then now finally try to do the endoscopic full thickness resection, pure endoscopically. So thank you very much for your kind attention.
Thank you very much, Professor Noy, for the brilliant presentation. Thank you very much. Please have a seat. It's my pleasure now and honor to introduce Professor Shaimal Kholi. Professor Shaimal Kholi is a professor of gastroenterology at Cairo University and advanced endoscopy. She will present the Fuji symposium. I'd like to invite the chairpersons. Yeah. Professor Muhammad Salahuddin, Professor Osama Abada, Professor Osama Abdelal,
Professor عمرو المستكاوي, Professor Ashraf Zaki, and Professor Muhammad Abu Zaid. Professor Shaimal Kholi will talk about enhancing endoscopic dissection with novel technologies.
ممكن نبص يا درس بعد إذنك. طيب احنا هنقول محاضرة كده إن شاء الله عن ال new technologies about enhancing endoscopic dissection، وبعدين دكتور برعي هناخد بريك صغير، وبعد كده هنبتدي بقى البث من مستشفى الناس مع بروفيسور إينوي وبروفيسور فيناي دير. هنقدم حالات ظريفة جدا جدا السيشن الجاية. يعني انتوا شفتوه في الأول ده كان لسه بس يا دوبك بنقول بسم الله الرحمن الرحيم. السيشن الجاية واللي بعدها رائعين، فأرجوكم خليكم معانا. طيب خليني أتكلم النهاردة عن enhancing endoscopic dissection مع التكنولوجي. احنا بنشتغل ESD. why ESD؟ عشان احنا we want in block resection. why we want in block resection؟ عشان this is what we want is a therapeutic resection. You want to remove your lesion as one piece. You want to remove it in block. Right. In ESD, we are dealing with a cancer, and the cancer is our enemy. So if you are fighting with the enemy, if you have a battle with your enemy, what do you need? You need a good weapon with you. You need a good field. You need to know a proper data about your enemy, and you need to put at the end a proper plan. طيب هنبتدي بأبسط حاجة. You need a good weapon. So what's the good weapon? دايما أشهر سؤال بتسأله: إيه المنظار اللي أنت بتستخدميه؟ إيه أحسن منظار؟ أحسن حاجة في السيمبوزيوم ده إن فوجي مش موجودة، أولمبس هم اللي موجودين. يعني أول مرة أشوف سيمبوزيوم الشركة المنافسة هي اللي بتحضر. طب فين بنتكس كمان عشان نكمل السيمبوزيوم؟ طيب so what do we need؟ احنا دلوقتي طبعا of course we use high definition scopes attached with auxiliary water channel and CO2. So this is what we use. خلاص المفروض ان ده this is the standard of care. طيب بس هل الموضوع بالبساطة دي؟ يعني عايز منظار حديث وخلاص؟ No. There are a lot of items that we really require during doing complex procedures. أنا بنشتغل procedures complex معقدة. هل القصة قصة image؟ هل this is what I need؟ إن أنا I need better enhancement. I need a lot. I need maneuverability of the scope. I need the scope to be good in the bending angles عشان يستحمل اللي احنا بنعمله فيه. I need the working channel. Where's the working channel؟ ال working channel دي بالنسبة لنا مهمة جدا، لأن أنا دايما السؤال diagnostic ولا therapeutic، وهنشوف دلوقتي ال outer diameter of the scope. Where is the outer diameter of the scope؟ طيب بنتكلم كتير قوي عن الإيمج، بنتكلم عن الليجن كاركترايزيشن، عن الميكوزال ايمج. طب هل في حد بدأ يتكلم عن السب ميكو؟ اهم فوجي اول مره يجوا، والله اولمبس ما قصروش، كانوا حاضرين السيمبوزيوم من الاول ما شاء الله. فوجي جايين متاخر في السيمبوزيوم بتاعهم. طيب فبنتكلم على الليجن كاركترايزيشن، بنتكلم على الايمج. طب هل في حد اداني ايمج غير بقى الميكوزال؟ بدأنا ندخل في السب ميكوزال. يمكن هو ده الجديد اللي احنا بنتكلم عليه، ازاي enhance the image but not from the mucosal side, from the submucosa. طيب السؤال اللي دايما بتسأله: بتستخدمي المنظار الدايجنوستيك ولا الثيرابيوتيك؟ بنقول ان كل واحد ليه بروس وكونز، في مميزات وفي عيوب. الدايجنوستيك المانيفرابيلتي بتاعته رائعه، بيندنج انجل كويسه، بس مشكلته ان الوركينج شانل 2.8. خلاص. طيب لكن الثيرابيوتيك سكوب الوركينج شانل بتاعته ممكن تبقى 3.8، وممكن اللي في النص اللي هو 3.2 عشان يمسك العصايه من النص. طب انا ليه محتاج اصلا كده؟ انا ليه محتاج ده؟ عشان sometimes you may face this situation. ايه رايكم في المنظر ده؟ دي حالات من حالاتنا فعلا الحقيقيه. عندنا bleeding, heroic bleeding. You need to stop the bleeding. You need to use a coagrasper. وفي نفس الوقت يبقى عندك القدره على ان انت to do suctioning at the same time. So this is this is الديبيت اللي ما بينك دايما وبين نفسك. هل هتستخدم منظار ثيرابيوتيك عشان تعرف تسكشن كويس، ولا انت لازم هتضطر الى المنظار الدايجنوستيك، لان الثيرابيوتيك ما هوش مساعدك قوي. حتى even in the therapeutic scope لو انا بستخدم الكولونوسكوبي برضو there is a problem about the working channel. طيب هنشوف. طب what about the bending angle؟ the bending angle يمكن فوجي كان ليهم السبق. هي موضوع السمارت باند ده is not new. السمارت باند ده موجود كمان كان في مناظير قبل كده. and you have to know يعني نصيحة من القلب لكل زملائنا، you have to know everything about your scope. everything about your scope. انت مش بتستخدم آلة وبس. you have to know everything. you have to know the bending angle. what are the angles؟ الاب قد ايه، الداون قد ايه، لان هو this is important وهو اللعب على الداون انجل. اوكي so the bending angle is really important. وزي ما قلنا ان يمكن فوجي عندها السمارت باند من سنين. طب خلينا نشوف البندنج انجل why it is important. this is a case of ESD. this is what I call bridge ESD. so خلي بالكم هنا this is my lesion and this is not a perforation, this is a communication with the other side. فاحنا داخلين بالمنظار بنعمل retroflexion through the bridge that we made with the lesion. Can you see? شايفين maneuverability, how the maneuverability helps. This is why I need to use a very slim scope. عايز استخدم very good bending angle because I am dealing with millimeters. أنا لازم أبقى شايف كويس جدا ويبقى maneuverability بتاعتي كويس. So the problem في أي دماغ أي حد بيشتغل advanced endoscopy is this: the balance between the maneuverability, the working channel, the outer diameter, and also the image. Why? Because يمكن most of the new scopes that are focusing on the image, they don't focus on other subjects, but really we are greedy. We want more. We want the scope companies to help us to have the maximum that we can do, and we need a little bit more and more. So regarding about this the smart band, this is Fuji scope, the 8 series, and I was really honored to work with. It's still not available in Egypt, but I have done a lot of cases outside Egypt using the 840. And what is new about the 840? The new is that they can combine that I use a slim scope. A slim scope, you can imagine how slim. It's 7.9 the outer diameter. لو احنا شفنا انت بتصور يا احمد يا حافظ، بص بيصور عشان يغش طلعهم بره بس. الاوتر diameter بتاعه is 7.9. 7.9 شفنا التيبل اللي من الاول كان 9.2 اصغر حاجه او 9.3، ده 7.9. imagine البيدياتريك سكوب بتاعنا بيبقى 6 وبيبقى 5.5 مللي. And in the same time, the working channel is 3.2. So this is a genius endoscopy, by the way. يعني إن أنت to have the outer diameter of 7.9 and to have the working channel 3.2, this is really amazing. ليه؟ عشان كل اللي احنا قلناه، maneuverability, bending angles, and more هو طبعا is very يعني benefitable في ESDs EMR. كمان بينفع especially لما أكون in a very tight situation. هوريكم فيديو الحالة اشتغلتها في إيطاليا. Z poem, a very old patient, very tight or very narrow space. So this was really a very smart option to use. And imagine that you have the same working channel as 3.2. So this is about the maneuverability, about going into deep spaces. You need to go in depth into the deep spaces, deep and narrow spaces. طيب moreover كمان ان يمكن الحاجات اللي عملوها، في ناس بتقول ان الحاجات اللي منظار الرفيع ده is very floppy. So the thing is ان هم مش بس ان القصه مش قصه ان هو outer diameter، لا هم خلوا التip بتاعته is a bit stiff so that it does not flop with you. ما يبقاش المنظار عايم منك كده وانت شغال، لا بالعكس، يبقى انت استفدت من المميزات بتاعته. And I believe this could be the standard of care in endoscopic resection, to use a slim scope with a good working channel. طيب بنتكلم على الإيمج، بنقول إن إحنا we need more and more. And by the way, for all the companies, not only Fuji or Olympus or Pentax, we still need a lot for the image. There are still a lot of work, hard effort that you have to do to deliver us a better image. And also to combine this image with the AI. I need the AI to tell me that this lesion is invasive. This lesion is submucosal invasion. It's SM1. This is what we need. So maybe لو احنا بصينا على الصور القديمة بتاعتنا لما كان التكنيكس دي، طبعا المودز دي انا ما كنتش، كانت لسه قبل ما اتولد، تمام. طيب احنا دلوقتي عندنا كمان بعد الفايس عندنا البي ال اي والال سي اي. شايفين الصوره دي؟ الصوره دي جميله قوي، انا مش ناسيه البيشنت ده. This is a lesion in the rectum and how amazing when the image tells you what's wrong. الليجن ده جاي لنا على بيشنت على انه serrated adenoma in the rectum. انا فاكره ان انا وانا شغاله الليجن ده انا قلت للناس it looks like the mucosa of what do you think. حد عنده اوبشنز؟ حد عنده اقتراح للليجن ده؟ حد عنده اي حاجه؟ ما حدش بيشتغل بفوجي؟ اخص عليكم. طيب الليجن ده وانا بتفرج عليه قلت لهم ده شبه الميكوزا بتاعت الاستومك. It doesn't look like a serrated lesion and it's there. After doing the ESD and sending it to the pathologist, it is an ectopic gastric mucosa. So you can imagine how the image can help as well. برضو هنا ما استخدمنا zoom endoscopy, which is not till now, the zoom endoscopy is not mandatory for endoscopic resection. لا guidelines ولا protocols, but if you have it, of course, it will be much better. This is the zoom endoscopy of a patient with a lesion with a previous trial of resection. And the thing is that we want to do, is this an invasive lesion? يعني أنا أقدر أشيل الانvasive lesion ده ولا no, this is not invasive, it's just a trial of resection. And this is amazing about the zoom, it gives you a lot of tiny details, even the shape of the capillaries and the pit pattern of the adenoma. And this is a low-grade dysplasia adenoma. So this is the image that we used to have. So what is new? What is the new technology? It is, of course, the noise reduction. You can see here, this is the new LCI. This is not the casual LCI that we use. And also this is the new BLI, as we can say. Why? Because there is a noise reduction. There is more clarity of vision. We need a more clarity of vision. طيب خلينا نشوف كده الفيديو ده. Can you see this is the 8 series and how the 8 series of about the what we call it CMOS technology and how it can help that you see the finer details. طيب we are speaking about the mucosal and all about the mucosal. So what's new? What's new? And why do we need all this sophistication? هو أنا عشان أشتري منظار هقعد أفصص فيه؟ you have to. You have to know everything about you cannot have an iPhone and you don't know how to use it. You don't know the application. This is really important. So sometimes the procedures are really complex. يعني بصوا على الليجن ده. This is a lesion. This is a huge lesion that it is in the rectosigmoid. It looks like this patient ده كان صغير في السن، أربعيني وجاي محطم. ليه حد قال له أنت محتاج جراحة؟ The thing is that you need to know that the image helps us. It helps us in taking a better decision. So a lesion ده بعد ما عملنا له characterization and it was obvious that there was no submucosal invasion. And the problem about this lesion is not about the lesion characterization. This kind of huge complex cases, you need a very good scope to work with. خلاص؟ يعني if you look, sorry. If you look even here في submucosa, can you see the field is really very bloody. It's very foggy. You have a lot of bleeding as you proceed. But this is not what we want. We want more. We want much better. عشان the procedures sometimes are very complex like these patients. So وده اللي خلى يمكن الاتجاه مؤخرا ان احنا نتكلم على الاندر ووتر. Why do we use underwater? Because of the clarity of the vision. I need a more clear vision. I need to see better because if I see better I can do better. شايفين هنا قد ايه الصورة رائعة دي، المية بتاعت ربنا سبحانه وتعالى اللي هو خالقها لنا. You can see here that I can do the dissection. I see every single fiber very clearly. I don't perforate. I don't cut the muscle. I'm just going on with my procedure. And even I can see the start of the bleeding blood vessel, and then I coagulated, and now my lesion is dissected. So this is the point. This is the point. I want to have all the possible tools I have to remove such, and this is, by the way, was a very, very complex case because the patient has a dolic colon and it was in the hepatic fracture. طيب. What about the submucosa? اتكلمنا عن الميكوزا. هل حد بقى بدأ يخترق السبميكوزا ويقول لنا can you enhance the image submucosal? Yes. And this is the amber colored image from Fuji. شايفين الفرق ما بين السبميكوزا؟ The thing is about the amber color that we need the submucosa to be like the blood vessels to be like very, very red so that you see it. And our preferred color is the blue color of the submucosa. فالفرق ما بين الصورتين مش ان انا حقنت ميثيلين بلو زي ما انتم متخيلين. This is an option in the scope. This is the option. It gives you this very blue color of the submucosa, and it gives you a very, very clear red color of the vessels. And this is what we, why? Because some of the Japanese, they don't use methylene blue, by the way. Why? Because they feel that the injection of the methylene blue, it secures the blood vessels. في بعض الناس لغاية اللحظة اللي احنا فيها ما بيستخدموش لون في الحق. بيقول لك أنا بعمل السبميكوزال dissection، وناس منهم قمم بتقول لك أنا بعمل submucosal dissection with the saline, normal saline, because I want to see the blood vessels. I want to coagulate the blood vessels علشان أنا مش عايز يحصل مني نزيف. طيب why not إن أنا أخلي الانجكشن بتاعي very minimal and so that I can see the blood vessels more clearly. So this is why it's the ACI mode. We believe that this is the dissection mode. احنا ممكن نشوف هنا ده فيديو قبل ال ACI mode, and this is without injection. You just press on the bottom. This is what we need from the scope companies. أنا عايز تخلي حياتي أسهل من كده. أدوس على الزرار خلاص كأني حقنت. And now I go with my procedure. This is about the ACI mode. So the thing is, إن إحنا what we need is we need a lot in the scopes. We need maneuverability. We need the thinnest or the smallest outer diameter with the best working channel. احنا طماعين وهنفضل طماعين. لازم تخلوا حياتنا اسهل، تتصرفوا وتخلوا حياتنا اسهل. Okay? I need a good bending angle because I go in narrow spaces. I go and do maximum down, maximum up. I need my scope to tolerate. يمكن Professor Inouye will show you a case today about the anti-reflux procedure. Professor Inouye is not happy even with the up angle. عارفين بيعمل ايه يا جماعة؟ بيعمل ايه؟ بيجيب السنير ويحطه من بره على المنظار ويقطم المنظار خالص، يقفل السنير because he wants to give the maximum up. He will do this today, so please don't miss it. ربنا يستر بقى على المنظار بتاعكم. فهو هيعمل this is what. So why is he doing this? Because we still need more. احنا محتاجين اكتر من شركات المناظير ان هي توفر لنا the maximum that they can do to have a better dissection or a better complex procedure. وهنا يمكن دي الحالة اللي أنا عملتها في إيطاليا using the 840 scope and the ACI mode. I believe the ACI mode, there are few publications, but there are a huge ongoing research data about the use of the ACI as to be the standard of care as a dissection mode. This is my team, and thank you.
Thank you very much, Shema. We know that you have to go to a NAS hospital now. You'll not go? Good, perfect. So any questions with Dr. Shema? If no questions,
أي أسئلة؟
we'll have a small break, 10 minutes, and come back immediately to follow the live transmission. Thank you very much.
طيب ثلاث كله اللاب تمام اللاب إبراهيم.
ممكن يا جماعة ننادي على فين بقية الشباب؟ وقت الأكل بقى. يلا يا دكتور عصام، ده صاحبك قاعد. يا مصطفى، مصطفى قبيل. لايف، يلا مفيش محاضرات، خلاص خلصنا محاضرات. اه عايزين بقى دالاس تعمل لنا اللي انا قلت لك عليه، تطلع السنترز كلها. بنت يارا دي ولا يوم؟ انت مين يا بنت اللي هناك؟ يارا دي ولا يمنى؟ فين الشباب بتوع ايرس يا جماعه؟ احنا كده عندنا ديلي. ماشي، هو فين الناس بياكلوا؟ ايوه يارا، نادي مصطفى بسرعه، يارا اتحركي بسرعه، بطلي اكل. ماشي. هو مين الشير بيرسونز؟ دكتوره عصام ودكتوره هدى، دكتوره نجلاء ودكتور طارق ماشي، وزاهر ما جاش، محمد سعيد. وفين ملاك؟ ماشي. اهو بيزن، اهو بدأ يشتغل. هي الفكرة عشان الناس ما اكلتش من الصبح فايه. يا دالاس، الناس بتوع العراق يا دالاس عايزين حد يبعت لهم اللينك. دالاس يا دكتور برعي، نادي خلي ايرس ينادوا الناس من البتاع. هيبعتوه دلوقتي، ايوه هيبعتوه دلوقتي. يلا يا هيام. ما انا لسه عايزه، انا عايزه اجيب بس طلع كارت الاول حتى. يا مصطفى، طب بتنادي الناس انت قاعد ترغي. يلا يا مصطفى، يلا العيانين نايمين. يا جماعه حد ينادي الناس. هي دالاس انت بعت لي ايوه دالاس. ده بتاع العراق، ده بتاع الهند قصدي.
الهند، ده الهند سانجي.
ايه؟ عايزهم ينادوا الناس من البيت. ماشي، يعني انت هتحط لي هنا. طيب ماشي، هنبتدي ببتوع الهند، يلا. فين محمد عبد الظاهر؟ يا سامح، عايزه الناس. هبتدي والله. ايوه يا ابني، انت فين؟ انت سيبهم هم يجمعوا، انت تيجي تقف هنا عشان تكلمني مستشفى نصر بدأ ولا لسه؟ خساره، حاله حلوه الماجنت دي، عايزه الناس تحضرها. حاله حلوه. لا بس يجوا الاول. اشوف بس طيب مستشفى الناس دي. شغالين الهند، واقف الراجل واقف على كده. لا انا هكلم الهند. طيب خلاص اقفل. دخلنا على هيوة كمان يا، على العراق يا درس. طيب احنا هنبتدي السيشن الثانية. السيشن الثانية يعني the second session will start. It's one of the يعني maybe powerful sessions. So I will invite the chairpersons, دكتور محمد البرعي، دكتور أحمد غانم، دكتور محمد السعيد، دكتور عصام علي حسن، دكتور طارق إبراهيم، دكتورة هدى عبد العزيز، دكتورة نجلاء فتحي. And we have Dr. Nuno Nunes from Portugal with us. So this session is a very special session. We are transmitting from 2 different countries. We are transmitting from Al Nas Hospital as well. And now we are having India with Professor Sanjay Rajput, and Iraq with Dr. Hiwa Abu Bakr. So let's start with a very, very interesting subject in endoscopy, what is called magnets in endoscopy. And I'd love to welcome Dr. Sanjay Rajput. Sanjay, are you with us?
Yeah.
حط الهند معنا يا درس بعد إذنك. So لا الهند. So Dr. Sanjay, good morning or good afternoon. Dr. Sanjay.
Congratulate you.
Yes.
And your team, Dr. Ahmed, for inviting me us and giving me this opportunity to present in Egypt. I have Dr. Miller, guy who is the backbone of these cases. Mr.
I can put money, yeah. I'm a JNA2A, huh? JNA2A. Yes, but this area, some area or JNA2. Yes. Specifically in this area. But we see that some with the pressure area.
So,
Sanjay, Dr. Sanjay, please. Your voice is a little bit very far. So because this is really important that we want the audience to understand the concept of magnets in endoscopy. It's a little bit far.
Let me try more. Now,
It's
I can hear you, but it's a little bit far. If it's possible that you put the voice.
Hello, can you hear me?
Yes,
So
this is better than the.
can, can you hear now?
Yeah, this is much more better.
Okay, so someone will have to hold this mic. So the case is a case of post liver transplant with a stricture. Though patient has a bile coming from the bile duct, but he has a difficult stricture where we cannot pass a guide wire from below, and PTC also cannot pass guide wire from above. You can see the screen of IITV, the image, where you can see there is a dilated hepatic duct on the right side, and from contrast also from below is not going above. So there is a clip in between. So this patient will require major surgery post liver transplant if we cannot do or otherwise he has to live on lifelong PTC. So we are trying to do a magnetic reconstruction anastomosis for this patient. We have developed a unique magnet with a hole which can go through the scope, and we will show you the magnets. Cheti madam, show the magnets.
Dr. Sanjay,
Yeah.
can you hear us?
Yes, yes.
This is Assam from Egypt, and sitting beside me, Tariq. We are sending you and Mr. Ashish our greetings from.
Thank you, Assam and Tarak.
Yes.
Thank you.
We will meet you soon, and we hope to meet you soon in physically in Cairo.
Yes.
Mr. Sanjay, you are our mentor, and we are happy to see you now. But we want to ask you something about the magnet technique.
Yes. Tell.
We want to start from the very basically. What are the indications for using magnets in biliary injuries?
Yeah, the main indication is cutoff of the mind. Now you can hear me better?
No, the previous mic is better.
Okay. Yes. So the main indication, as you all know, is complete cutoff post cholecystectomy bile duct injury, where there is a less than 2 centimeter of the cutoff is there. The distance should be less than 2 centimeter. The second is post transplant liver stricture, and third one is refractory stricture, which requires repeated stenting, and still when you remove them, then this will cause the stricture. So these three are the main indication. Another indication, very interesting indication, is post-chole right hepatic duct isolated injury, where you do not have other option than surgery. Here we can use magnets to reconstruct the right hepatic duct with the common channel. So these four are the main indication for magnetic reconstruction of bile duct.
Okay. For our young colleagues, you are doing it with the cooperation with interventional radiology.
Yes.
Yes, the radiologist bumping the wire.
If you interventional radiologist and the duct is dilated like this,
Yes.
you can do hepaticogastrostomy EOS guided. You can put a stent from left duct and go through the stent and put a magnet through the same hepatic duct stent. So we had a case, and we will show you in after 2 months in New York Live. We have a case which we have from where we can put a stent HGS, and we will put a magnet from the HGS stent.
Do you use a special type of wires or the usual one?
Same wire.
Wire.
We do not need special accessory. And now we have made this procedure very, very simple. Just anybody who can do ERCP can do this procedure at his clinic. So I will show you the accessories which we are using. We are using the sphincterotome and the guide wire routine. We are using the stent. Cheti madam, so we have put this magnet on a stent so that you can just place.
Can you zoom on? Yes.
These are the magnets.
Yes.
These are the magnets. We have different sizes of magnets, 5 millimeter, 9 millimeter, and diameter is 3.4 millimeter, 3 millimeter, and 2.4 millimeter, each decided by the size of the CBD as well as size of the hepatic ducts. Now, previously what was happening is that when the dilated ducts were there, the magnets were used to rotate, or they used to have a different position. They used to choose the different position than what we are intended. So then we have made a special magnet stand. We have embedded the stand with a magnet. So now this magnet stand has a unique property that your pole will not be changed. This magnet will have the same pole every time, and the above magnet which we are putting from the PTBD side will not change. So by putting a simple stand with magnet, you can do all three complications are gone. One complication was magnet could migrate into the liver because of the change of the pole in dilated duct. That is ruled out. Second thing, the lower magnet can fall down if they do not unite at the time of placement. They may unite later. So the lower magnet also remains at the same place. Third thing, that you don't have to decide the pole again. And the fourth one is when the magnet unite, you don't have to remove the magnets. You just have to remove the stand, and all the magnets once united, they will come out together. So I will show you how this happens.
We are excited to start the procedure.
Yeah. So this is a magnet stand. And these are the magnets. This is the pole decided previously that this is the black. Once they are united, you just have to remove all the magnets together with this. So we have already placed the wire inside. Chaiti madam will describe the procedure now. Chaiti madam.
Yes, yes, bro.
So,
We have already placed the wire.
sir, we have already cannulated the bile duct, and we have done the sphincterotomy for the same. So guide wire, as you can see on fluoroscopy. Are you getting the fluoroscopy image?
Yes, yes, we are seeing the.
Okay, so guide wire from below is not crossing the stricture. And at the same time, PTBD has also been done. 10 French sheath has been placed, and guide wire from there also has been placed till CHD level.
I will put the first magnet with a stand, and then I will ask Milan sir to push the magnet from above further. So we are exchanging the wire slowly. You have to be careful. This procedure becomes very easy with the invention of this magnet stand, because previously we had to push the larger magnets into the bile duct with the help of the larger stands, and you have to push it, and it was very cumbersome, and we have to put the metal stand to push this magnet. So that's why this procedure was not very successful and not very popular. We have done around 40 cases now. This is our 40th case. So, and we have 91% success with these magnets. And we have 3 years follow-up now. From January 2024 to now, we have almost 3 years follow-up with 91% success. We have only 3 failures in which there were distance was, in one case, distance was more than 2 centimeters. In one case, there were more than 3 clips in between, and there we have to cut the clips and then put the stands through the rendezvous. And the third one was a liver transplant case where we could not find out the apposition because of the distance alignment of the ducts. So then we have made another magnet of side attachment magnet. We will show you the side attachment magnets when the anatomy is difficult.
Okay, sir. While you are passing the stent, I'll explain to my colleagues here the technique in a simple words, because some of them are not following the
magnets which are having side attachment. Can you see?
Okay.
So, Professor Sanjay, we will
magnet
to the audience. Just give us
instead of opposing parallel to one another, it is one is forming T shape and one is going perpendicular.
So it will not take more than 3 minutes. Milan is pushing the magnet from above, and we are pushing the magnet from below.
Professor
Yeah,
Sunday,
I pushed my magnet first.
do you hear us?
Actually, this procedure is now very easy because of all this
Sanjay sir,
invention.
Sanjay sir,
Yes. Yeah.
are you hearing us?
Yes, yes.
I'll explain it in simple words for our colleagues here in Cairo.
Okay.
Okay?
Okay. Egyptian friend with us.
Yeah. We are happy to be with you, sir.
Yeah.
Yeah, thank you. Dr. Sanjay, he innovated a new technique in biliary strictures. He is using the magnets to solve the post-operative strictures, mostly post-cholecystectomy strictures and post-cholecystectomy cutoff of the common bile duct. And in liver transplantation also he can do it. He is using two magnets, واحد بيدخل ب-ERCP, واحد through the skin, and the two magnets are fused together. Within 2 to 3 weeks بيحصل tunneling ويحصل new CBD بتبقى re-innovated. A very successful technique الحقيقه زي ما هو بيقول ان النتائج فوق ال 93% في البوست في small strictures less than 2 centimeters. يمكن تكون اقل شويه لو الستركشر اكتر من 2 سنتيمتر. This is an innovative technique الحقيقه he started it in India 3 or 4 years back and he is one of the most brilliant professors in
So
this.
now you can see the magnet going down.
هو دلوقتي داخل بالدعامه وعلى التب بتاعتها الماجنت، مش كده يا دكتور عصام؟
بالظبط، الدعامه داخله بالمنظار
السلام عليكم.
والماجنت على التب بتاع الستنت.
So now my magnet is there. Now Milan sir uses magnet over his wire.
We are seeing the progression of the stent with the magnet on top, and the other magnet is coming from the external catheter. The other magnet is moving now. Yes.
Yes.
We have two magnets now, one from below and one from the ERCP.
Yeah.
Yes.
Can you see?
And now the fusion happened. Yes.
Yeah, the fusion is happening.
Yes.
So you can see in front of you the magic.
Yes. Very great, sir.
We have 3 cases of like this, and we have one magnetic GJ also. So if you want to go and come back, we will show you another case.
Yes.
Okay.
Yes.
Okay, sir.
Thank you.
Thank you, Sanjay, sir. We enjoyed very much of this. Thank you, sir.
Thank you.
We are moving to Kurdistan, Iraq, with a case of ESD. Dr. Hiwa, مساء الخيرات. Dr. Hiwa.
Yes.
Yeah, we are transmitting now from Sulaimaniya University. يا دكتور هيوا ما شاء الله خلصت الليجن، ما تصبر شوية. دكتور هيوا اصبر شوية يا دكتور هيوا، كنا عايزين نشوف الليجن ونشوف الاستراتيجي. صباح الخير، مساء الخير قصدي. دكتور هيوا we cannot hear you. دكتور هيوا. دكتور هيوا ولا احنا اللي مش سامعينه؟ طب هو احنا مش سامعينه ليه؟ طب can you open the mic please دكتور هيوا because we cannot. Yes.
Do you hear us?
Yes, now we can hear you.
Thank you very much, Dr. Shaima Al-Khouli, Dr. Muhammad Al-Shirbini, for your kind invitation. It's a great honor for us to be with you in Cairo Live Endoscopy 2026 with my colleague, Dr. Mohammed Al-Salomi, Dr. Diab Khoshnau from Sulaimani, Iraq. I will show you we will present a short video of the case and then we will start the procedure with you.
Yes. Can you present the case, please? Dr. Hiro, can you please present the case?
Yes. Need injector better. So you hear the history?
Yes. So we can see he's an 81-year-old male patient, and his colonoscopy showed a rectal laterally spreading tumor. Dr. Hiwa, can you please show the audience the lesion and the strategy
Yes.
that you choose for?
Yes. Actually, before we started the live, we started mucosal incision. You can see the lesion is about 3 to 4 centimeters from the mid-rectum. The lesion to us, it is a combination of non-granular flat elevated type, or you can say also granular LST. But my impression is more goes with flat elevated non-granular LST. And the lesion is about 3 to 4 centimeters, as you can see from white light. Endoscopy, the JNET classification in most of the part is 2A, and in some area we have 2B, and we have some area of slightly depressed area, as mentioned by Dr. Mohannet. So, Dr. Mohannet, what do you think?
We evaluate the lesion before doing the mucosal incision. It was 3 to 4 centimeters, as Dr. Hiwa said. It is mixed granular, non-granular, GNET 2A, and in some areas 2B. And Paris classification, it is 1S and 2A. So Dr. Hiwa, his strategy to start the mucosal incision from the anal side, and he already did the mucosal incision because our patient is elderly, and we start the procedure under light
sedation. We are talking with the patient. Actually, the patient is awake and he's talking with us because this patient is risky for GA. He's talking with us.
Greetings to your patient, Dr. Hiwa. قول له سلامات.
Yes. So my strategy, I did a C-shape incision, as you see from anal side, and I follow the Ohata style sensei C-shape incision. I go till I reach to the meat of the lesion. Then I make a proximal incision, and then I finish by breast technique, as you described, Professor Shema. This means because we think that there is some. Yes.
So Hiwa, you will do the
Yes,
bridge technique or just pocket?
My plan it will be a breast technique. So C-shape incision from the anal side, and then when I reach to the proximal side, I will make another C-shape incision from the proximal side, probably in retroflexion, and then I will connect the tunnel. Then I will cut the gravity side, left side, which is this side, and then I will cut the anti-gravity side. As I mentioned, because the lesion is risky lesion, we think that there is some mucosal invasion. Probably we may go in SM3 or deep submucosal invasion, because probably we may face some fibrosis in this area, and we hope that we can control the plan. And usually I will try to make a conventional ESD without underwater in this patient.
So Dr. Hiwa, يعني can you tell us your setting, the scope you use, the knife you use, the position of the patient, so that the audience are following?
Yes, because before the live, Nidlin, the position in the left lateral was not so good, so I changed the position to the right lateral. So you can see that the patient is facing to us, and we are doing the procedure in the right lateral position. And I am using Olympus EVIS-X1 system with therapeutic scope, which is GIF H290T. This scope is very good scope for endoscopic submucosal dissection procedure in the rectum and upper GI tract, because the working channel is 3.2. And I use RB via 3 electrocautery system. I use Endocut I222 for mucosal incision, and I use soft coagulation effect 2.5, 45 watt for submucosal dissection, and soft coagulation for hemostasis.
And the knife you're using here, I think you're using Microtech knife?
I use a gold knife from Microtech T-type 1.5. So. And I use standard distal cap from Olympus, I think. We usually use standard cap injection. We don't use SC foot for rectal lesion unless we face some severe fibrosis, or when we want to make a tunneling, or we want to go for endoscopic intermuscular dissection.
So you use a 2 millimeter or 1.5?
Now, the knife is 1.5, of course, 1.5 for the lower GI tract. Always we use 1.5.
I totally agree with you. I know there are some who use 2 millimeter in the rectum and the stomach, but I prefer to use 1.5.
Knife.
So he will.
Because I don't make circumferential incisions, so I will not make a traction usually. Usually we use the natural traction for rectal ESD cases. For the right side of the colon or splenic flexure, sigmoid, sometimes we use traction by dental floss or by ring when we do endoscopic semicostal dissection. But for in the rectum, we don't usually do device-assisted traction.
Yes. So this is a very nice case. We will come back to you. We will go to Al Nas Hospital and to see the cases there, and we'll come back to you in a few minutes.
See you soon.
Okay, just a few minutes. Hi Diyar, hi Muhannad.
Hi. Okay.
أولادنا.
See you soon.
ممكن نروح الناس يا دالاس بعد إذنك؟ مستشفى الناس جاهزين يا شباب؟ مستشفى الناس يا جماعة. سنجي لسه هيدخل حالة تانية. مستشفى الناس يا شباب. ممكن الدكتور أحمد زايد يبريزنت ذا كيس؟ محمد. دالاس هات الكاميرا يا دالاس. طيب شغل الكاميرا مش مشكلة. طيب احنا هنا في مستشفى الناس. الشباب فين دكتور احمد زايد؟ ممكن تبريزنت ذا كيس يا جماعه؟ someone يبريزنت ذا كيس. هم سامعيننا. هو محمد اهو واقف ودكتوره سعاد وده كريم هم. طيب عايزين حد بس يبريزنت ذا كيس because we cannot hear you يا دكتوره سعاد. we cannot hear you.
Hello, can you hear me?
Yes.
Hello, دكتور شيماء, can you hear me?
ايوه كده سامعين. ممكن نعلي الصوت شويه ونقرب المايك من بقنا.
Okay. To start with this case.
ايوه يا احمد يلا توكل على الله.
40-year-old male patient. يا جماعة. It's a 40-year-old female patient complaining of bleeding for rectum for 3 months. The colonoscopy was done, revealed sigmoid lateral spreading tumor, flat homogeneous type, Paris 2A, Janet 2A, about 2 centimeters in diameter. The patient is case of sigmoid LST for endoscopic resection by Dr. Muhammad Nabil, Dr. Antonio.
السلام عليكم. دي بس شيماء.
ايوه دكتور محمد.
Can you hear?
اخبار؟
الحمد لله. Can you hear us please?
Yes, now we can hear you but we don't see you. Now we can see you and hear you.
Okay, thank you. Now we are in front of the lesion. The lesion is 40 centimeters from the anal verge, so we prefer to bring an upper endoscope, EG 760R, for better manipulation. And regarding the position of the patient, we tried at the first to have the lesion at 6 o'clock. It was very difficult, so we changed the position of the patient to the right lateral position. And this is a very stable position now. The lesion now is the characterization of the lesion. We have a very nice lateral spreading tumor, granular type, very homogeneous, like you can see here. It's about maybe 1.5 centimeter in size. So we were discussing with Dr. Suad and Dr. Karim what is the ideal way of removal of this lesion. Dr. Suad suggests that we do cold snaring EMR. I was thinking about the underwater EMR, and Dr. Karim was thinking about the classic EMR. What do you think, Shayma?
I think cold snare. I'll go for it. Just with a little suctioning.
Yes, I can. It's a pretty small lesion, and with a little of suctioning and using cold snare, if I'm sure I'm gonna take it as one piece, I'm gonna take it as one piece. If not, I'll go for underwater EMR. So,
Yes.
Okay.
any suggestion? حد عنده اقتراح؟ دكتور طارق، دكتور عصام، دكتورة هدى.
If we can,
It's always with me.
Dr. Muhammad Nabil, can we do
أيوة.
can we do elevation before doing EMR?
Yes, of course. Okay, we will start the classic EMR now. I will start with the oral side of the lesion from here. Send me Muhammad.
السلام عليكم.
Please
ازيك دكتور
inject.
محمد؟ دكتور هدى عبد العزيز من الزقازيق معاك.
دكتورة هدى أهلا وسهلا.
اهلا بيك، اهلا بيك دكتور محمد. I think underwater EMR better. This is a small lesion and can be taken in one piece. I think that was called snare after elevation.
Yes. Send. احنا عملنا كلاسيك ميثود انجكشن submucosal injection saline and methylene blue for better elevation and separation of the muscle. And after that, we can attach it in block with a snare. Inject. We're changing now the position of the scope for having a very wide area of injection using the scope itself.
Very nice. It is rising above. Good elevation.
Yes. Oh. Nice. So we start the injection distally at first at the cecal side, then the anal side to prevent inversion of the lesion to the other side.
So, Dr. Muhammad, what do you think about the cold snaring EMR?
A very good option. You know, Dr. Shama, I prefer cold snaring from a very long time. However, for يعني demonstration of an EMR technique, the classic EMR technique, تمام. Okay. We will do it by EMR. So خلاص خد السن، خد السن ادينا السنير. والله ادينا السنير 27.
You tried before mixing methylene blue with hyaluronic acid for delayed reabsorption?
Sometimes I use it, but not in this case. It allows a longer lifting.
The
Longer time.
will persist more time than saline injection.
Yes. Yes. However, it is a small lesion, so we don't need a very long time of lifting.
So, what is the type and size of snare you're using, Dr. Muhammad?
I'm using the Boston Scientific Captivator snare, 72 centimeters, 72 millimeters. 27, sorry.
27.
27 centimeters.
27 millimeter. 27 milli. But the lesion is a little bit, it looks like 1.5 or something.
We don't have 15. The only present is 10 and 13. So we frightened that the lesion is not totally taken in a one bite. افتح على الآخر. على الآخر. طبعا خلي We try to have some
You do some suction.
safety margin.
This is one of the important things. دايما بنقول
Yes.
The best option for the lesion is the first trial. So try in the first trial of the lesion when you resect it to resect it completely with a good normal tissue around. حتى even a small.
Yes.
So now we are happy that we catch the whole polyp and also maybe a good safety margin. After we resect the polyp, We will inspect the bed, Dr. Muhammad, and we have to shift again back. So very nice. Thank you. Can we shift now? We will come back to you, Dr. Muhammad, if you're going to close or not. But we are going to Hiwa. Back to Hiwa, please. Iraq.
حلوة. يلا طلعوا لبسين كده. حلوة انت تاخد سيفتي مرة حلوة جدا.
هيوا
يا دكتور هيوا ارحمنا شويه يا دكتور هيوا، ايه السرعه اللي انت ماشي بيها دي؟ عقدتنا فاجتنا.
You hear us? لغال معناه؟
هيوا, do you hear us?
Okay. Yes, yes, yeah, we hear you. We are in progressing
ما شاء الله.
tunneling, and I hope that post coagulation. Of course. Because in this area there is some fibrosis, so I will postpone the fibrotic area to the end of the procedure. I want to make a tunnel and I will dissect the other side of the lesion. Then I will go below the fibrotic area, which is located at around 12 o'clock. You see here some fibrosis here. You can see.
Yes, Hiwa, can you
Yes, yes.
show the audience how much progression have you made? Can you show them the pocket that you have created? Just a view.
Yes, yes. You can see that we make a good progression. So I think we reached to the mid part of the lesion, and we dissected around maybe 40 to 50% of the tunnel of the lesions. So once I see the blue discoloration of my injected specimen in the other side, then I will make another C-shaped incision. Now I will change to the needle injector because I want to inject more. When we don't perform circumferential incision and we make C-shape incision like this in this case, so the lifting agent will stay for a long time because in the colorectal ESD circumferential incision sometimes make the lifting agent grow rapidly. And during my dissecting the submucosa, usually I use the cap as a good retraction. You see how the cap making attraction in the space of the submucosa. In the right side of my field, there is a muscle, and on the left side, there is the back side of the lesion. Needle out.
So here you expect that the patient, we will face the fibrosis from the endoscopic assessment of the lesion, right?
Yes, because this is a non-granular LST, as I said, needle in. So we face many times that there is some fibrosis. Like here, you can see this blue discoloration. So I will keep this fibrotic area to the end of the procedure. I don't want to get muscle injury or any perforation. Needle out. So I will finish the other side while I keep tunneling till I reach to the end of the tunnel, and I see blue discoloration of my lifting agent in the proximal side. Needle in. Needle out.
So
you can see I am making injection at the shallow submucosa because I don't want to make any injury to the muscle. Needle in.
Okay. I see that you're.
So you can see the tunnel is very beautiful. And I think we reach to this side here. So probably we will make some progress till we reach to this side, and then I will make a C-shaped incision in retroflexion view.
So Hiwa,
Yes, Dr. Shema.
I see you're injecting with a casual injector, and the Microtech knife has a very, very good injecting capabilities. So why do you keep on exchanging between both?
Yes, yes, yeah. This is a very good point. Always when I do dissecting, especially when I use EndoCAD, I ask my assistant to inject. So while I am doing dissecting the submucosa, I do also. You can see how my assistant doing continuous injections through the tip of the knife. So here there is some blood vessel. I use forced coagulation and I use prolonged spark of the forced coagulation to prevent bleeding. And if any bleeding happened during my procedure, I shift to the RDI, which is very good for detecting the submucosal blood vessel if I don't recognize properly, like here. So I will use the RDI and I will use the forced coagulation, but I use in a prolonged way. If I don't control, then I shift to this spray coagulation 1.5 or 1.8 spray coagulation. Spray 1.4.
So
And
now,
I make continuous injection of the.
so you're now using the RDI mode from Olympus.
Yes, please. This is arterial bleeding. So if not controlled, then I use co-grasper to control the bleeding to avoid any muscle injury. I think because this is non-granular LSD and there is a lot of fibrosis, so probably we may face some big vessel. If not controlled, to avoid muscle damage, I will shift to co-grasper. And while I am preparing the accessory, I will tamponate the blood vessel by the cup in order to prevent pooling of the blood in the gravity side of my dissecting field.
So we're having Dr.
Yes.
Nunes with us from Portugal on the Zoom, and he wants to ask some questions. Dr. Nunes from Portugal, he wants to ask some questions.
About open.
لا خلوا يا دلس سيب الصورة على هنا. يا جماعة مهم عايزين نشوف ازاي بيكنترول الايد.
So there is some bleeding. داخل عينيه.
Can you open the mic for Dr. Nunes بس?
We can see that we could control the bleeding with a grasp. This was a big vessel, and I will coagulate the other side, and I will then go to the needle. Okay. The gold knife to continue the dissection of the submucosa.
Okay. Very nice
Annette, can you?
demonstration. And it's really very important when you have a bleeding that you don't panic. So can we go to Al Nas Hospital? We will come back to you, Hiwa. Can we go to Al Nas Hospital?
Okay.
Nabil, and then come back. عايزين أسرع شوية دلس بعد إذنك. طيب, this is the bed of the lesion, yeah, of the polyp, Dr. Muhammad. Very nice resection.
Yes. Here is the lesion.
Yes, we can see.
It's totally removed. The area in the 1 o'clock is an artifact due to the athermy. It's not residual. So in such lesion in the left colon, Dr. Shema, would you close the lesion or not, the defect or not?
I think it can be healed spontaneously, Dr. Muhammad.
No need.
In private
For me, I
session,
will
I
not
close it.
close any lesion in the left colon, except according to Sydney classification. If there is any muscle injury, I will close it. If not, I will not. And also, if the patient are taking any anticoagulation or antiplatelets, just to resume his medications.
Okay, thank you, Dr. Muhammad. We have to go back. Can we go back? Yes, we have to go to Dr. Sanjay in India. He's ready.
Thank you.
Yes. Can we go
Allah,
to
Jamba.
Dr. Sanjay? عايزين نروح الهند يا دلال. رحت الهند. So, Professor Sanjay. Professor Sanjay. So a very, very interesting topic is the use of magnets. Now I can hear you. So this is another another application for the magnets. Yes, it's really very interesting subject and very cheap as well, right? Maybe next time we'll have
Very cheap. Yeah, all the magnets are very cheap, less than the surgery, and it will prevent major surgeries in these cases. So this is a very interesting case. Yeah.
Yes. Can you please someone present the case for us?
Yeah. This actually I will only present because I have all the history. This patient is interesting case, a young female around 20 years old, presented to us with accidental ingestion of lime.
Dr. Sanjay, can you hear me?
Yeah.
This is Tariq.
Yeah.
Can you change the mic, please? The hand
This
mic.
is-
Yeah.
Okay. Can you just hear now?
Yes, yes, it is better.
So this person has accidental ingestion of lime, which is corrosive. So she has stricture in the pelvis. At 20 years of age, she has difficult stricture which was requiring dilatation. So she came to us with a history. She is still not married and she don't want to undergo surgery now. Yeah. So we have put an axial stent for after 6 to 7
Sanjay sir,
dilation.
Sanjay sir,
Yeah.
can you use the hand mic? Can you use the hand mic? The other mic, yes.
Okay.
Yes.
Okay,
Yes,
okay,
please.
sure.
Remove this. Yes, thank you.
So this patient, now can you hear?
Yes, this is great.
So this person had lime ingestion with corrosive stricture of pylorus, no esophageal stricture, unmarried female, and she want undergo. She is unmarried, so she doesn't want any scar on her abdomen before her marriage. So we gave her an option of magnetic GJ. Before that, we put an axios, luminal axios, 20 millimeter for this patient. Now this patient had gained 7 kg weight, but once we remove this axios, she will again have the stricture. So we had given her an option of magnetic GJ. We have done around 20 cases of magnetic GJ with 70% success rate. This magnetic GJ is a boon for this
Now
person
you
who
will
will
present
require
another
surgery.
technique. You are talking with us about gastrogynostomy. Yes?
Yes,
Magnetic
this is
gastrogynostomy.
gastrojejunostomy.
Yes.
This is magnetic gastrojejunostomy,
Yes.
where we pass a magnet into the jejunum over the wire. We have developed a special magnets and special tubes to pass them over the wire. This is a tube.
So
You
you
can see
use
the tube.
another type of magnets. This is
Yes, they are the linear magnets.
Linear magnets.
They are large magnets, very large magnets.
You will pass
5
it-
centimeter.
you will
5
pass it with
centimeter
the
long.
catheter to the jejunum.
Yes,
Yes,
yeah,
and,
we attach
and it will
this
fuse
with the
with the
catheter.
stomach.
Yeah, this will go over the wire.
Yes.
This all will
Over
go
the wire.
over the wire. So once this magnet goes into the jejunum over the wire, as you can see on the screen. Can you see on the screen?
Can we see the
On the
screen,
follow
please?
screen?
Show us the screen, please.
Yes, we can see.
Now we have the screen. Yes. This
Yeah,
is
so you can see
the
that
magnet
this
over
magnet-
the rail.
Yes,
the
we
magnet
have-
over the rail in the jejunum.
Oh, yes, it is in the jejunum.
Yes.
And the second magnet is also over the tube. Pakad. Second magnet is also over the tube, same tube.
Yes.
Because this patient has a benign stricture, so he don't need a long-term nasojejunal feeding tube. So we have made a special tube. So once this magnet unite in the stomach,
they will
then you
cause
can remove the
ischemic part and necrosis will happen, and
Yes,
we will have a
yes.
fistula between the
Yes.
stomach and the jejunum.
within 2 weeks.
Within
And
2
then
weeks.
here after they unite, during the same procedure, you can just remove this tube. So
You
patient
are
don't have
pulling-
to be on
pulling-
nasojejunal.
So you are keeping the tube inside.
Yeah, tube inside, which will prevent the migration of these magnets
To prevent
into
migration,
the
yeah.
distal part, and because all the complication occurs only due to migration. So once these tubes are magnet GJ is formed, you just have to cut this thread, and then these magnets will be on one tube, and then you can remove the tube through the GJ. And this will form more than 5 centimeters GJ, which is as good as surgical GJ.
That's great. So just
Yeah, so I will show you. Yeah.
Can I ask you one thing?
Yeah.
Did you innovate this by yourself?
Yes.
This is great, sir. This is great. Okay.
So now we are just going to show you the technique, how we push this magnet. You can see on the IITV, the first magnet, and then second magnet is just in the esophagus. Can you see? Just show me.
Show us the screen, please.
Yeah.
Yes.
So the
You are
second
moving
magnet
now
is
with
just,
the rail to the stomach.
yes,
Okay.
बताओ. So the second magnet you can see
Yes.
is in the esophagus.
Okay.
So we will push this magnet inside. We can push this magnet, you can see.
Yeah, we are seeing the magnet now
This is
moving
going
in the esophagus.
Yeah, this is going in. This is
Yes,
going in.
yes,
So,
yes.
so now this magnet itself will hold the second magnet. It will attach to the second magnet. Can you see it?
Okay, this is great. Yes, yes. Now we have the jejunum and the
the
stomach are facing
Yes,
together.
together.
Yes,
And
yes.
the most important part, can you focus on this tube?
Moving.
Here, please.
Yes, yes.
No, just focus on this tube.
To
So
the
you don't
right.
need to. Yes, you just have to move this tube.
It's screw-like.
Counterclockwise.
Screw-like.
Yeah, screw-like. Remove the wire, and this tube is out.
So you removed the extra part of the rail, and you kept inside
Yes.
both the magnets
Super, yeah.
and a small part of the rail to prevent its
Yeah.
migration.
Yes.
Okay.
So I will show you in the stomach. Just a minute. Just wait for 1 minute. We will show you how it looks in the stomach.
So can we use this for bariatric procedures? Doctor?
We have done 4 cases of gastro and ileostomy with good results. So we are going to use in bariatrics in near future, and we are going to publish it also. So I will show you the screen.
Bariatric.
The endoscopic
Yeah,
view,
this has a
Dr. Sanjay?
bariatric use also.
Can we have the endoscopy view? Yes.
Endoscopic view.
Yeah, just now. I will show you just now.
And at what time do you expect the anastomosis to be completely established?
2 weeks.
Within 2 weeks. This patient has a deformed stomach. Can you see this?
Yes. Yes.
This is the magnet with the tube. It's going through the pylorus. You can see the axios for the feeding. So she doesn't require nasojejunal feeding tube for the feeding also. And she will have a GJ within 2 weeks, which will remain there. We have seen that in those patients where GJ, where the stricture is there, this GJ is permanent. And in those cases where you do not need this, like group pancreatitis, SMA syndrome, when they have cured of their disease, this GJ will close. So it is good for benign disease also, where you do not need GJ for these patients, surgical GJ. You can cure the basic disease and patient will do not require surgical GJ for those.
Dr. Sanjay.
So, yeah.
Did you encounter any complications from the magnets, especially the large ones?
Pain. The patient will have pain for 2 days. This is a big magnet, so they will have a little bit of ischemic pain for 2 days. For last 21 cases, we did not have any single complication. And we have now developed one ferrofluid guided magnet placement for safety also. We have now developed one more technique of ferrofluid guided, where we, by EUS, we choose the site where we inject the ferrofluid, and then we place the first magnet in the jejunum, inject the ferrofluid, and that ferrofluid will take the magnet with it, and then we will place the second magnet over that ferrofluid. So this is the safest way where we can avoid any structure coming in between the GJ. And we have one more case of bile duct. If you permit, we can show them with the. If you have any question?
Another question, Dr. Sanjay, is another contraindication for patient with pacemaker with magnet.
Contraindication mainly are pacemaker. If they have pacemaker or arrhythmias which require further treatment for cardiac or any coagulopathies. Otherwise, most of the time you can do this. In bile duct, you have to follow. In the bile duct case, you have to follow them up every 1 week, X-ray, and see them, the bile duct magnets for through 2 to 3 weeks. Most of the time, the bile duct magnet, they fall off.
So
if they do not follow,
Yeah, Dr. Sanjay, amazing presentation. Amazing.
Thank you,
cases.
thank you.
But I have
Simon.
to shift. Maybe I'll come back to you. I have to.
Yeah, sure. Till that time, we can be ready with the third case. Thank you. Sure. Thank you so much.
Nas Hospital with Professor Inouye Now
Yeah.
Professor Inoy is doing a case of anti-reflux. Can we shift to Al Nas Hospital?
Yes, hello, I'm Ahmed with you.
Ahmed.
Yes, doctor, I can hear you. Yes, okay, we'll start with this case. Okay, it's a 25-year-old male patient complaining of persistent heartburn and regurgitation of 4 years duration. EGD was done, revealed incompetent cardiac history and pangastritis. High-resolution manometry was normal according to Chicago 4 classification. The patient had 24-hour pH meter that revealed pathological acid reflux. As you can see here in the image, the gastric emptying scintigraphy done was normal. So this is a case of pathological GERD for endoscopic anti-reflux procedure by our dear Professor Inoy.
Slides are not moving. Okay, so
Gastric emptying scintigraphy.
yes, تمام. So this is an
Gastric emptying scintigraphy.
تمام. يعني هو patient 25-year-old with persistent GERD and manometry is good and this is important, scintigraphy is good and he has a pathological acid reflux. Can we shift to the endoscopy picture of Professor Inoy, please?
Hello.
Hello, Professor
Hello.
Inoy. How are you?
Can you see us?
Yes, we can see you.
Can you hear us? And you can hear also?
Yes, we can see you and we can hear you.
Yeah, great.
So, yeah. This is a case of a typical NARD, non-erosive reflux disease. So this is the patient's distal esophagus. You can see no erosion, no erosion. It looks almost normal. And then, so this is the proximal end of the gastric port. Now I switching to MDI. So you can recognize the squamous-columnar junction quite well. And then, this case, the proximal end of the gastric pole is almost equal to the position of a squamous-columnar junction. Anyway, so no esophageal erosion, so this is a case of a NERD. Then, so we are getting a stomach and then try to keep a little flex. But like this, we cannot see the squamous-columnar junction. We cannot see the esophagogastric junction well. Then we give a more undulation to the scope. So please.
Can you point camera here, please? ممكن تجيب الكاميرا?
Yeah. Later.
So Professor Inoy, would you explain why you put this snare over the scope before going inside for audience?
Yeah, that's right. So to support the further undulation, we place the this is the snare outside the scope, and then grab the tip of the scope, and then
camera.
Yeah.
Yes.
Grab the scope and then pull it close to the target.
So simply to increase the angle of
Yeah, that's right.
Yes.
That's right.
Okay.
Up angle, increasing up angle. Then we can see the junction like this. So once again, without the angulation, without the angle booster, it's impossible to see. This is the maximum.
Yes,
up
maximum
angle.
up.
And then wait a moment. Left and right, we cannot see the junction
There.
well. Yeah.
Even performing maximum right and or left with maximum up.
Yeah. Then, so I request the Mayo-san to
Yes,
do
yes,
the
yes.
angle booster.
It's
and
very
then,
clear.
Yeah, we can approach the junction well.
Yes.
So in this case, in the MDI, you can see a squamous-columnar junction is exposed to the stomach. So of course, you know, squamous-columnar junction, squamous epithelium is an esophagus. So this case, the distal end of the esophagus is exposed to the gastric fundus. So in a greater curve side as well. So usually we cannot observe the squamous, but in this case, we can see squamous epithelium circumferentially. And then now I touch the insufflation button, then the patient has a burping. So that means the patient easy to burp. That means potential acid reflux happening.
Yeah.
That is a mechanism of the nerve. So anyway, this case, we carefully check it. Then you can see greater curve side gastric fold. This one, gastric fold,
Yes.
you may see well. The gastric fold is made of the clustering muscle behind the mucosa. There is the clustering muscle. Then this case is a clustering muscle is free open. So it's very difficult to perform the anti-reflux mucosoplasty. So I think this case, it's better to do the mucosal resection arms procedure.
But if you are seeing that this a wide opening like health tree, would
that's right.
be benefit from RMB, anti-reflux mucosoplasty.
Yeah, that's right.
So I think we have to spend sufficient time to take a decision, as you did, sir, to see the all squamocolumnar epithelium from on retroflexion and looking for the crust on both sides.
Yeah, that's
Yes.
right. That's right.
شربيني
Then
شربيني
Yes.
section needle free.
شربيني ممكن
صح.
تشرح للناس البلان بتاعته ايه؟
طيب هو بالعربي يعني؟ طيب هو first of all our patient is intubated in general anesthesia on left lateral position. Then Professor Inouye after that put a snare. طيب عربي ماشي. هو في الاول المريض نايم على جنبه الشمال، وبعدين هو حط سنير في الاول بره اوتسايد ذا سكوب على التب وعمل انجوليشن عشان يميك شور ان الزاويه احنا كلنا عارفينها الاب 210 هو دي هتديله مور اب علشان يقدر يشتغل على الليسر كيرف. تقييم الحاله ووضعها هنختار انهي بروسيجر. احنا عارفين بروفيسور انوي the inventor of most of anti-reflux procedure starting from anti-reflux mucosal ablation ARMA ودي very common في مصر، وبالاضافه للارمز بيفور anti-reflux ميكوزيكتومي، وهو كمان اضاف anti-reflux ميكوزوبلاستي اللي هو بعد ما بيعمل ميكوزيكتومي يعمل بلاستي يقفل البيت بكليبس، وكمان بيعمل حاجه اسمها انتي-ريفلكس ميكوزوبلاستي ويز فالف. طيب هو التقييم هنا هو شايف ان دي هيل 2 اتس نوت هيل 3، وشايف ان الكراس تحت الميكوزا ستيل بريزيرفنج، فهو ميكوزوبلاستي او ميكوزيكتومي is sufficient for the patient no need for ميكوزوبلاستي. يعني بعد ما هنعمل EMR على الليسر كيرف it's sufficient، هيسيب الاريا رو لما يحصل هيلينج فايبروزس ده هيبقى كافي لهذا المريض. لكن لو كان الاوبننج فيري وايد وكان اكتر وبدانا ندخل في هيل 3 وبدا يبقى فيه لينس نوت هايتس هيرنيا بالهيل 4، يبقى ساعتها الكراس ده ضعيف، يبقى هو عايز يعمل ميكوزال فالف او عايز يعمل نيو فالف. هو هنا نو نيد فور فالف، جاست ميكوزيكتومي EMR على الليسر كيس زي ما احنا شايفين. هنا he did injection on the lesser curve and using CAB assisted EMR. So it's a dedicated CAB with dedicated snare for CAB assisted EMR, not a regular CAB or regular endoscopic procedure, even snare. فنلاحظ هنا ان الكاب نفسه بعد الانجكشن لما بيدخل السنير بيبقى coapted inside the cab itself.
السنير اللي بيستخدمه ده شربيني شكله غريب شويه، ممكن تقول لنا ايه نوع السنير ده؟
Yes. This snare, give me the paper بعد إذنك. This a dedicated snare, this from Olympus core snare master. So it's like a hexagonal. Yes, it's not an oval as we can see here as different shape.
كبر سير
Okay. هو ده 25 مللي 25 مللي، وهنلاقي فيه زي نوتش. النوتش دي اللي بتسمح ان السنير زي ما احنا شايفين لو شايفه صوره المنظار ان السنير يدخل جوه الكاب كويس. فهو ديديكيتد سنير اتس فروم اولمبس سنير ماستر، مقاسه 25 مللي وفي النوتش اللي موجوده، والثيكنس بتاع الفيلامنت بتاعه 0.3 ملم.
Oh wow. So this snare is only available.
So now we did a good catch. Yes. So as we can see, after performing injection, he did a good catch. Then after that, mucosectomy. So it will go, you will go for one piece or more than one piece?
Yeah, no. So many pieces.
Many pieces.
Okay. Leading sango.
Yes.
Oh.
اول قطعه بناخدها بالكاب وبنطلع بيها بره وبعدين ندخل تاني نعمل اسسمنت. هو هيعمل ميكوزيكتومي على الليسر كيرف كله، يعني مش هيعمل حته صغيره على الليسر كيرف كله عشان يسيب رو اريا كبيره لما يحصل هيلينج تبدا تضيق الفالف تاني او الاوبننج بتاع الاسوفاجو كولامينار ابيثيليوم.
في سؤال، حد يدي مايك لدكتور محمد الغباري يا جماعه. في سؤال بيسأل مقاطعنا. There is a question from the floor that do we expect bleeding here in this area?
The question about bleeding in this area.
Yeah. If we encounter bleeding,
yes.
So we will make a...
As you can see, Shaima, we have a minimal bleeding in the submucosa, and if we encounter bleeding, we will manage bleeding accordingly.
طب واحنا مش ممكن نعمل كاب assisted EMR عادي يا شربيني او ligation assisted EMR if the snare is not available?
If there is a question, sir, from floor, if we don't have this dedicated snare and cap, can we perform mucosectomy using ligation assisted?
Yes, it's okay. A ligation assisted mucosectomy is okay. Any procedure we can accept. So ESD as well, but CAP-EMR is faster.
Yes.
At Lavavand, EVL assisted mucosectomy is also good, but the specimen is not so big.
Yes.
So resection area is limited. So I think CAP-EMR is much faster.
Okay. So you started by the central part, then going to right and left after that.
Yeah, that's right there. Okay.
زي ما احنا شايفين يا شيماء، هو السنير الاول بيتحط انت لو جربت سنير عادي هو مش هيدخل جوه الكاب بهذه الطريقه. هو اما بيحط السنير النوتش دي بترشق جوه الكاب وبعدين هو بيبدا يعمل جيجرنج لحد ما السنير ياخد الدايره كلها بتاعه الكاب، فهو كده يقدر يشت لانه عمل ريتروفليكشن فيبدا كده ياخد جود كاتش باي بيرفورمينج سكشن وهو عامل جود انجكشن. هو ناو هي ديد ا جود كاتش زي ما احنا شايفين ان احنا على اليمين الجزء اللي اتعمل ميكوزيكتومي وفي النص الجزء اللي هو ماسكه دلوقتي. then again another piece from the lesser care.
Yeah, that's right. Okay, Lili Sango.
ممكن لما يخرج بالمنظار تورينا الفكره بتاعت السنير يا شربيني لما يخرج كده؟
Can we show, excuse me sir, can we show them the yes. Can you clean
ركز على ايه الدكتور شربيني؟ على المنظار من بره. هو سنير شكله زي شربيني ولا هو نفسه برضو؟
هو عمل السنير بس فضى شيس تاني عشان يعمله.
Okay, I will show you the mechanism of yes. So angle, this is the maximum angle over up angle.
Yes.
Then so angle booster please. We can bend
clear شيماء؟
شايفاه اهو زي بالشريط لحام كده على التب بتاعت المنظار وعلى
بالظبط
كده.
He bought a snare from outside. Okay.
I lost one scope by this maneuver. I lost one scope by this maneuver. I did this before and I lost the light source. The light bundles by the snare when you are catching the tip of the scope and you grasp it. Force, Dr. Muhammad, sorry.
Sorry, Dr. Assam, this is a very good question, and I think a lot of doctors asked Professor Ono before about this question. Yes, Prof. Sir, there is a question about there is any hazard over the scope from this maneuver. They are worried about the company or doctors about the light source and bundles of the scope from this maneuver for this pen.
So you mean can damage?
Yes, can damage.
We do a couple of years, but we don't have any problem for the scope.
هو ما حصلش دامج يا دكتور عصام، فيعني ايه ممكن نعمل بس نبقى براحتنا شويه.
طيب هو
وعندهم مناظير ببلاش يا بيه.
طيب هو انت يا دكتور شربيني عشان فوجي دفع لك فبتبوظ مناظير اولمبس عادي كده؟
Okay, we will do like
ممكن
this.
باشا شربيني نستأذنكم نشفت على وهنرجع لكم على طول.
Yes please. Okay.
احنا هنكمل التو سيشنز مع بعض يا جماعه continuous and we will go to Greece. We have a very nice case from Dr. George Mavroginas. Is George with us?
Are you listening to us? We are live.
Hello.
Can you hear us?
Yes.
Hello. Thank you very much for the great honor. Here I am with Dr. Andreas Koutsoupas and Ioanna, my expert assistant. We have a 75-year-old lady. Please put the presentation slide. It's a 75-year-old lady with a small diverticulum, 2 or maximum 3 centimeters in size. And the plan is to do ZPOEM. I think ZPOEM is excellent for small diverticula because with standard septotomy, we cannot be very radical. Although, let's agree that all techniques work pretty much well, but now I will try to do ZPOEM, undersaline ZPOEM without tunneling. So please show the endoscopic image. Okay, can you see the patient case, the
yes.
Diverticulum? Okay, so this is the diverticulum. It's not too big, it's about 2 centimeters. And this is the esophageal side. I'm using undersaline. Why? It's not obligatory, but when you have minimum space in such patients, it can help you start the procedure. I have placed 2 small dots to guide me for the mucosal incision. I'm using a very slim endoscope, which is particularly useful for third space endoscopy. This is the 840 TP and flash knife. So what I'm going to do, I'm pressing Endocut U. I'm working under saline, and I will do a small incision, and I will try to inject with my knife. Right, so I'm doing the submucosal incision with my knife, you see. And now I start with endocut. I will do a short incision. It's not needed to do a very large one because I'm using a very narrow endoscope.
So you're using flush knife now from Fuji, right?
Flash knife, yes.
Flush knife 2 millimeter or?
1.5.
1.5, wow.
Yes, why? 2 millimeter will be faster, but if you use a knife with a short blade, you diminish the risk of mucosal injury. Now, my strategy is to make a short incision, expose the muscle, and now I have exposed the muscle, and I will not do tunnel. I will inject here at the diverticular side with my knife. I created a cushion. You see the cushion? And now I will inject from the esophageal side, and on the middle I have the septum. Now I can start. I'm doing the septotomy right now under saline. I expose the muscle fibers. The more we cut, the more space we will have. Now I switch to CO2. I inject again.
So this is very, very unique for you that you do the single tunnel. So you dissect and cut at the same time, George, right?
Yes. Yes, so I published this technique in endoscopy 3 years ago, and then we published our series comparing tunnel-free and standard technique, and we demonstrated that you gain about 10 to 15 minutes if you skip the tunnel.
طيب I will explain to the audience. احنا الزنكر diverticulum عندنا كذا طريقة لعلاجها بالزي بويم. لما بيبقى الدايفرتيكولر كبير ممكن نعمل tunnel on either side of the diverticuli so that I expose the whole septum and then I cut and then I close. جورج هنا بيعمل ايه؟ This is a small diverticuli فهو مش عايز يضيع وقت طويل في ان احنا نعمل tunnel
فبيعمل exposure. عشان كده مختار سكينة رفيعة قوي اللي هي 1.5. فتح بالراحة وبعدين he did dissection. هو عايز يحافظ على الميكوزا برضو فبيعمل dissection and he is cutting in the same time. Dissection and cutting of the septum in the same time. This is, we call it like tunnel free Z poem, and it's also it allows George, can you explain more now?
Yes. So a common question is how deep do we go? So the answer is that we go until at least until the bottom of the diverticulum. So from time to time we have to exit and see if the diverticulum collapses. So here is not collapsed yet. And we can also check from the esophageal side whether the discoloration goes deep enough. But the most important is to see that this muscle becomes thin. So it's not thin yet. So I suppose we have at least 1 more centimeter. This is the transition to the esophageal part of the muscle. I use Endocat EU because it works well under saline. This is the new current by Herbe. And usually we don't experience vessels, although now I use precise sec.
George, what scope are you using? You're using Fuji scope, right?
Yes. So you can see the type of the scope on the screen at the upper right side.
Which one, the 7 or the 8?
This is the 7.9 millimeter Fuji scope. It's called 840.
Oh,
this is a fantastic scope because it's therapeutic. You have a large channel, 3.2 channel, but it is very slim and it has also water jet. So I think this is a very attractive scope for third space endoscopy.
Yes. We were just speaking about the new scope from Fuji, about the outer diameter of 7.9 and still a therapeutic working channel. And I did the same case of Z-Poem before, and it was really amazing in the Z-Poem because the space is very narrow.
Very narrow, and the mucosal incision is very small.
I will come back to you. Can we go to Iraq, please, Sulaimaniya? We have left Hiwa for a lot of time. Iraq. العراق مشواره جاي يا دكتور هيوا.
Open the speaker. Yes. Do you hear it?
Hiwa, I have seen you by the way.
Yes. Do you hear us?
Yes, I can hear you. I can see you, and I guess you.
Yes. We make progress. Loud.
Yes, I've seen.
We make a progress. I will show you after this injection. I will show you what we did till now. Needle in. Needle out. So we make a C-shaped incision as previously you saw in the distal side and outside needle in. And we make a C-shaped incision in the proximal. And we make a tunnel. Needle out. Injection. So, okay, needle in. Yes. So you can see that this is the site of incision of the distal end, and we finished the other side, and we connected the tunnel together almost more than maybe 80% of the tunnel in the left side, gravity side. We have some bleeding. I will try to control it, and then the only part which is left this side, which is anti-gravity side. I will make another C-shaped incision, and I will finish the procedure.
Hiwa, I have seen you having a lot of bleeding in this case, and this is expected from a tumor in the rectum. Would you like to add some diluted adrenaline to the solution that you are using?
Although the question was not so clear, usually we don't put any adrenaline during the ESC procedure in the colorectal lesion. For upper GI tract, yes, we put some adrenaline, but in colorectal, we don't put any adrenaline. But because this patient is actually only light sedated patient, risky patient, so probably we face more bleeding during what we expect in patient intubated. So I will make another C-shaped incision in the counter side, and I will push the knife to be longer in order I want to see the margin better. and I will try to reach to this side, which is almost the cut of the end of my cut to this side.
Hiwa, can you show us the view on
And then I will make
on retroflexion?
Yes, yes, yeah. You want to see about retroflexion? Yes. You can see that on retroflexion, this side is completely finished. And you can see that I can see the other side of the lesion. Only this small part in the left side of my screen is left to be connected by the tunnel. But the right side is completely, almost completed, almost finished.
Very nice.
But you face a lot of bleeding. As I said, the lesion is very vascular. So I will try to finish some part of the left side by retroflexion, and I will make a trimming just in a forward view. My knife just below the mucosal flap, and I will make some trimming because this is a normal area. So I am not aware, I'm not afraid of cutting the muscle because I don't go deeper. And I am sure that the muscle is far away from my incision. This area is somewhat blind and there is some fibrosis. So I will try to make deeper cutting because I don't want to get any positive margin during my ESD dissection.
So Hiwa, you're doing an amazing job. I will come back to you. I have to go to Professor Inouye. Can we go to Professor?
Yes, yes. I hope I will finish within few minutes, inshallah.
I will go. I'll come back to you.
Okay, thank you so much.
You're doing an amazing job. A lot of bleeding. So Professor Inouye, Sherbini, we're back to you. And please, because
yes.
Olympus guys are crying here because of the snare attached to the
Yeah. So I hope you can see. So this is the distal esophagus. We have already resect the half of the caudal mucosa, but pointing.
لأن الصوت مالته ما يجي هنا. لا أعتقد هي ما تشتغل. إي والله.
شلون؟ إيه؟
اوكي.
بابا ربو إنوي يقول ادفع هيوا للإنوي بابا. إنوي مو ما يجي كل يوم.
Okay, so we have already reset this.
Don't worry, this bleeding is minor.
Yeah, but we have to reset this one as well. So please. So anytime when we perform the mucosectomy, so we have to inject. We repeat inject.
Yes.
In order to avoid the muscle involvement, needle out, injection please. And please confirm anytime the lifting of the mucosal surface like this. Okay. Okay, thank you. Then pass me the new snare. Okay. And then the technique to make a free looping is to block the outflow exit of the cap packed with a mucosa with a mild suction. Okay, like this way. Okay, wait a moment, please. Okay, snare open. Okay, then so snare wire is going around the ring. Okay, open. Okay. So slowly close. I think it's okay. So the 6 o'clock is wire is out of gutter, but no problem, I think. So please. Okay. Okay. Okay, close. Okay, then we can cut the mucosa like this. Then the electrocautery cut the mucosa, and we use a forced coagulation mode, so less bleeding we encounter. So this side almost good, looks good. So release angle, we repeat the procedure, and then anyway. Okay. So in this procedure, we have to place the 2/3 of circumference at least. So this patient is the junction is widely open, so we have to do it. Yeah, 3/4, almost nearly circumferential. Mucosal resection is necessary to control his reflux.
And the anesthesia after the procedure?
No, so we are placing the outside the junction.
Yeah.
So, go forward. Yeah.
So,
Okay.
Professor Inouye, so about closing the defect, are we going to close this defect? The bed?
No.
Just leave it?
So because so if the junction is not widely open, so then a small opening, so we can close a defect using the so-called arm key. But this case is fully open, so it's impossible to close. Okay.
As long as the muscle is intact, no need to close.
Yeah. Okay.
علشان بس
Okay, thank
كريم
you.
معلش ممكن او محمد يسألوا على الفرق ما بين الارمز and الRMB عشان for the audience, because this is really crucial, because I know that after the resection sometimes they use the pseudo art to close or to make like a wrap. Can you please explain, Karim or Muhammad, to the audience? Can you ask him?
Yeah. If the defect is small, so we can close it. I mean, at least at 1/3, but this patient is the squamous epithelium open to the stomach, so 360° circumferentially. So that means the junction is pretty open. So partial closure is not enough, not effective to this patient. So we have to place a very wide ulceration like this. Then, so in the healing process of this artificial ulcer, so junction became tight than before. So patient feels much better. Okay. Release a little bit. Okay, a little bit. Okay.
I think Shaima asking what's the difference between arms and RMB, when to use arms and when to use RMB.
Yeah, so it's difficult to talk. So I need a slide. Otherwise, it's difficult to talk. But anyway, so this case is a good for arms. Okay, open. Okay, like this. So smear wire is going around the ring. Okay, stop it. Okay. So then we approach to the target mucosa. Watch carefully. This one is the previous ulcer, and we can recognize the squamous epithelium as well. But anyway, so close. Okay, so we can get a big sample. So this side mucosal resection is impossible. The band ligation assisted mucosectomy. So anyway.
So, Professor Inouye, you're not planning to go circumferential EMR for this patient, right?
No, not a circumferential. So 3/4.
2/3 to 3/4 the circumference, not circumferential.
So I will come back to you. Can we shift back to Greece, to Athens, to see the zebra case? We'll come back to you. George, are you still with us? George, can you see us?
Yes, hello. Can you hear us?
Yes.
Yes. So we are at the end of the tunnel. Here, the muscle layer is very thin. This is the esophageal muscle, and you can see the extension. It took us 3-4 minutes to complete it because it's a small diverticulum.
And you're using ACI, George.
And now I'm using the ACI mode that illustrates the muscle layer very well. There are no remaining fibers.
Okay.
And now I will evaluate the depth in
George,
two more
can you
ways.
show the audience the ACI mode again, please? Can you show them?
Yes,
the
so this is a standard endoscopic view. And now I switch to ACI, it's more reddish. And we saw the blue very well and we identify the muscle very well. This is the standard mode, this is ACI mode. So the muscle becomes more white. This is the standard view, this is the ACI view. And the blue is Greek blue, Aegean blue, all right? Aegean blue, yeah.
Yes.
So
What is the
here,
limit for muscle cut, please? What is the limit?
Yes.
Your limit to cut muscle cut.
exactly.
Landmark for muscle cut.
So I extend 2 centimeters beyond the bottom of the diverticulum. So this is the bottom of the diverticulum, is already collapsed. And if I enter here, I'm much more deeper. And also from the esophageal side, we see that the extension of the tunnel is very deep. So now we will proceed to clipping. For me, this is the most difficult part of the procedure and the most important. We will start to place the first clip higher, here, close, but don't deploy. I want to check whether the lumen is still open, because one of my few, let's say, adverse events was closing the entrance to the esophagus. So I try to check if I'm well. Actually, now I realize that I can place it a little bit higher. Please open the clip. I will place it a little bit higher. Here, close here. Now I move my endoscope to see if I'm okay. Okay, please deploy.
So,
Can you clip?
what is the type of clip you're using?
This is a conventional clip, nothing special. A generic clip, nothing special. 11 millimeter clip with a not very long stem.
Does it make any difference if you start from the top end or the lower end?
Yes, I suggest you start from the top in order not to obscure the view for the subsequent clips. And I usually place 6, 7 clips. I'm very aggressive with the clips.
So
I never had a leak. Yes, please tell me.
So George, do you think that the opening over the tunnel has a lot of advantages because using the clip over the redundant mucosal fold can cause ischemia to the this
Yes.
redundant mucosal? Yes.
Yes, by placing the clips, you also destroy the mucosal flap. I would like to say that for diverticula more than 3 centimeters, nowadays, at the end of the procedure, I also do mucosal trimming. So I cut the mucosa for diverticula more than 3 centimeters.
Okay. Very, very nice demonstration, George. We will come back to you. I know that you have a lot of cases for us. So let's move.
I will complete this closure, and if you have time, I will start an ESD.
Yeah, sure.
Share with us.
Yes.
We'll see you later.
For your ESD, and we'll come back to you. Thank you a lot,
Right.
George. Thank you.
Right.
Very nice. Can we go to Al Nas Hospital, please? Room 2, Al Nas Hospital. Sherbini.
Yes.
Now on the screen.
شيماء.
خلاص ممكن نرجع لبروفيسور إينوي. ممكن نرجع يعني.
We're almost finished.
Can we go back to Professor Inouye?
A little bit.
Yes. Injection once again.
أيوة سيماء معاك.
Now on the screen.
Yes, Nas, we can
Same.
see you and we can hear you.
Okay, now I'd like show you the current situation. So hopefully you can see well. Wait a moment, I flash the lens. Okay. Then
So
angle.
I want to ask
Angle.
Professor Inouye a question about the use of other modalities like the Gerdix or the TIF in the management of reflux compared to the simple or maybe less cheap way in managing reflux. What do you think?
Yeah, so TIF is the best device. So TIF anti-reflux procedure is best. It's a depend. So this procedure is cheaper than the TIF. So that's the point. But theoretically, TIF is more reliable, I think. But this one is very simple, and with the natural heating process that makes a junction tight. Okay.
Professor, will we coagulate these blood vessels at the end of the procedure or just?
Yeah. I will coagulate at the very end of the procedure. Right? So we have to research some more mucosa. I think.
Karim, I will shift to another case from iScope. Can you shift to iScope, please?
بص يا عبير، حتى انا والدكتور فادة بنقول ممكن ندسكس خلاص، وحتى نبدا الايس دي لايف في دقيقتين. اي وبعد كده انا اطير وخلاص.
عايزين iScope يا جماعة. يا دكتورة جهاد.
انت كده دكتور. مع حضرتك
دكتورة
دكتور
جهاد, can you present the case?
Yes. Good afternoon. This is a case for endoscopic bariatric surgery. She's 64-year-old female patient, pre-post medical and surgical history with a BMI 46.8. The patient was classified as obese type 3 and was offered elective bariatric surgery, but she refused. Patient is for endomina by Dr. Adib.
طيب, Dr. Adib, welcome to Cairo. I've seen that you already deployed the device. You're in a hurry, but we are having a bariatric surgeon with us, Dr. Muhammad Dia. Can you please join us on the stage? Adib, مساء الخير.
Thank you, مساء النور دكتورة شيماء. Thank you everyone.
كنا عايزين نفهم الفكرة because this is could be the first bariatric procedure to be done live in our workshop. فكنا عايزين نفهم منك الفكرة بتاعت الاندومينا and how it's gonna be like effective in managing obesity. Welcome to Cairo first.
So thank you very much, Dr. Shaima. Thank you, Dr. Sherbini. Thank you for every one of the team here in the endoscopy with us in an iScope. It's a true honor and pleasure to present this case. Endomina is one of the actually very promising devices in full thickness plication of the stomach. And the idea behind is to approximate the lesser and the greater curvature safely under direct supervision using the tissue grasper with the endomina devices, taking a full thickness suturing from the lesser curvature toward the greater curvature and doing the suturing and closing the
معلش أديب احنا ممكن نخرج بالمنظار تاني ونشوف الديفايس. can we have
دكتورة شيماء.
دكتور معنا هنا. فيري جود.
ازيك يا دكتورة شيماء؟
ازيك عامل ايه؟ ممكن بس عشان نوري الاودينس الجهاز ممكن.
طيب احنا معانا ديفايس تاني ممكن نوريهم الديفايس.
اوكي.
انا بره ده الديفايس بتاع
ممكن الكاميرا تركز على ايد دكتور هاني يا جماعه؟ ايوه عايزين نفهم الفكره بس.
طيب ده الديفايس بتاع الاندومينا. احنا عندنا الهاندل دي فيها كنترولز الويل اللي موجوده في الديفايس will open and close the tooth like this. You can see. So we have this tooth. The wheel will open and close the tooth. Okay. We have this handle. We'll move the arm. You see this bending arm? It is clear. So we have opening and closing tooth and the bending arm through which the needle will move.
The bending arm will take actually the needle from the right handle arm toward the left, then back forward, taking the full thickness of the mucosa in one fold and transferring the other suture to the other fold and cinch both of them. This device is usually inserted over a metallic guide wire. Then, first of all, you do the full examination of the stomach and the duodenum to make sure that everything is fine. Then you go with the upper endoscopy at the guide wire, the stiff guide wire, metallic guide wire. Then you insert the device over the guide wire. Then you put the scope beside the device and we open the device. Then we insert the scope in between the right and left arm, preparing for the first suture to be taken, as I'm going to show you right now.
Okay, so we will see your first suture.
Exactly.
Yes, this is the suture. It can be inserted through the device through this opening. Can you see the suture?
أيوة شايفين يا هاني.
It has a handle on the tip. قرب القرن ده.
Now it's ready.
ماشي.
هو
Each suture will contain 2 tags to oppose the mucosa. It will move through this.
So the first tag will make a bend in the metallic object here that carries the needle, and now it's ready to pierce the tissue directly through the second arm, and then we deliver the first suture inside it, and it comes back to take the second one. So one suture will take 2 folds with us. I will show it to you right now.
Okay, ممكن نشوف بقى لايف الحالة.
So the scope in between the 2 arms of the endomena, and now we will start grafting the first tissue, and this is a tissue forceps open. The stomach should not be over-insufflated or desufflated. It has to be in the medium part. So this is the incisura. I'm starting just above the incisura closely. And now I'm taking the tissue.
So, so Adib, what you use here is a grasping forceps, not like a helix like the ESG.
Not the helix, not the helix. And now?
And you're sure that this is a full thickness bite or what?
Yes, 100% sure. It's 15 millimeter. And now, as you see in the screen, the needle is taking the first suture down. Yellow. Okay. This is the first suture. Now I'm gonna relieve a little bit, and you can see the full thickness that I've taken. As you see here, this is remove the. Open, please. Open the portrait.
We want the camera to focus on the hand of Ahmed Turki, please يا شباب. عايزين how he fires the suture.
So we fired the first tag.
Yes.
And now we have to transfer to the other. But give me part of the tissue, please. Okay. Okay. Good. I'm ready to take the second one right now. I will do some deflation in here. Open. Close. So now, Ahmed, please take the second tag. We need to make sure that we are not piercing the other part of the stomach. So yeah. Okay. Perfect. We can see obviously the other tag of the suture is coming out now, away from the. That's fine. Relieve. Okay. Open. Take the needle out. And as you see here, we make this to bridge, Dr. Shema, between the 2 folds, as you can see in the suture. Now I have to remove the scope. Open, please. And I'm gonna take. Give me the snare, please. Very simple, very straightforward, very easy, not complicated, clean field as you see. Yes.
So we are connecting the anterior to the posterior wall.
Exactly.
Yes. Then approximating the suture.
The two sutures.
Yes.
And you can tell from the bite that we are taking a full thickness.
Yes. Yes.
You see, this is the inlet and this is the outlet of the. Maybe you need just to lubricate a little bit. Okay. We need to hold the suture loop from the first bite that we've taken. So open gently, please. Not fully. Not fully. Sometimes it's a bit tricky. Yeah. So close a little bit. Okay. Yes, close. And now I grasp the whole tissue. So we will start pulling back and tightening the suture, as you can see here.
So Adib, this is continuous suturing or interrupted ones?
This is an interrupting suture, Dr. Shaima.
Yes. عشان بس احنا برضو لسه مش متخيلين الفكرة قوي. يمكن الناس كلها قاعدة مركزة جدا جدا عشان تتخيل الفكرة. أيوة.
Do you see it?
Yes.
This is the approximation that I'm talking about. We'll continue.
Dr. Shaima, I think this is like the Olympus overstitch gastroplasty device. بس في الأوليمبس overstitch كانت بتبقى continuous suturing. صح؟ كنت عايزة أسأل بقى دكتور أديب, do we need a prior marking لليو shaped area اللي احنا المفروض intending إن احنا نعملها approximation?
In the beginning of the learning curve, yeah, that's fine. You can do this, but the shape of the stomach is gonna be taking you in mapping the rest of the stomach. So for example, now I need to know that I have to take a suture that to close this defect here. So we're going to take the second suture.
أديب صوتك بعيد شوية. ممكن نقرب بس صوتك يقرب من المايك.
Okay, I need to take the second suture 2 centimeters proximal to the first one. So the first suture actually will decide where to go for the rest of the stomach mapping.
اوكي. هرد على سؤالك يا دكتورة نجلاء. قصدي الجهاز البوسطن بتاع اندوستيتش. طبعا احنا هنعرض الحلقة السيشن اللي جاية حلقة من أمريكا بالاندوستيتش من بوسطن so that we can see both modalities of bariatric. This is my first time to see Endomina, and then we're all waiting for the results. I'm not sure if there is comparative results or.
And now I finished the first suture and I have to cut it out.
هل في دكتورة جهاد انت كنت حاطة زي سلايد كده بصورة الجهاز بتاع الاندومينا ينفع توريه لنا عشان الناس بس تتخيل؟
طب ممكن نجيب الجهاز تاني؟ ممكن نجيب الجهاز تاني يا جماعة؟ أهو جهاز موجود معانا. الجهاز تاني يا دكتورة شيماء.
تمام.
ده الجهاز بتاع الاندومينا. احنا دخلنا الاول جايد واير.
As you see here, I've cut the suture already with the.
خلاص نشوف السوتشر الاول وبعدين نرجع نقول الجهاز تاني. هو استخدمنا دلوقتي لوب كاتر عشان نقطع السوتشر. اول سوتشر خدناه.
This is the picture from outside and this is my target. I want this is the area that the food will go through it and we will block all of this area. We will close all of this defect. Okay?
تمام. احنا هنرجع لكم تاني يا هاني but I have to shift to الناس hospital.
اوكي.
بروفيسور ممكن نرجع مستشفى الناس.
Hello, Shaimaa.
أيوة.
Can you see the endoscopy image?
Yes, I can see you and can hear you, Professor.
Okay.
Ahmed.
Yeah. This is the very end of the procedure. So we have already placed the 3/4 circumferential mucosal resection around the gastric cardia. The point is we have to preserve the greater curve side. Greater curve side mucosal fold, we have to preserve it. So if we place a circumferential, it's too much, too tight. Yeah. So, and then another point is you can see like this, and then so this angle, and then we are coming back to straight angle. Okay, straight view, then forward view. Then from esophageal side, this is the esophagus, and then advance the scope gradually, but we cannot see the ulceration. So this is a point. So the we can see a little bit, but anyway, so mostly we cannot observe the ulceration. So this means the patient has no stenosis after healing. So makes the junction tight. Okay. Then also angle please. Then so makes the mucosal flap valve, remaining mucosal flap valve become more sharp on the lobus. So this is a procedure. So arms, anti-reflux mucosectomy.
Yes.
Okay.
Very nice. Very nice. Very nice demonstration. So can we shift to Dr. Sherbini case, please?
Another.
Yes, Dr. Shaimaa, can you hear me?
Yes.
Okay, this is the second case now, the other room.
يلا يا حبيبي.
Very interesting. It's a 56-year-old male patient complaining of abdominal pain for 6 months. Upper endoscopy revealed duodenal subepithelial lesion with central amplification, 1.2 centimeter in diameter, that was biopsied, and the pathology came out as neuroendocrine tumor. Gallium ductate scan revealed duodenal bulb, avid polyp measuring 8 by 14 by 17 millimeter and achieving up to 6.6 SUV max. EUS was done, revealed submucosal mass in the bulb measuring 15 by 16 millimeter, thickness 7 millimeter, located in the third layer, the submucosal layer, while the muscularis propria is free. We'll shift now to Dr. Sherbini. Perform a ESD by Professor Sherbini, Professor Karim Assam, and Professor Al-Fadda.
So the decision is ESD or FTRD?
The decision is ESD.
شيماء
سامعاك.
شيماء
سامعاك كويس. So what
هي
is
قاعدة شيماء can you
سامعاك قول يا شربيني سامعينك.
وشايفانا طيب؟
كل حاجة.
Yeah, thank you. Yes, good evening again. Hopefully you are still ready and fresh. I'm happy to present this case with my brother and friend, Professor Abdurrahman Al-Fadda from Saudi Arabia, King Faisal Specialized Hospital. Also, Dr. Abdullah Tawil is standing here beside us for support. So as you hear the case from Dr. Ahmed, we went and did examination before life. Here, as we can see, after just passing the pyloric ring, as we can see here, we'll find at the anterior wall this subepithelial lesion. This subepithelial lesion, actually, the position is not such stable, and we have to assess using the different endoscopy. Fortunately, here I'm using Fuji-scope 700 series, 760 is a diagnostic scope supported by processor 7000. So this is the lesion, as we can see here. And as you can see, this may be a bulk lesion.
a thick lesion, subepithelial, because overlying mucosa, as we can see, is very nice, apart from some hyperemia in the middle. And here we can observe central depression. So this is the bulb anterior wall. So what do you think, Professor Fadda?
Yeah, so this is an interesting case because this patient is having probably larger than 1.5 really centimeter, what was mentioned in the endoscopic ultrasound, a lesion in the first part of the duodenum submucosal. And you can see there is an umbilicalization inside. So the top diagnosis in this case will be either GIST tumor that will arise mainly from the fourth layer of the lining of the duodenum, or it could be, which is rare but can happen, a pancreatic rest, when you have an ectopic pancreas going out to the duodenum and sometimes the stomach. But looking into the lesion, Hamad, I think it is really a lesion that measures more.
Yes.
So the question here, probably, are we going to do a full thickness or an ESD? Because probably I think it's thick a little bit, big really. Yeah.
Actually, Shema, before life, our plan, as we did it before, to remove this lesion by endoscopic full thickness resection device from Ovesco. But when we assess the lesion, me and Dr. Al-Fadda totally agree that this lesion, we think that it's more than 15 millimeter. So we tried the cap of Ovesco before, and we passed hardly from the upper esophageal sphincter, unless after going here and we try to assess the lesion using the cap of Ovesco, we found that the lesion couldn't be inside the cap. I think the first thing is it's more than 15. The second thing, maybe it's a bulk lesion.
Definitely, yeah. Such lesion, you might not have all the lesion coming in because
So
looking into
the decision is that you will go for ESD?
Yes, we think that this is a good decision because we think about if we bring another more large or wider Ovesco like for colonoscopy, it will not pass from the upper esophageal sphincter. Actually, we deflate the balloon of endotracheal, we put a patient in the left lateral position, and we bust very hardly using the regular upper FTRD device. So, do you have opinion, Abdullah, for that?
So, Sherbini, this is the very critical put.
I think, as was mentioned,
in the bulb of the device. So what is your plan? What is your strategy in such a critical lesion?
Actually, I think we have to go to ESD. After injecting water, we see that this lesion independent board. So I prefer, after performing injection, to start from the cecal side. We can inject from here and start to do a dissection from here. After that, after performing dissection from this side, we can go for some fraction technique. It could be use a clip and line for traction, or we can use clip and band and to put it on the other side. Because this independent part, as we can see here, water is accumulating with the gravity here.
Yeah, so the thing is that this lesion, as was clearly mentioned, is out of any kind of therapeutic intervention other than the ESD, given the size of the lesion. So doing a careful ESD, trying to restrict all the lesion would be probably the best kind of therapy in this patient.
I think the main question here about after finishing the lesion, usually you refer to close any mucosal defect, especially in the duodenum and such a precious area, and also sometimes you encounter some muscle injury, because most of literature recommend to go more deep over the muscle and don't go towards the submucosa to make a safety margin or artery resection.
Yes.
What do you think about closure after finishing?
I think if you have a good hemostasis and you don't have any bleeding blood vessels, and you are quite confident that the patient, that the procedure reached a good hemostasis, maybe probably applying a plurastat or something and keeping it open.
with a very close follow-up where the patient could be of help.
Okay.
I'm not too much into closing any duodenal
Sherbini.
leads, to be honest.
So Sherbini and
Yes.
Dr. Fadda, good luck with a very critical case, and please close. You have Mantis with you, so please close. And we will come back to you within a few minutes. Can we go to iScope to see the endomena, please?
يلا هات injector.
Can we go to iScope يا شباب?
So we are in the third suture, Dr. Shaima, right now.
Yes, yes, يا دكتور أديب. We have
We are
Dr.
finishing the
Mohammed
third-
Diya with us from surgery. Diya, do you have any comment? من غير خناق، بس من غير خناق.
لا لا الجراحين حبايبنا يا دكتورة شيماء، ما تزعلهمش مننا.
الجراحين احنا جايبين لك اشهر جراح في مصر بتاع بارياتري.
Open the forceps, close. احنا we don't compare apple to orange.
هو
There is no
الصوت بتاعك يا أديب بعيد شوية، ممكن يا جماعة حد يقرب المايك لدكتور أديب؟
طيب ممكن ننقل المايك الناحية التانية.
يعني يا دكتور اديني صوتك واضح وهو صوته مش واضح يعني.
احنا دكتور شيماء we don't compare apple to orange. يعني usually endoscopic sleeve gastroplasty is not the competitor of lap sleeve. What we do is just an alternative solution for patients who are not candidate for lap sleeve, or for patients who are willing to go for a minimally invasive procedure like endoscopic sleeve gastroplasty. Okay? You need to lubricate your. So as you see, we took almost like 5 to 10 millimeter away from the antrum, and as you see, this is the area we closed. This is only 3 sutures. Now I'm gonna cinch or close the third suture, the third suture. Open.
هي كل سوتشر يا دكتوره شيماء بتبقى بري لودد ويز 2 تاجز. احنا بنريليز ال 2 تاجز على الاوبن تولز.
تمام.
وبعدين
هسأل سؤال.
اتفضلي.
لما شفتكم اول سوتشر اتاخدت، حسيت زي ما يكون ان في جروف او ان في تانل هيتعمل بعد يعني في النص ما بينهم، بعد كده دلوقتي مش لاقياه، فانتوا السوتشر الثانيه خدتوها بحيث ان انتوا يعني تكولابس الحته دي، ولا عملتوا ايه؟
وده اللي كنت بقول عليه في الاول دكتوره شيماء، انه السكند suture is gonna follow the first one and the third one is gonna follow the second one. This is how the mapping of the stomach in gastroplasty works. So doing the marking, I guess it's not so practical in this procedure, because you don't want to lock your mind to the markers. You need just to follow what the stomach and the first suture or the second suture did in the stomach space.
Oh. So how many sutures do you usually perform, Dr. Adib?
It takes from 6, 7. Sometimes we go 8 sutures, depend on the size of the stomach.
7 to 8. معلش برضو الصوت رجع بعيد تاني، ممكن حد يساعده؟ ممكن حد يساعد دكتور أديب في الصوت؟
طيب هو دكتوره شيماء ودكتور اديب في الاول قاس المسافه ما بين الانسيزوره والكارديا.
تمام.
وحدد عدد السوتشر، تقريبا احنا بنسيب من 2 ل 3 سم بين كل سوتشر والثانيه. فحطينا المتوسط بتاعنا اللي احنا هناخده في الحاله دي بناء على المسافه دي.
تمام. طيب خلاص احنا ممكن نروح.
طيب دكتوره شيماء اقول لك كومنت
هنا.
طيب عشان اولا انا يعني سعيد جدا موجود النهارده ومتشكر على الدعوه الكريمه من دكتوره شيماء ودكتور شربيني، عشان خاطر اخواتنا هنا في تخصص الاندوسكوبي الاندوسكوبيك بارياتريك بروسيجرز. دلوقتي حاجه بروميسنج عشان الناس تعرف المستقبل بتاعها عامل ازاي. حاجه بروميسنج. احنا دلوقتي بنشوف ان في وسائل متعدده جدا للويت لوس، وما ينفعش ان احنا نقفل دماغنا ان هو بس البارياتريك سيرجري هو الحاجه الوحيده اللي بنعمل فيها ويت لوس، لان في دلوقتي الميديكيشن ريسبكت ان هي دلوقتي واخده بارت كبير من وسائل انقاص الوزن. ونفس القصه ان شاء الله دلوقتي او في المستقبل كمان في الاندوسكوبيك بارياتريك بروسيجرز. لو احنا هنقارن دلوقتي الاندومينا او الاوفر ستيتش او البوز، الثلاثه تقريبا بعد سنه بينزلوا حوالي 15% من التوتال ويت لوس. البارياتريك بروسيجر زي السليف بتنزل حوالي 30% من التوتال ويت لوس، والباي باس بتنزل حوالي 35 من التوتال ويت لوس. فعشان كده اول كومنت واول نصيحه لزمايلي في الاندوسكوبيك بارياتريك بروسيجرز ان هم يختاروا البيشنت بتاعهم صح. الايديال بيشنت للاندوسكوبيك بارياتريك بروسيجرز ممكن يكون البي ام اي من 30 الى 35. ده يكون بي ام اي مناسب ويخلي البيشنت يحس بفرق في النزول بتاعه. النقطة الثانية اللي عايز أقولها الريفيجنز بتاعت أو المستقبل بتاع الاندوسكوبيك بارياتريك بروسيجرز. أنا عملت حوالي 4 حالات ريفيجن، واحدة بعد اندومينا وواحدة بعد البوستون ساينتفك اوفر ستيتش ديفايس، كلهم كانوا ويت ريجين، وعملناها كومبايند بروسيجر ما بين الاندوسكوبي والبارياتريك سيرجري. يعني زمايلنا دكاترة الاندوسكوبي دخلوا بالاندوسكوب مكان البوجي أو الكاليبريشن تيوب بتاعنا، وشافوا من جوه وبقوا هما كاليبريشن تيوب وشغالين في نفس الوقت سيمالتينيوس اندوسكوبيكلي ولاباروسكوبيكلي. التعليق اللي انا شفته سواء في الاندومينا او في الاوفر ستيتش ان بيحصل بعد سنه لوزنينج اوف ذيس ستيتشز. يعني احنا شايفين دلوقتي الستيتشز ار فيري تايت وكويسه جدا، مع الوقت والاكل والمانيبيوليشن بيحصل لوزنينج للستيتشز. وعشان كده بعد 5 سنين النتائج بتقل تقريبا ل 12% توتال ويت لوس بعد الاوفر ستيتش. الاندومينا لسه ما فيش نتائج بعد 5 سنين منشوره، بس اللي منشور في الاوفر ستيتش تقريبا 12% توتال ويت لوس. ملخص الكلام اتس يعني بروميسنج بروسيجر لو اتعملت للبي ام اي الصحيح، ولو هم كبقى ديفايس الشركات سواء اندومينا او بوز او اوفر ستيتش لقوا طريقه ان هم يقللوا موضوع للوزنينج اوف ذا ستيتشز، هتبقى جايبه better results on the long term.
Thank you Dr. Dia for the comment. This is really very valuable. أنا عندي بس تعقيبين. أول حاجة الستاديز اللي طالعة الجديدة if we combine GLP-1s مع الاندوسكوبيك النتائج دي أول حاجة. تاني حاجة أنت أكيد برضو عندك حالات ريكورنس، فهل حالات الريكورنس دي أو حالات اللي بترجع تريجين ويت هل ممكن يبقى الاندوسكوبي ساعتها مفيد بدل ما اضطر اعمل جراحه تاني؟
السؤال رائع طبعا يا دكتوره شيماء. كالعاده اتعمل بعض الاستاديز بعد الباي باس، لان واحده من اسباب زياده الوزن بعد الباي باس هو اتساع الجاستروجيجينال انستموزس. فاتعمل بعض الاستاديز على ان احنا نرجع نضيق تاني الانستموزس ان هي تبقى حوالي 1 أو 1.5 سم، بس كانت نزول الوزن بعد كده كانت الريزلتس مش يعني مش احسن حاجه. الاندوسكوبيك يعني الريكارنس بعد ما اتعملش بعديها ستاديز ان يتعمل اندوسكوبيك
لا ويت
بعديها لسبب لان معظم الناس اللي بتزيد بعد السليف مش بتزيد عشان خاطر الكوتش بتاعتهم بتزيد جدا، بيزيد عشان هم مينلي سويت ايترز. وعشان كده مش يعني ستيل البيشنت اللي بقى له 10 سنين عامل سليف وتساليه وزاد جامد، انت تساليه انت هل اكلتك زادت؟ لا اكلتي لسه قليله بس انا بقيت مستريح للسويتس، وهو ده سبب زياده الوزن. بس خلينا نقر ان في المستقبل لازم نكون كلنا موافقين ونشتغل مع بعض ان في وسائل متعدده عشان البيشنتس يكون عنده فرايتس، بس المهم اختيار البيشنتس الصح. وطبعا الكومباينيشن ما بين الجي ال بي 1 انالوجز والاندوسكوبيك ابليكيشنز عموما بيدي definitely يعني boosting للريزلتس.
I totally agree.
دكتورة شيماء أنا I echo كل اللي اتقال بالنسبة للweight recurrence. Recurrence it's mentioned in the record of lap sleeve, gastric bypass, endoscopic sleeve gastroplasty. So again, what we offer to our patients is multi collection of let's say options that offer them the surgical option after the endoscopic sleeve gastroplasty and vice versa. We've done a lot of sleeve and sleeve stomach. We've done a lot cases of TORI, which is transoral reduction of the pouch and the gastroduodenal anastomosis. So the idea is that we don't compete with bariatric surgeons. We complete each other for patient services and better patient selection. Of course, endoscopic sleeve gastroplasty, the key of its success is based on the patient selection. For patients who underwent surgical intervention, I guess it's from the fairness is to offer them the endoscopic sleeve option, because definitely, and I think most of the surgeon would echo me on this, they don't want to go inside the abdomen again after a gastric bypass operation or a patient who was morbidly obese and underwent the lap sleeve with a lot of adhesions and the risk of doing another lap sleeve and a sleeve stomach and the complication that could carry huge consequences. So endoscopic option should be always in our mind, and also for the surgeon. And this procedure is not locked only for gastroenterologists. A lot of surgeons, they are pioneers in this types of intervention, and actually I would recommend to train them as we are thinking of training the gastroenterologist on doing any weight reduction surgeries.
أديب ده نفس الكلام اللي قاله لسه بيقوله دكتور ضياء. We totally agree, خصوصا إن obesity is a chronic disease, so we have to put pressures here, not here. طيب we have to shift. I'm sorry, I want to go back to هيوا. بس ولا هيوا؟ هيوا بس نوري الليجن باد، بس نوري الليجن باد وبعد كده هنروح لتونس على طول. دكتور هيوا.
Right, open.
Hiwa, can you show us the bed and the bloody procedure that you have been doing?
Dr. Shaima, do you hear us?
Yes. Wow, amazing.
Okay. This is the sample on the outside. We are, see the sample, we completed the procedure almost about 6 centimeters.
Wow.
So it is very, very essential after ESD to see the sample from the outside and to correlate your optical diagnosis from a definite pathological diagnosis. And usually we mark from the anal and oral side. In this area, you can see there is some suspicious area of JNA2B or 3. So we hope that the result of the ESD is envelope R0 resection and complete curative resection, which we hope.
Thank you. Hiwa, congratulations.
And if you go to the MBI, you can see still there is no any
can we see the
suspicious. We have a good margin. Almost you have about 5 millimeter margin. And this is essential to send the specimen in this way for the pathologist, because once the sample dry and later expansion of the sample will be very difficult on the plate if you don't make it yearly.
Thank you, Hiwa. It was a very tough case. Congratulations. Can we see the beds before we leave you?
Okay, okay. I will show you the bed of the patient is awake. He's talking with us now.
Oh,
Dr. Shaima, I want to ask a question.
So I applied some clips because of bleeding. There was no any area of perforation, but in this area, because of muscle retraction, which I show you before I completed the procedure. So I did some muscle injury, because in order to get complete resection, because this patient is 81 years old, male, risky patient, so we cannot do any surgery, even if the margin is positive. So you can see that the bed of the lesion is completely clear. There is no any visible perforation to us. I don't know what's your opinion, Dr. Shaima.
Question from Dr. Nagla.
Congratulations, Dr. Hiwa, for the nice work and the
I'm-
amazing part about the live transmission to show the young generation that bleeding does happen. It's how we deal with it. So thank you. But I want to ask, are you using a gastroscope? Is it a gastroscope?
Yes, I use therapeutic gastroscope from Olympus, GIF S290T. This is a therapeutic scope with working channel 3.2. This is an amazing scope because this is not a 4K scope, but it is a high definition scope. It is very good working channel come at around 6 to 7 o'clock. And with 3.2 working channel make the job very easy. We can do the same on the same time, dissection and suction. So face accumulation of the fluid or distension of the bowel lumen during the procedure.
Okay, thank you.
What do you think, Dr. Mohammed?
Thank
Good,
you.
yes.
Thank you so much. Can we shift to Tunis now, please?
Thank you. We hope to see you again. Thank you for
Thank
this
you.
opportunity,
Thank you
Dr.
so much.
Shaima.
Thank you.
Dr. Mohammed, bye-bye and see you soon.
Dr. Sami. Dr. Sami.
Alhamdulillah, دستان خوش.
Dr. Sami. تونس يا جماعة. لو تونس مش جاهزة ممكن نروح لآيس كوب تاني. طيب يلا. ممكن نشوف تونس يلا. دكتور سامي.
You hear me? Hello.
Dr. Sami?
Yeah, I hear you, Shaima.
Yes.
But I need to share my screen. Fine, and you?
Yes. Can we see you? We can
Need to share my screen. They give me access to the sharing.
ممكن تدوا له شير سكرين يا جماعة بعد إذنكم؟
Still don't have access to share my screen.
شايفينه we hear you but we cannot see you.
Because I don't have access to share. I asked for sharing now.
ممكن حد يديله access يشير؟
Hello, Dr.
Hello.
Saima. Dr. Saima, can you hear us?
Yes, Dr. Sanjay, but we are just we are with Tunis now.
Yeah, we just want to thank you for all the opportunity and everything you have given to us. We have finished the second case also. So I would like to thank Ahmed and Cairo Live Endoscopy for giving us this opportunity. Thank you so much and would like to see you again.
Thank you.
Thank you
so
very much.
Thank you. Thank you so much.
Bye. Bye.
طيب الزي بوينت لا يونان خلص خلاص. طب في مشكلة في تونس يا دالاس؟ ايه؟
It's okay, Shaima. Just 1 minute, Shaima.
طيب.
You hear me, Shaima?
We can hear you but we cannot see you.
You will see me. Just wait a little bit.
احنا
You will see me.
تونس.
Oh, better. It's okay, so.
طيب تمام.
So you see me now?
Yes, now I can.
Shaima.
أهلا.
Good morning, everyone.
Comment ça va?
أهلا. Très, très bien. So I want to thank all my friends Shaima, Sherbini, and all the other for this opportunity to be with you today. The case we will broadcast is a 27 years old woman with type 2 achalasia. So what I will try to show today is the sight technique in POM. So what we use devices, it will be the Olympus 1100, which is 8.9 millimeter diameter. We will use the ST Wood cap from Fuji. The injection needle will be from Boston Scientific. And I have the choice between two knives, the Fuji flash knife, 1.5 ball type, or maybe the gold knife from Microtech, the T-type 2 millimeter. And for the closure of the defect of the entrance, we will use the Locado from Microtech. So our setting will be only one setting. Don't change anything. It will be the undercut eye, effect 1, duration 4, interval 1. And for the, will be for the mucosectomy and for incision of the muscle. And for the tunneling, it will be the Swift Coac 2.5. I don't still have the option, the upper grade of the AirB for the undercut U. So hope next month we will get it. So just because before beginning, I want just to explain why I have the choice between these two knives. So if you see in the left the Fuji flush knife, and we see that the injection is going around the needle. So this will help to give the sink effect on the ball. So the heat will be just located around the ball. But for the other knife, which is the injection go through the needle, the water will go in front of the ball, not all around it. So my purpose today is to show how we can control the vessel by the freeze effect before cutting. Today in 2026, I think we have to avoid bleeding, not control them. So as I will show, I can see the vessel, control it, and then cut it. So before beginning, I just want to show to everyone something we don't always show is the setup of the room. So the first thing we will do today in the sight technique, I will show you that if you see here, the pump, the CO2 pump is closed. I don't have CO2, so I will work only with saline, okay? So I put my screen just in face of me. I have my screen, and if you see, this is the head of the woman, so I will be just in front of my screen. Second, you have to control your pump, so I don't put maximum irrigation. I don't want to have a lot of saline inside the tunnel. And the other thing, I have also to control my AirB here, so it's really facing me. So everything is near me that I can control everything. Of course, we see the devices here. The other thing is important for me is the color of the saline I will put. So we have at the left, the blue dark one, but I usually for sight, I use this blue, we said azure or like a sky, blue sky, okay? So this is our flash knife from Fuji. We have the other choice of the Microtech here. And of course, we can't do any ESD or any third space endoscopy without having a coagulation forceps here. We may use it, but I hope don't use it today. So we'll begin now our procedure. So we didn't do anything. We cleaned a little bit our esophagus. So I will show you the difference, really, the difference between working under CO2 and working under saline. I will clean a little bit. We are at 30 centimeters now. The cardia is 40. So as we said, I don't have any CO2 working now. And you see the water is going in, and this is my cardia. We see the aspect that we call the rosette aspect here, the cardia. We are at 3940. And we will switch slowly. We will pull back our scope. I will choose at 30 centimeter the beginning of the tunnel. And you see how beautiful the picture are. This is the side effect, the magnification with the saline. We see the vessel, and I think we will begin here our injection. And I just want to show what we can do with Olympus, the X1 series, that we can switch to the TXE mode, and we have more vessel visible. So we will inject, we'll just inject the ampere شوية, and you see just some blue liquid, and really it's almost white, not blue. So with the TXE mode, I can see my vessel, so I won't hurt any vessel, so I will just insert my needle here a little bit, injector, and I'm pulling back my needle, and you see my bubble coming. So I don't need a lot of injection as before, the 4 or 5 cc. Even 1 or 2 are enough, because I will use my saline, my side technique. So we have, so the other thing that we can really help with the site, is think about physics here. We have pressure inside our esophagus. So the pressure of the water is superior to the pressure of the little vessels. So we can, even if we have bleeding, with some water injection, we can stop it, because it's question of pressure here. So we are using ST wood cap, so I will make a little incision, and you see how beautiful are these vessels there. So of course, the problem always is to catch the bubble of air, of CO2 here. So I will just suck and come back to my injection here. We are almost here. So I use the 1.5 millimeter. It's just enough for me. I need to control the vessel then. So my paddle, so I will begin our mucosal incision. And I will just put a little bit. And you see how I can see my mucosa here. Just I will change a little bit my setup here. Sorry, one moment.
So Sami, I want to ask you about what do you think of the add-on benefit of doing underwater poem or side poem if we compare it to the classic poem that we all know?
So first of all, I don't care about the CO2. Usually we try to see the pressure of the CO2. Here, I don't have this problem. I'm not using CO2. Second, you will see the demonstration of the entrance to the tunnel. I put now maybe 8 millimeter opening. I will make it maybe 1 centimeter. And I don't need any trimming here, because my pressure of the water here will just open the space, as you see. And you see that little vessel, Shaima. Now, injector. I will inject some blue, and look what happened here. Injector. This is what we call the freeze effect here. I can do my freeze effect with the injection through the needle or my pump. So this is what helps. I'm pretty sure I won't have any big bleeding here. Injector. And if I need to enter now my tunnel, I have my pressure of the water or the saline here. I put some saline, and you see, I didn't make a big opening. And this is help the entrance. So if your question is what will help here, I don't need a large size to enter there. So until now, I have my entrance here. I will just rotate a little bit and we'll be inside my tunnel here. Inject here. Inject it.
Sami, can we just shift for a few seconds to
Yes, of course,
greet
of
them
course.
back to you? ممكن نروح
Okay,
للبداية
okay.
شباب؟
نمشي شوية.
Valemas online.
Presentation.
George,
Hello there.
hello.
Can you hear us?
Inject here.
We want to see you.
All right. So do you see us?
Not yet.
Not yet.
Now we can see you.
All right, perfect. So this is a 2-centimeter rectal lesion. We have done the circumferential incision to gain some time. And I will show you my current strategy for most colon ESD. So I'm not in favor of one single technique. I like to combine everything. So my strategy for small or medium-sized lesions is to do circumferential ESD, under saline, and clip and band traction. So I have already placed a clip. Don't place traction before doing circumferential incision. So this is crucial. I will now open, please, the clip. Yes. I will grasp the band. All right. And now I will attach the band distally or more proximally. Please open the clip. All right. And please close the clip. Okay, fire. All right. So now the submucosal space is exposed, but this can also be dangerous because you may induce muscle retraction sign by this technique. So in my early days, I remember cutting the muscle due to excessive traction. Please give me the knife.
George, what is the mood you're using? Is it a white light or what mood? Because
now I'm using LCI.
Can we go to
and
white
now
light?
I will.
Yes.
So this is a white light.
This is white light.
And yes, this is white light. And what Fuji recommends for this part of the procedure is their new light ACI, in order to illustrate better the blue and the muscle. So now you see the blue is more blue than usually. And I will inject with my flash knife now. A key point for third space endoscopy, in my humble opinion, is to have 2 pumps. One for the knife and one for your endoscope. So look here. Here the clip is attached, needle out. The knife is attached to the submucosa. I will expand it and cut below in endocut mode. Once I cut just below the clip, the traction will be even more effective. I use alternatively my water pump and my pump connected to my flash knife. And in case of bubbles, I flash. My current setting is endocut U. And as a coagulation current, I'm in spray, but spray does not work very well underwater. So in case I encounter any bleeding, I will switch to CO2. For example, here, I press CO2, the water is gone. I will destroy these vessels with a very strong mode spray. You see? My settings for spray in the value of 3 is 4.0. So this is a very aggressive current. You have to be very cautious when you use it, but you can go really fast and spare the need for coagrasper.
So George, this is really an interesting approach because some experts tend to do the coagulation underwater while the dissection with the CO2. Are you doing?
I strongly disagree. Of course, there's no one single truth. It's like religion. Because a coagulation current under CO2 is very, very effective. My ideal coagulation current is spray. It's very strong, very fast. You see how fast I can move. And this current, if I put water, it does not work very well. So maybe Herbe will discover a blue current that works well underwater with no many bubbles. But we cannot go faster than this underwater. So when we use underwater techniques, we slow down our procedure.
Really? I think
in,
we're testing the procedures.
You think you go faster?
Yes.
Okay. Look, for a colon, I use only under saline because it protects me against muscle injury. But for rectum, I don't use it
Rectum
very
is a
often.
little bit difficult for underwater, yes.
So look at the
very
look
nice
the
demonstration.
Look the anatomy here. So in ACI mode, the muscle is here, and my line of dissection is here. So here starts the submucosa and it goes up to here, but there is no reason to go so deep. This is not a malignant lesion. It has high-grade dysplasia. I will work at the middle.
So I will go to our bariatric case, and because they finished, I'll come back to you, George. Just wait for us.
Right. Thanks.
Okay, ممكن نروح اي سكوب يا شباب؟ اي سكوب.
Dr. Shema, now we are almost done here.
Yes.
We're putting the last suture, as you can see
Good
here.
to see you. So Dr. Adib, can you show us?
Yeah. So this is the GE junction, as you see, and you're going down here. We are almost closed like 60% of the stomach body, and this is the antrum here. As you see, we approximate the anterior wall to the posterior wall, and this is the last suture I'm gonna cinch.
So I believe, Adib, that the main difference between the endoscopy and the surgery is that we leave the fundus, right? Right, Dr. Dia?
True. Open.
So, Dr. Dia, we believe that the main difference between the endoscopy and surgery is that in endoscopy, we don't pallicate the fundus. We leave the fundus as it is.
Okay. I just asked Dr. Dion that there is a gastroplasty laparoscopic. What do you think the difference between the laparoscopic plication and the endoscopic one?
يعني very good question. واظن ان دي حاجه مهمه ان انتوا تعرفوا الريزلتس بتاعت اللاباروسكوبيك بلايكيشن، لان دي حاجه اتعملت من اكتر من 10 سنين وبنفس الفكره تقريبا. الفكره ان دي external بلايكيشن ودي internal بلايكيشن او endoscopic بلايكيشن. الجاستريك بلايكيشن انا شفت طبعا التكنيك ده وشفت التكنيك ده. اللاباروسكوبيك بلايكيشن اللي هي بتكون من بره على الجريتر كيرفتشر، الفرق ان احنا بنعملها طبعا فول ثيكنس بس كذا لاير، مش لاير واحده. اولا بتكون كونتينيوس من اول المعده من عند الجاستروسوفيجيال جانكشن لحد تقريبا 3 أو 4 سنتيمتر قبل البايلورس. ورقم 2 بنعمل لها كمان لاير ثانيه فوقيها عشان احنا عارفين ان بيحصل لوزنج للستitch. ومع ذلك للاسف الشديد على المدار الطويل ستيل نفس المشكله اللي قلناها اللي شفناها في الاندوسكوبيك بلايكيشن بتحصل حتى في اللابروسكوب، رغم ان في 2 لايرز بيحصل ده طبيعه المعده، بيحصل لوزنج للستيتشز، وعشان كده الباوتش بترجع تكبر مره ثانيه. النتائج عشان ناخد ارقام اكيوريت بعد سنه نزول الوزن بعد اللابروسكوبيك بلايكيشن بتكون حوالي 22%. التوتال ويت لوس بعد سنه حوالي 22%، وبعد 5 سنين حوالي 15%. compared بالاندوسكوبيك بلايكيشن اللي لسه كنا بنقولها من شويه حوالي 15% بعد سنه وبتنزل حوالي ل 12 سنه. ملخص الكلام اتس بروميسنج تكنيك، بس لازم نكون عارفين الدروباك بتاعه ان بيحصل لوزنج للستيتش والباوتش بتكبر مره ثانيه. فاهم حاجه اللي انا بنصح بيها وده دكتور اديب مشكورا قالها، ان احنا نختار الجود سيلكشن بيفرق جدا جدا في الريزلتس. وتسلم ايد دكتور اديب، يعني عمليه رائعه، تسلم ايدين.
وديك دكتور شكرا لكم جميعا. يعني هنا we will show you the results of the
can I ask a question? Is there any difference in the incidence of post-procedure like reflux or hiatus hernia? Does it differ between endomina and laparoscopic sleeve gastrectomy?
So this is the point of not suturing the fundus. I know some of the schools and for the endoscopic sleeve gastroplasty, they tend to suture the fundus to suppress the glargine hormone and enhance the weight loss. But actually, the studies showed that it carries the same outcome if you close the fundus or not. But the beauty about our procedure, when we preserve the fundus, any patient who has hiatus hernia or chronic reflux, they would not feel any kind of exaggeration of the reflux after gastroplasty. Because definitely we spare the fundus and all the angulation that helps to maintain the gastric acidity and the intragastric volume. And as you see, this is the outcome here. Very clean procedure. And this is the GE junction here.
So, Dr. Dia, we believe that the complications are much more less with the endoscopy than the laparoscopic sleeve. What do you think?
طيب يعني سؤال طبعا رائع، وهو الإجابة دايما بتكون بالأرقام. كويس. أكيد الاندوسكوبيك بلايكيشن واحدة من المميزات الكبيرة اللي فيها إن هي بتتجنب complications زي البليدنج زي الليك. بس تقريبا عشان نقول نسبة حدوث الليك دلوقتي بعد سنين طويلة قوي في الحاجة زي السليف جاستريكتومي less than 1%. فممكن يكون less than 1 per 1000. less than 1 per 1000 نقدر نعتبرها a very low risk. ومع ذلك طبعا هي ريسك موجود ولازم يكون مكتوب ويتشرح للمريض، ودي طبعا بتتجنبها. بالنسبة للسؤال اللي عجبني السؤال جدا اللي اتسأل على ان بعد السليف ممكن يحصل ريفلكس، وهل احنا في سواء اللاباروسكوبيك بلايكيشن او الاندوسكوبيك بلايكيشن بنتجنبه او لا. هو الفكرة في السليف مينلي بيكون اهم سبب بيعمل الريفلكس ده، بخلاف ان بيحصل ضعف في الهايتس ماسل نفسها، وبنلاقي دايما في هايتا الهرنيا محترمة. بس الانكريزد انتراجاستريك بريشر بعد السليف نتيجة تصغيرها جوه ده سبب رئيسي في ان يحصل الريفلكس اللي موجود. وعشان كده لما بنيجي نعالج مريض بيجي لنا this is very common، ممكن 20-30% من الناس اللي بنعمل لهم سليف وبيجوا لنا بعد كده بريفلكس. الحل مش ان احنا بس حتى لو عنده هيتا الهرنيا ان احنا نعمل له كروروبلاستي ونصلح الهيتس هرنيا. الحل لازم نعمل له كمان جاستروجيجينوستومي برو ان واي بخلاف بتاعه البايباس، بس لازم يكون في جاستروجينوستومي عشان نقلل البريشر جوه الباوتش. ده مش موجود في اللاباروسكوبيك بلايكيشن او الاندوسكوبيك بلايكيشن. بس كقاعده عامه اي ريستريكتيف بروسيجر للستومك هتزود البريشر. فلو مريض برضو دي نصيحه لزمايلنا الانترست في الاندوسكوبيك بلايكيشن، لو مريض عنده ريفلكس من الاول ما ننصحوش ان هو يعمل اي ريستريكتيف بروسيجر ولا لاباروسكوبيك ولا اندوسكوبيك، لان ده ممكن يزيد نتيجه زياده انترا جاستريك بريشر بعد العمليه.
طيب تمام.
طبعا under the light of the innovation in endoscopy, now I published 20 cases of endoscopic fundoplication in conjunction with endoscopic sleeve gastroplasty, and the outcome was brilliant. I did Gerdix for those patients. It took 15 minutes, 20 minutes before the procedure. I complemented with the gastroplasty for patients who had hiatus hernia and prolonged history of reflux, and it went perfect.
So أديب أنت نشرت حالات عن endoscopic management of reflux بعد endoscopic sleeve مش laparoscopic sleeve, right?
I did publication. I published a case series of 20 cases of endoscopic fundoplication in lap sleeve stomach.
Lap sleeve, okay.
And I published another 25 cases of combined endoscopic fundoplication using Gerdix device with endoscopic sleeve gastroplasty. And that solved the problem of a reflux for most of the patients.
Could you manage to get the device in the sleeve, the surgical sleeve stomach?
The surgical sleeve? Okay, so some of those patients, we were able to manage to do the retroflexion inside the antrum and pull back the device toward the cardia. And some of them, we did it with my own technique, which is the forward view. I will show it. I will show it to you secretly.
Okay. Adib, very nice job. Very nice job. Do you have, like in your mind, a comparison between the Boston device and the Endomina regarding the results, regarding the procedure complexity, complications?
I guess we're gonna see this in the coming future. We can't compare this one because definitely the cases that's been done with a Boston device has been there for a long time. I think we need to publish more study and to study more cases. But I believe both devices are brilliant. Both devices are good to be used. The Boston device is actually helpful in cases like Tori, patient who had gastric bypass, or patient who had sleeve that I need to do sleeve and sleeve. Endomina, as you've seen, it's very clean field. There is no bleeding. I can send the patient home safely. I didn't pierce beyond the stomach wall. All my job was inside the stomach without taking any risks of pushing the helix further beyond the stomach wall.
So Adib, we will have a case transmitted from USA using the Boston device. Maybe in a few minutes we will be in the United States just to see the different modalities of bariatric endoscopy. Now I have to go to a Mass hospital for Professor Inoue because they are performing a poem and he wants to perform the double scope. Can we go for Professor Inoue, please?
يلا خلاص احمد
Can you hear me? Hello, Professor Shaima, can you hear me? Okay, now we start with another case at the Mass Hospital. It's a 40-year-old male patient complaining of dysphagia for 3 years. Eckert score was done, it's 11. The patient had barium swallow done. Barium swallow showed dilated esophagus with a tapered distal end, suggesting achalasia of the cardium. EGD was done. It revealed the esophagus was dilated and the cardia was spastic. High resolution manometry. IRP was 23. There is pan-esophageal pressurization. Lower esophageal sphincter pressure, it's 47. It's a type 2 achalasia. So this is a type 2 achalasia case for peroral endoscopic myotomy and double endoscopy by Professor Inoue, Professor Mayo, and Professor Karim.
Hello, now on air?
Yes.
Okay. So,
Shaima, do you hear us?
already? On air?
Yes, we can hear you.
Okay, anyway.
Yes. Yes, we are on air.
Okay. So, this is the case of Chicago type 1 achalasia. So, this distal end of the esophagus, so the junction is tight, but not a type 3 achalasia. So we can place the relatively short myotomy. I mean, a 7 centimeter is okay for this case. And then now I back up endoscope 10 centimeter from the junction. And then anterior approach. Then we are trying to get in. Okay. Dissect the submucosal layer a little bit. They need out.
Professor Inoue, we had a case now transmitted from Tunisia with Professor Sami Dabbous about the underwater poem. What do you think about the underwater poem?
Yeah, I agree. And we can, but not insist to underwater. So we can switch with the regular form, and if necessary, moving to underwater. So wait a moment. Okay, so injection, please.
So we are now doing anterior approach.
Anterior approach.
Yes. At
Okay.
1 o'clock.
Yes. Okay.
We made a mucosal incision, small mucosal incision, and trying to introduce the scope into the submucosal space.
Okay. Not yet, man. Okay. Okay, need out.
We need
So
the
using a splay more.
Yeah.
We can dissect a little bit. Okay. Oh, we have to go this side. Okay, so once we back up and then approach again. Okay.
Okay, so we will shift to Greece to see the end, and we will come back to you, Professor Inoue. يونان يا شباب.
Yeah.
Okay, can you hear us? Hello.
Hello.
Hello there.
Hi, George.
Hi, you delay us. We have finished the.
Very nice case. Very nice.
Okay, so Sayama, spray coag under CO2. Remember that.
Yes.
Okay, so this is the final cut. All right. We have a very good traction. So we're done. And then I will use an endoloop cutter to cut the rubber. So I don't know how you do it, but I like to use an endoloop cutter. In the meantime, while my assistant will bring it, I will inspect to see if there are any muscle damage or any big vessels. So this is very important. Here, we have a penetrating vessel that has to be treated with coag rasper very carefully because you can induce perforation. Otherwise, there are no other major vessels.
So, George, the question, the very, very public question, to close or not to close, what do you think?
Yes, I'm a big endeavor of closing everything. There are things that we don't mention in congresses or in publications. Some patients live in remote areas without access to big hospitals. So, and patients of high risk, and there is recently a limos risk of bleeding, taking into account the risk, the age more than 55, the use of antiplatelets and anticoagulants. And if the score is, the higher the score, the higher the bleeding. But personally, I like to close everything. This is a 50-year-old patient living in Athens, so he can come at the hospital in 30 minutes. I will not close it. But for patients from remote areas, I always close it. In particular, lesions in the colon.
So do you use the loop cutter to cut the band or just grasp it with a...
Yes, yes. So this is the endoloop cutter. I use it to reposition to close. So I push it. Yes, close, please. Now,
loop cutter نشوفه النهارده يا جماعة.
I pull back and the rubber is cut. You see?
Very, very nice.
George, you have very big experience with
clips. Easy, George, while you're doing it. It looks very easy.
Many failures behind that easiness that you see.
You have very big experience with clip and rubber. Do you have any tips and tricks how proximally you're gonna attach? Is there any trick how far you attach the clip? So, or it doesn't matter to optimize traction?
For the clip and band traction that you can combine, by the way, with undersaline dissection, you should always do a circumferential incision. Otherwise, it will be difficult to complete the procedure. And you aspirate the CO2, the gas, in order to reduce the lumen, reduce the size of the lumen. And after you position it, then you insufflate again.
So what is the mode that you are going to use for the coagulation of the blood vessels that is very close to the muscle?
What is the strategy? I grasp the vessel. Yes.
The mode, the electrosurgical mode.
I use soft coagulation. The setting is 5.0. And I use always the coag rasper. I don't like to use biopsy forceps because they are more aggressive. With one exception, huge vessels, huge arteries, then you can use them. I pull back always, and I press for maximum 2 seconds with tapping. There are cases of delayed perforation, so be careful of the excessive use. And I will search for other vessels. Please close, pull, okay. Open, close, pull back. Another technique is to use your coagrasper closed and just touch small vessels, but you have to be very precise not to induce a perforation. Open. So that's it. I think you can go to other operators.
Thank you,
we are
George.
done.
This is was very, very nice. Thank you.
Thank you, all the best. Thank you for the invitation. Bye.
Thank you. Thank you so much. Can we go back to Tunisia to see Dr. Sami Boudabous, please? Dr. Sami Boudabous, are you still with us?
I am with you, but I have to share my screen again.
Can we come back to you?
You see my screen?
We want to see you. We can hear you, but we cannot see
Okay.
you.
You will see me. It's okay?
Not.
You see, Ma?
Yes, we can see now. So
Okay, so I just was waiting for you to see if there is some vessel bleeding to show you what is the importance of the undersaline PUM.
Sami, there is something very special that I want you to know, that you are performing underwater poem, and on the other side is Professor Inouye performing classic poem. We are not stressing you.
I can't argue. I can't answer for this. Sorry. So what I just want to add, the tunneling will be under saline, but for the cutting of the muscle, it will be under CO2. So I just will show you here. There is some vessel bleeding here. I will show you this, the importance of the immersion technique. You see the blood coming from 1 o'clock position here. And with my irrigation, the bleeding has stopped now. So look what will happen now, injector. And this is what can happen with the water, with the saline. The pressure inside the tunnel will help me to control any bleeding vessel, even if I have bleeding. And the other advantage, I don't need to change any device. It's only one device, one setting, that's all. And the magnification of the saline here, we can see everything almost really injector. And you see how beautiful the blue color you see here.
I love the underwater, but the bubbles.
It's under saline, not water. It's under saline. So because water is something, so we can't do the freeze effect with the water.
Sami, about the bubble thing. What do you do for the bubbles?
The bubble will inject water. We just put saline, and the water will go up. And the other thing, we just put the head of the patient a little bit upper to make the air go up. So we'll show you a demonstration now of this. You see this big vessel there coming from the muscle. And this is what is the freeze effect I need. Injector.
Dr. Sami.
And this is the freeze effect. You see it?
Assalamu alaikum, Dr. Sami.
Assalamu alaikum.
Alaikum salam. Dr. Huda Abdelaziz from Egypt. Can I ask you about how you judge the amount of saline to be injected?
So this is the best question you asked today for me, because we are not in the colon.
What?
So we are in the esophagus. We have the cardia is closed. So all the water is coming up. So you have to be sure your T-tube is well protecting the airway. And the assistant behind me is checking for the saline coming outside from the mouth.
You completely immerse the patient in saline.
Yes, I will show you. I will go back.
This will reduce the risk of barotrauma of CO2 insufflation?
Yes, as I said at the beginning, I don't use CO2 at all now. It's closed.
You turn off the CO2.
I turn it off, of course. And you see all my esophagus is under saline here.
Completely under saline.
Completely under saline from the beginning. We are reaching almost here the cardia. We will cross the next few minutes the cardia, but everything is under saline here. So the CO2 is off.
Dr. Sami?
Yes.
Assalamu alaikum.
Salam.
In case of severe submucosal fibrosis in
It helps a lot because I will dissect first. When you put saline around your needle, your knife, the heat will be focusing on the point, the tip of the ball. That's all. You won't have any.
Why is there air bubbles? If you immerse the patient completely, the esophagus and the tunnel in saline, why is this air bubbles is present?
Because it's the heat of when you it's like water boiling.
Smoke from diathermy.
أول ما تدوسي dissection يروح عامل bubbles على طول.
I will show you. Just if I'm putting water here. I will cut with the Swift coag. Okay, I will have some bubble. But if I use my undercut, the bubble are really less.
Dr. Sami?
Yes?
I'm asking about the, extensive submucosal fibrosis, just the saline or under saline poem. You can solve the problem, or what can you do here?
We can cut through the fibrosis near the muscle and get away from mucosa, and the saline and the continuous irrigation here can open the space. So I don't think we can see better the fibrosis or the submucosal fiber here with the CO2. So even with fibrosis, we can dissect fiber by fiber.
Well, what about the double tunnel technique?
In severe fibrosis, maybe we will go behind the muscle and do another tunnel through the muscle. The circular layer, and go until the end, until we reach a normal space without fibrosis.
Sami, thank you so much. I'll come back to you. Can we go back to Dr. Sherbini and see the ESD case? Sherbini. Sherbini, do you hear us? شربيني بتعمل ديودينا الاي اس دي في البلب من غيري؟
لا دي عادي. بصي، لا مش اي اس دي عادي طبعا. طبعا وي فاوند المنطقه اللي كانت انا الدكتور عبد الرحمن ده هنا اهو حبيبي. احنا لما خدنا الديسيجن السنترال امبلايكيشن والليجن الكبير وان هو بالكي مش قادرين ناخده جوه الكاب بتاعه الفول سيكنس، فالديسيجن كان الاي اس دي، وكنا بنفكر في ان احنا نعمل تراكشن وفينش ذا سيركل انسيجن. طبعا احنا قدرنا ندخل تحت الليجن، بس هنوريكم ان الليجن في النص كان لازق في المصل جدا، فاضطرينا ان احنا نعمل فري هاندد اندوسكوبيك فول سيكنس ريسكشن ات سام بارت. زي ما انت شايفه هنا كده شيماء، في حته من الليجن كانت اتاتشد في المصل كويس، وده الجزء اللي اتاتشد. احنا اضطرينا ان احنا نفصله من المصل، وبعدين رجعنا تاني وسيفد المصل تاني في الجزء الباقي. فده الجزء اللي عملنا فيه فول سيكنس، وده بقيه الجزء اللي هو خلاص احنا لسه لنا جزء صغير خالص. ادى الليجن من تحت اهو. شايفين الصوره دي؟ اعتقد واضحه كده. شيماء ممكن تشرحها للاوديان. As we can see, here is the inner circular layer muscle. This is the outer longitudinal. We dissect through the inner circular muscle layer at some part, but here again we found the submucosa, although it's very dirty and a lot of fibrosis. What do you think? Yes.
احنا عملنا قبل ما نعمل
Yes. اتعمل اي او اس، وكان الليجن طالع من الثيرد لاير، وقال ان الماسكولايز بروبريا فري. بس احنا اللي احنا شفناه هنا ان احنا ما لقيناش بلين واضح في الجزء اللي كان فيه سنترال امبلايكيشن. ما فيش اي انجكشن. الدايسكشن كنا هنيجي على حساب النيورو اندوكراين تيومر او على الليجن، فكنا ممكن نسيب ريزيديوال. فوي بريفيرد ان احنا نعمل دايسكشن through the muscle to make a good safety margin.
دكتور شربيني, this is always expected for the neuroendocrine tumors to have some muscle attachment.
Yes يا شيماء.
دكتور محمد معاك هدى عبد العزيز، تسلم ايديك استاذنا ودكتوره شيماء ودكتور كريم. انا ادين لكم دايما بالفضل في تعليمي السيرد سبيس، وبقول الكلام ده في كل حته بروحها يعني. انا بس هسال حضرتك سؤال، هو الحته بتاعت السنترال امبلايكيشن دي كانت مكان البيوبسي ولا لا، ولا كانت موجوده من قبل البيوبسي؟ لان اتقال في الاول ان بتاخد بيوبسي وقالت ان هي نت.
يس. لا هي من الاول قالت نت، وهي من قبل البيوبسي يا دكتوره ليلى. يعني بص حضرتك، احنا مع ان احنا بنستخدم here I'm using a very nice knife in injection. It's Pro knife from Boston Scientific. However السبميكوزا عند some part لو احنا بصينا هنا مفيش elevation خالص هنا، no plane. يمكن تحت شويه هنا كده شايفين في plane عند الساعه 5. فده يقول لنا شايفين البلين قد ايه. لو بصينا عند الساعه 3 الليجن attached للمسل. So at some part we have to dissect through the muscle to make sure that we did a good safety margin for this lesion. Jack?
Well, given the lesion was like in the EUS smaller before, it might be that the lesion is growing and invading more. So whatever we had in the EUS that was done, probably not reflecting much what we are having here. So مثل ما قال دكتور محمد, in the really central part of the lesion, it's very difficult to dissect the submucosa. So giving a better safety margin will be better in this case, preserving the limb.
Yes.
سؤال قبل الأوان. What is your plan of closure?
Yes, this is a question that I asked before because I was expecting what happened now.
You will use the endolobal clips or you use mantis or what? What are you going to
use? Mantis clip first. Stop. I'll try mantis clip. Then, if it's difficult to close using mantis clip here, I have the option of burst string. Okay. But usually, you know, Shaimaa, that the bulb is very tough during closure, especially because it's very stretched and you cannot approach or you cannot add both edges to each other. What do you think, Doctor?
Yeah, I think the first choice here is mantis clip. Hopefully, it can manage to approximate the lesion in this case.
Probably it's like three. No.
Here you can see this is a very clear image here.
We will
a small plane of
شربيني انا بس عايزه اقول حاجه، انك احنا من الصبح بنشوف حالات ESD وشفنا different types of knives. شفنا مايكروتك، شفنا فلاش نايف. كلمنا على النايف اللي انت بتستخدمها قبل ما نشفت البروفيسور إنوي. What knife?
We are using, yes. As you can see, it's still attached here, but we are about to finish, maybe less than a few millimeters. But here we are using a flash knife, this Orice Pro knife. Orice Pro knife, this coming from Boston Scientific. As we can see, this knife, this called Orice Pro knife, come with 3 diameters or 3 lengths, 1.5, 2 millimeter, and also 3 millimeters. 3 millimeter for tunneling, 2 millimeter for dissection or ESD through the stomach, and we prefer 1.5 millimeter in the duodenum, in the right colon, and sometimes in the rectum. So it's a very nice knife. So you can go with the tip outside and you can fix. So in retroflexion position, don't worry about that. The needle will go inside the sheath, and also supported by a good injection. And really we appreciate, and can you agree that this is a good injection in injection this knife? So it's a very good knife for dissection, especially in the duodenum, and actually also supported by part for cleaning here. So you can go outside and just putting the tip of the knife, just doing right rolling, it will be clean.
تسلم ايديكم دكتور شربيني. انا عندي بس سؤال صغير. الكيس في البدايه قلتوا انه هي اتشخصت ببيوبسي انها نيورو اندوكراين تيومر، ويمكن دايما في الكورسز لما بنحضر مع حضرتك ودكتوره شيماء دايما تقولوا لو احنا بلاننج ان احنا نعمل اي اس دي سباتر ان احنا ما ناخدش بايوبسي. فانا كنت عايزه اعرف ليه احنا ما دام كنا بلاننج ليه اتعمل بايوبسي من الاول. الحاجه الثانيه عايزه اعرف برضو نوع البايوبسي اللي اتعملت كانت بايت اون بايت ولا اي يو اس بايوبسي.
I mean, البروسيس يا دكتورة that this patient when they found the submucosal lesion, it was in the fourth layer as far as I remember.
Yes.
And then giving the hypoechoic structure of the lesion being in the fourth layer, the risk of neuroendocrine tumor is high. That's why the doctor, they just performed an EUS FMB for the lesion and it came to be neuroendocrine tumor. But it's a very good, if you are planning to do any kind of dissection in any part of the duodenum, usually if you are performing FMB, try to avoid going through the deep layers of the lesion. So you can take as much as you can of passes in the upper part that's facing the mucosal layer. There is no clear data that looked into the effect of FMB, not biopsies, but FMB in dissecting any region after that. But theoretically, it's better to avoid the deeper part going into the muscle and going back. You make it more superficial. Can you hear me?
Yes, we can hear you. This is a very tough case. The last thing you like to do is to do a duodenal, is to touch the duodenum anyhow. And it was expected from the very beginning. This is why we love to do FTRD in the bulb. So we are shifting to the United States because we cannot postpone the United States because of the strict time difference. We are having a second case, bariatric endoscopy as well, using the ESG, the Endostitch device. Can we shift to the United States with Professor Tobias Zocelli, please? نطلع على أمريكا يا شباب. So bariatric endoscopy is really a booming field now, and there are two devices, and it's expected soon to have a lot other devices as well. ممكن يا جماعة نجيب أمريكا يلا. Toby, do you hear us?
I do hear you. Do you hear me?
Yes.
Shema, can you hear me?
Yes, we can hear you, but I cannot see you.
Yeah, we just hit a little video glitch. We're working with Iris on to help get that squared away. I guess I can, so.
أمريكا يا شباب. So Tobias, welcome. I would love to introduce Professor Tobias Zocelli. He is a professor in Henry Ford Hospital from Detroit, from USA. And we have been speaking about the bariatric endoscopy a lot today. And we had a case of Endomina device, and we're waiting for the ESG device to compare. So ممكن يا دالاس نشوف أمريكا يلا يا جماعة. Can you share from your side? Because I think...
Yep, I think they're just logging in to reshare. I have, should be like, hopefully like 2 minutes. But while we're waiting, I just wanted to say marhaba, Cairo. Thank you so much for having us and allowing us to participate in this. Thank you, Shema. Thank you, Dr. Professor El-Sherbini, Okasha, Al-Fada. We really appreciate the opportunity to talk here today. Just the background of the case while we're waiting to get video streaming. This is a 42-year-old lady. She has a BMI of 40. She has 2 children and has tried multiple weight loss avenues. She has tried medication, pharmacotherapy.
Yes, now we can see the presentation.
Oh, you can see the presentation now?
Yes, but the presentation, it states post ESG instructions. We want to see the
well,
ESG.
we're a few slides ahead, I guess, then.
Okay. ممكن نرجع slides من الأول.
Yeah, and so I don't know how clear this is on your end for us.
Yes, now we can see a 42-year-old
Yeah.
woman, yes.
Yep. And so she does not actually want surgery. You know, her BMI is close to a surgical threshold. She doesn't want it. She has very reasonable weight loss expectations. We're live now? Okay. And, you know, we talked to her with based on MERIT trial and other trials looking at ESG in America, we're looking at about a 15 to 17% total body weight loss. And what we're going to do, Shame, I heard you talk about this earlier, is we're going to send her to her metabolic clinic here, where she's going to get started on a GLP-1 in the short term after ESG. And that's to augment her weight loss. So hopefully we can get her total body weight loss down to over 20%, maybe as high as 23% based on some studies. I don't know if we can go to the endo view. I'm going to skip some of these slides for now.
Yes, we want to see you.
Yeah, I want to see you.
We want to see you on the procedure.
Yeah, we should be
Yes,
able
now,
to switch
yes,
over.
finally, now we can see you.
You got me.
Yeah, I got you.
Yalla. Now we go. What do you think? All right, so this is our, as everybody's well versed in, this is our typical anatomy. It's a stomach here. I'd like to introduce our team before we get started. This is our 4th-year fellow, Omar Shama. I have our trusty set of nurses here, Sean and Amanda back in the corner. We have our rep from Boston Scientific, Jody, here with us. And we have our anesthesia, Tim. So he's running, making sure the patient's safe. What we did just to get things rolling is we already marked out, you don't have to do this. We marked out the anterior wall just to serve as a guide. We marked out the posterior wall to serve as a guide, because sometimes when you're doing full thickness sutures, things will start to get a little bloody. So now that we have this marked out, we see the incisura here at the top of the screen. So we're going to start just adjacent to that on the anterior wall. And what we do a lot is we'll use a helix. You have to use a helix for this procedure, or you're not going to be able to get full thickness bites. We want full thickness transmural bites to ensure durability of the suture line. So what you can see here is go helix out. Okay.
So
The
please,
helix-
because maybe most of the audience are not oriented with the device, so can you explain to them the idea of the device and how it works?
Absolutely. I'll go through that. So first, let me show you this helix. And it's really like a corkscrew device. So what that's going to do is it's going to screw into the wall of the stomach, and it's going to allow us to bring the wall of the stomach, helix back, into our suturing device here. And what we're going to do is we're essentially just going to take a suture, a needle, and we're going to take it from the needle driver. That's what's closing on the screen right now, through the tissue. I don't know if you can see my hands, but what I'm going to do is I'm going to use this needle exchange catheter here, and I'm going to take the needle back, okay? And then I'm going to open my needle driver. We would release the tissue, and that allows our first bite to go through. I'll demonstrate this momentarily. But, you know, there's a lot of minor technicalities of suturing, and we'll go over this during the case. I think one of the biggest things is just the steps you need to suture. And I call it the give and take. So first, what we're going to do is we see a horseshoe-like shape at the bottom right of our screen. And that's actually called the horseshoe on the suturing device. You never want your needle, right now you can see my needle's in that horseshoe. You never want your needle in that horseshoe device. And the reason is, if you close with this here, there's a risk you can bend your needle. If you bend your needle and you bend your needle exchange catheter, you may have to open up another kit. And despite what people may think about Americans, we do like to save money for patient care. So that's one thing I want to emphasize. So once your needle is out of the exchange, or out of the horseshoe, you're going to close your needle driver. You'll hear a nice click. That lets you know your needle is locked in, your needle driver. You're going to push your hands out, and you're going to haptically, you're tactile, you're going to feel it sink onto the needle exchange catheter. Then this is the give. So you're going to give by pushing your blue button down and pulling back a centimeter or two. This releases your needle now onto the needle driver. And now you can take a bite or place a suture. Once you go through the tissue, this is the take part. You're going to push on until it snaps on. And you're going to take the needle back.
Okay.
You're gonna open to release tissue and you're gonna start suturing. How's that so far, Shimna? Ready to go on?
Yes. So
right.
you did some marking before, right?
I did some markings.
That's what I asked about in the previous endodomy.
Yep, you don't have to, but it is a nice thing to do so that when you're going through the suturing, things get a little distorted or there's some oozing from the bites, that you know exactly where you're going. And what we mark is the anterior and posterior wall. We do not suture the fundus. We try to bring this as close as possible to the G junction, which was at 40 centimeters. So why don't you go helix out then? Okay. So right now, Sean has the helix out. He's going to turn it 4 times to the right.
Okay.
And then what that allows us to do is
So-
capture the tissue.
I will explain to them. شايفين الفرق بين الجهاز ده يا جماعة والجهاز اللي فات؟ الجهاز اللي فات كان بيستخدم جراس. هنا ده بيستخدم هيليكس. يعني هيليكس.
Hey, Shima, I have a surprise for you. We have multiple Arab speakers in this room. You want us to do it in Arabic? Omar, go. Yalla, Omar, come on.
بس انا اخد الفول thickness معايا يعني this
Maybe we don't have comparative data yet, but maybe it looks like maybe this is more like a full thickness bite.
Yeah, that's the goal. So what we're gonna do is we're gonna pull this in. You don't always have to go what we call a pink out, where the mucosa is completely blocking your stream. You know when there's too much tension and you don't want to rip the mucosa where the helix or the corkscrew device is. The most important thing is really staying completely perpendicular to the mucosa that you're bringing in. And you can see this by our suture here. It's perpendicular to the gastric mucosa you're bringing in. If you need to make it more perpendicular, most of the time you drop your hand to the left, and that allows you to pull back on your helix and then rip the tissue. And that's what I wanted to show you. All right, helix back. Yep. Helix out. Out. And go forward. 1, 2, 3. So here we'll pull back. And again, you don't always have to be completely pinked out. This is going to be your bite here with just some movement. Right here. Most importantly, when I close, I can feel a double crunch. And what a double crunch is when I close my handles, I feel a crunch in the middle. And that's haptics telling me that we hit the muscle layer, the muscularis propria. And that allows me to know that we've gone full thickness with this. So really happy with that bite. My next steps are simply to push out my needle exchange catheter. And like we were talking about earlier, we're going to push out and I'm going to take the needle back. So you see the tissue jump? That allows me to know that the needle is now on this and not still on my needle driver. So I can open up my needle driver. I'm going to push out my needle exchange catheter and my helix a little bit. And I'm going to tell Sean to unhelix. He's going to rotate this helix device to the left 3 to 4 times. Go ahead. Okay. 1, 2, 3, 4. One more. Okay. A little bit more. Yep. Okay. And now we're back. So now we have our first bite and we've started our ESG.
Yes.
Now, here's
Very
probably the
nice.
next most. Thank you. Thank you. Here's probably the next most important part. And that is not crossing your sutures. So one thing I'm doing right now is I'm trying to stay off the CO2. I don't want to distend the stomach too much. If you distend the stomach too much, you make bigger targets and it makes it harder for the tissue to come in with the helix. You don't get as good a bite. So I'm limiting my CO2. I have it on a lower setting. 2, we hear about crossing sutures. And what crossing suture lines means is whatever direction you want to go in. So meaning if I was going to the right on the screen here, I never want the trailing wire, which is the wire I'm touching with the suturing device up top, the visual left. I never want that to be in front of the direction where I'm going to suture. What happens then is if your trailing wire, which is this wire to the visual left, is in front of your leading wire, which is right now on our visual right, we cross the wires. And when you cross the wires and you go to pull tension and to complete your suture line, it will not pull through. You will have gaps. It may completely come undone. So we always want to keep that in mind. So our direction now is going from anterior to posterior, which is going to be down here, and we're going to use our helix for this. So since we're going down from anterior to posterior, we're going to keep our trailing suture up here at the top. So if I was on the other way, like.
So Toby, we will come back to you in a few minutes. المنصورة جاهزة يا جماعة. Now we will shift to Mansoura University with our dear friend Ahmed Zambari, and expecting a very interesting case of EUS biliary drainage. ممكن نشوف المنصورة يا شباب. أحمد أحمد احنا شايفينك بس مش سامعينك. انت سامعنا يا احمد؟ طيب
انا سامعك يا شيماء، سامعاني.
خلاص دلوقتي سامعينك. ازيك عامل ايه؟
ازيك اخبارك؟
ايه الاخبار؟ ممكن حد يعمل لنا كيس برزنتيشن كده سريعا؟
اوكي، انا هقول لك انا الكيس شورت يعني. الاول طبعا احب اشكر دكتور شيماء ودكتور شيرين ودكتور كريم for inviting me. Well, I'm happy to share in this big great event. We are working from Mansoura Specialized Medical Hospital. My team, I'm assisted with Dr. Ahmed Shaheen, Ms. Yasmin, Mr. Said and Mr. Saad, وماي anesthesia team دكتور عبد الرحمن ناصر. احنا البيشنت بتاعنا نير 70 طويل. البيشنت ده بريزنتد بأوبستراكتيف جوندس، يجيب دايجنوستيك ورك اوت، عمل US FMD، طلع بامبولاري انفيزيف جريد 2 ادينوكارسينوما في السي تي سبيشالز بني ماس. البيشنت كان في ديستورتد بابيلا، ما كان في ديفيكالت ترايل بي ار سي بي نظري ستيج. طبعا شايفين السكوبيك ايمج كان شو ذا امبولاري ماس. لو هي واضحه بالنسبه لكم، ذا امبولاري ماس فيري ديب ونيرلي اوبستراكتنج الهيومن. If you can see the endoscopic view, we have here distorted papilla and distorted anatomy. So in this patient, we try US guided biliary drainage. Our plan today is US guided biliary example. لما نيجي نشوف الاندوسكوبيك فيو بتاع US، لو US picture, we can see the US picture. I can see here the common bile duct and the conference of the portal beam joining with the superior mesenteric and the splenic beam. I'm here having a directed CDD. I measure the CDD. It's about is about 15 or 16 millimeter. I follow Kairos examination. I can follow down to the papilla here. I can see down moving down to the papilla, and now I can see the big or huge ampullary mass. The left side is the point that is the ampullary mass, and this is the intra-papillary portion of the same. It traces against the same moving up and moving anti-clockwise. We can trace the CBD, then the portal conference moving upward. You can see that it's better and moving again to the common papilla as the protein to the liver. So we start our procedure. First, we'll check by the endoscopy our position. I will start by the puncture with 19G. Here we are using the 19G expecting. We first do our puncture, confirm that we are inside the CDD. I'm just moving down just to pass.
أحمد معلش، أحمد الصوت شوية بعيد شوية.
أنا كده أحسن يا شمال لما عندي صوت.
هو بعيد شوية، ففي بعض الحروف بتطلع والبعض لا.
كده أحسن صوت. كده الصوت أحسن يا شمال.
طيب أحمد هستأذنك، هننقل دقيقة وهرجع لك تاني على الكلوجر. How to close a perforation، وهرجع لك تاني دقيقة واحدة. ممكن ننقل يا جماعة على مستشفى الناس بعد إذنكم عشان عايزين يقفلوا الديفكت. دكتور شربيني.
لا بروف إينوي.
أي حاجة يعني مش هات إينوي. So Professor Inouye We are back with you.
Yes. Yeah. Now we are completing the myotomy. This is the distal end of the submucosal tunnel. And then we have already dissected almost, this is the circular.
We want to show the double elimination, the double scope method, the trans-elimination method.
Yeah, that's right. So we are reaching the very end of the submucosal tunnel, and then, so please move. Yeah, okay. So this is the distal end of the submucosal tunnel. And then, so in a baby scope, you can see, please, okay. Yeah.
Can you see?
Yeah,
Yes.
Yes.
Like this, we can confirm the definitely the submucosal scope reach the gastric side.
Yes.
Very
So
nice.
1 or 2 later of gastric side myotomy is important. So I think it's okay.
So my
Yes.
my
So by this
question.
we check that we reached the GE junction.
Yeah.
My question.
This is the
also-
most reliable.
So Professor Inouye, my question is about the double scope trans-elimination method. Do you use it after the myotomy or after the dissection?
Yeah. It's thank you very much. It's a very good question. So sometimes we do. Most of the case we do the double scope check after the tunneling before myotomy. But this patient, the junction was very tight, so it's impossible to pass double scope. Then, so we perform the myotomy first. Then now we perform the double scope.
Very nice.
Okay.
Very nice demonstration. طيب
Yeah.
ممكن
So depends on the case. Okay. Thank you.
ممكن نرجع المنصورة يا جماعة الدكتور أحمد الطنباري بعد إذنكم.
Very open.
أحمد.
Welcome back, Shaimaa. I just did the picture of the CBD at the distant, and I'm now injecting my contrast.
معلش يا أحمد ممكن بس explain للناس أنت هتعمل إيه بس الأول كده بالراحة.
We are trying to perform a colidical endoscopy. So we did puncture of the distal CBD from the duodenal bulb. If we can see the EUS image, this is our needle, 19G needle from the duodenal bulb. This is the dilated CBD. This is the origin of cystic duct, and this is the portal vein. Now, if we can take a look at the fluoroscopy, I am injecting the CBD to check my position. We can see markedly dilated CBD, ملح. My next step, and this is the most challenging step, is to manipulate the wire straight to the hilum. Sometimes it's a little bit challenging or difficult, but we always have a backup plans. You can change your puncture site. You can do a rendezvous if you failed. You can do a backup hepatogastrectomy if you failed. So always be ready, because not all cases are always straightforward. But we will do our first step of trying to manipulate the wire through the 19G needle up to the hilum of the CBD. So this is our wire passing. Now we have a successful manipulation of the wire up straight. You can see the wire is moving up to the liver hilum, up to the left hepatic loop. So my next stage is to exchange. My assistant will push the wire inside, and I will pull back the needle to create a track. Our next step is to create a track. So I'm pushing back the needle, and we can see the wire preserved inside the CPD. I will close my elevator, and I will pull back the needle, and I'm ready with the cystotome just to create the track. So now, wait to adjust my position. Now we can pushing inside, keeping in fluoroscopy our guide wire straight up to the hilum, and leaving our position stable and straight. The next step is to create a track. When we create a track, we use a 6 French cystotome. We use an AutoCAD mode. I'm here using a Vios 3. So we will use AutoCAD 6.0 to create the track. Then we will, the final step, to insert the stent. عايز البلف. Now I am by EUS checking that my wire is in a good position and I am inside.
and I check by the fluoroscopy. Now, moving to the next step, which is the creation of the track. Do you have any question, شيماء؟
يعني اكيد مش انا اللي هسأل بقى بس
لا،
احنا
لا،
بس
مرة.
هستأذنك دقيقة. ممكن يا جماعة الشير بيرسونز بتوع السيشن يجوا، دكتور احمد فكري، دكتور ايمان عامر، دكتورة هيام فتحي، دكتور حسام سالم، دكتور أسامة أشرف. ممكن join.
Now I'm using the 6 French cystotome. We are inserting over the wire. While inserting, I will check by my fluoroscopy. It's the same like ERCP. I push my instrument and my assistant pulls the wire back, keeping the wire straight till I feel the cystotome coming out of the scope to be ready for the puncture. We are moving simultaneous. Now the cystotome, if you can see, is coming out of the scope. Now I am outside. I check my position by endoscopy and by fluoroscopy. Just to have adequate position, I just here. My cystotome is in view, in the EUS view, and under fluoroscopy also I can see the cystotome. So, while keeping this straight position, when I start to puncture, I use the AutoCAD, the yellow paddle, and my assistant pull back the wire at the same speed. So start pulling Yasmin. Now you can see the cystotome is inside. If you can see under fluoroscopy, cystotome is inside the CBD. So push the wire inside, and I will move to the last step, which is inserting 6 centimeter partially covered stent, which is already ready with us because you don't need too much time to insert the stent to avoid excess leak after the puncture. So I'm now after creating the stent. 6 centimeters.
6 centimeters.
I just need a short stent, no need for long stent in this situation because I'm in a close position to the duodenal wall, and I don't. I'm doing the puncture above the ampullary structure, so we don't have malignancy in our direction. So it's just to maintain the track. In Europe, they prefer to use the hot axis stent, or it's much easier. No need for guide wire manipulation. It's just puncture, freehand technique, and open the stent. But you know, hot axis is very expensive. So we use traditional biliary stent, and we need first to manipulate the wire, create the track with a 6 French cystotome, then finally to insert the stent.
Dr. Tumbari, this is Ahmed Fikri. I have a few questions. Firstly, how to avoid shearing of the wire while inserting? Second question, if there is any other way instead of cystotome to dilate, so you can use like dilators or something like that, or you prefer cystotome?
Yes, you were in Japan and you should do well. You were in Japan and you know that they use mechanical dilators because they don't like the heat effect. Now I am inserting the stent. If you can see, I'm inside the CBD. The first part, I start deploying. I will leave my answer for a little bit after opening the stent, Dr. Ahmed, and come back just to avoid leak. We will start to open the stent, the distal part under fluoroscopy. ابدأ افتح يا ياسمين. نبدأ نفتح. We are opening under fluoroscopy. The first half, I'm just pulling back and keeping my position just to keep a stable position. When I open half the stent, stop. I shift to the endoscopic view. Here, I just want to check the length of the stent outside the scope. So I pull my scope a little bit back without pulling too much, just to avoid slippage of the scope. And now we can see, if you can see my endoscopic view, the stent start here to appear. I now see the yellow marker, so I need to pull my stent a little bit back. Now we can see here the stent. I will pull my scope a little bit back. If you can see now the endoscopic view, we see the distal part of the stent at the site of the punch.
Yes, very much seen. Dr. Tumbari,
the important
nice
part.
work. Carlos Yusuf معاك. Very nice work, Dr.
Thank you.
Tumbari. Very nice work.
Now we will move to the last step, which is opening the distal part under endoscopic view. So Yasmin will start to open, and I am keeping my eye on fluoroscopy and the endoscopy, both at the same time. Stop, yes. Little bit, because the stent usually slip inside when you open. So you should be cautious. in this final step just to avoid internal migration of the stent. Even you can open inside the scope if you wish. If you don't feel safe, you can open inside the scope. Yalla, Yasmin, open. I stop. Each part I open, I pull my scope back and I check my position. I pull the stent a little bit backward to see the yellow mark and see my stent in a good position. Under fluoroscopy also, I'm seeing I'm a good position. Open, continue, stop, stop. You should always see what you open. Continue. Yalla. And now we can see the good drainage.
Excellent,
After opening.
excellent.
Check my
Excellent.
fluoroscopy. Thank you. Thank you so much.
Excellent.
You can see now we have a lot of bile coming out. I think we have also little pus inside the bile. We have adequate position. We have a good drainage. Back to the question, now we check the length of the stent. We have a good length. We have a good length of the stent inside the duodenum. We also check that we have no bleeding at the puncture site, and we have a good length. It's about 2 centimeters outside the wall of the duodenum, and our position is very good. Back to your question, we can use a mechanical dilator. Yes, we can use a mechanical dilator to dilate the track, but cystotome is easy and sufficient usually in most situations. Also, the second question is wire shearing. Wire shearing happens from excessive manipulation of the wire inside the needle. So you have different strategy. Always don't pull the wire too much during changing the direction. You also pull your needle back and manipulate the wire yourself outside the needle. If you are doing hepatogastrectomy, you can do liver impaction technique just to pull inside the liver tissue and remanipulate the wire just to keep your position straight without shearing the wire from excess pulling back. And now I think we have the job done. If we have any question, I am happy to.
Very, very nice job. I will come back to you. Just give me 1 minute because we want to shift to Al Nas Hospital to see the defect closure again. دي تاني مرة. ممكن نروح
Waiting for you.
Yes, I come back to you. ممكن نروح للدكتور شربيني يا جماعة عشان واقف على البرفوريشن مش عارف يقفله بسببنا. ايوه we're back. يعني منظر رائع يا دكتور شربيني.
منظر مرعب.
احنا
الحمد لله ده مكان.
قول لنا هتقفل ازاي بس مهم.
احنا سايبين لكم اخر قط على الهواء هنشيلها اهو وبعدين احنا عايزين يور استراتيجي يور ريكومنديشن. What do you see, Professor Abdurrahman, for how to close this defect?
I mean, there is more than one option here. X-Tat can be a solution, but I don't think it's available here. Maybe we can try Mantis and Muhammad and try to go from the cecal side to the oral side and see. Suture RT is going to be a little bit difficult due to the position and the orientation of. Can you hear us or?
This is Toby.
Hey,
how are you?
Hi.
I'm good. How are you guys? You okay?
We are good. How about you, Tawfiq?
Good, good, good. Is this Mohammed?
Yeah, what is it? Yeah, your question, please.
Hey, you know, I think sometimes I've had a case kind of similar to this where I've used a Mantis. I know Shema was saying Mantis or a smaller microtech clip in the ESD base to close the muscle and then oversewn on top of it. Is that what you're thinking for this, or what were you thinking?
Yeah, we've been discussing this with Muhammad, and I think we'll start with Mantis and see how it goes in this lesion. Carefully going from the part to the proximal part. Hopefully trying to approximate all. So as you can see now, the step is yes. Thank you for the question. And now Muhammad is trying to pull the lesion through and to get the dissected part of the lesion. After that, we will start closing this lesion.
طيب شربيني, did you take the decision of doing the Mantis عشان احنا عندنا كذا حالة لايف. Shall we go and come back to you ولا انت هتورينا المانتس دلوقتي؟
لا, go back if you don't have sufficient time and then come back after finishing.
We want to see how you close the Mantis. ده مهم قوي. احنا
Okay.
جينا مرتين عشان المنتس والحقن.
I need first to come with the lesion outside.
تمام. طيب ممكن نرجع لك كمان دقيقتين. We want to see the mantis. ممكن نروح للدكتور احمد طنباري يا جماعه. المنصوره معانا.
Yes, I'm here, شيماء.
ايوه زي. طيب تمام.
Now, if you can see the fluoroscopic view, we have what's called after opening, which is a candy sign. If you have the fluoroscopic view, candy sign means that you have a little bit space between the common bile duct and the duodenal wall, which is doing like a candy shape. This is not a problem. It will be fully expanded and you can have a full track within a few days. So it's not a problem. We can see a good drainage. If you can see the endoscopic view, I have a good position of the stent. We don't have excess bleeding, and if we can do suction, you can see how much good drainage of bile we can have. Even if we check by fluoroscopy, we have adequate drainage without any problem. So I'm happy.
دكتور احمد طنباري يا جماعه.
دكتور طنباري مساء الخير يا فندم. انا معاك الدكتور ايمن عامر. حضرتك سامعني؟
دكتور ايمان ازيك؟
ازيك عامل؟
معاكي
معلش سؤال، المينيمم كاليبر اللي ممكن ان حضرتك تعمل له بانكتشر بالنيدل؟
لو احنا بنستخدم الهوت اكسس بريفيرد انك تبقي اباف 12 ملم للسي بي دي، لكن لو احنا بنستخدم التراديشنال تكنيك زي ما احنا عملنا النهارده you can do at any diameter. Usually obstruction means diameter more than 10 millimeter. So above 10 millimeter you can do the traditional technique, puncture with 19G needle. For hepatogastrostomy, it's a little bit different. You need a caliber of preferred 8 millimeter for the hepatogastrostomy. Sometimes you can do with a 22G needle for even 5 millimeter diameter, but you need 0.018 wire, which is not available in all situations. But for the CBD, for doing cholecystectomy, 10 millimeter is sufficient to do the traditional technique like we did today.
Okay. Do you prefer a special type of stents?
You can use traditional biliary stent, fully covered or partially covered. Both are okay according to your preference. Both are accepted because we don't need a bile leak for the space between the CBD puncture and the duodenal wall. So it should be a covered stent, either partially covered stent or fully covered. Choosing the length is according to your situation during the technique. Mostly you can use 6 centimeter for the cholecystectomy, but in some situation, if you're doing from the antrum, if you have too much space between the puncture side, you can use 8 centimeter stent.
Thank you, Dr. Tambari.
Dr. Tambari, I have a small question, please. كرولوس يوسف مع حضرتك. اللي بتكلم فيه هل as in like different types of stents or biliary drainage, we expect that a track will be formed as a site of the stent later on, and that at some time we can extract the stent?
Yes. Yes, sometimes the track is usually full mature, mostly after 2 weeks. For the metal stent, if you're using plastic stent, it's about 1 month. You can do cholecystectomy even with the plastic stent. After maturation of the track, sometimes stent migrates. We performed a study comparing ERCP with the primary CDS for the biliary drainage, me and Dr. Ahmed Jahin. We faced maybe, I remember, 2 or 3 cases of late stent migration for the EUS group, but the patient didn't notice. He just noticed the stent coming out from the stool, or he vomited the stent, but without complication because the track was mature, and the mature track, as long as it's draining bile, it will never close. So you don't need to even put a plastic stent after that. Just after forming a mature track, it's like a choledoduodenal fistula draining the bile without any need for further using more stent. It's just mature track draining bile alone. So after 2 weeks, even if the stent migrated or removed or whatever the cause, you don't need to put any stent.
Thank you very much, Dr. Ahmed. A very nice and elegant presentation from you.
Thank you يا أحمد هاي.
As usual.
Thank you. أحمد عندك حالة تانية لينا هسيبك ونرجع لك تاني لو عندك حالة. ممكن نروح لأمريكا يا جماعة. We want to see the ESG. We want to go to the United States.
شكرا. Thank you.
شكرا جزيلا. تسلم ايدك. عايزين نروح يا جماعة اليونايتد ستيتس with Toby.
Hi, Shema. Can you hear us?
Yes, I want to see you.
Okay, so this is where we're at so far.
We put in what, got 3 sutures. This
Still
is-
can't use C, Toby.
They're gonna start sharing this. They're sharing. They should momentarily. Let me know when you can see, okay?
Okay.
But.
So now I
you
can see you. I got
You're
you,
right.
okay?
Okay, can you see the scope?
Yes.
Okay. Well, let me introduce someone first. This is my partner in crime, our endobariatrics team. This is Dr. Duyan Dang. So Dang was doing a spyglass case and was supposed to be here from the beginning, but we're lucky enough to have her join us now. And we have 3 rows of sutures in, so you can see the sleeve starting to form. This is our 4th row of sutures right now. And maybe we can get through this one so I can show you how we release the needle and use the cinch to complete the suture line. So again, what we're doing is we're just following our lines we created earlier. Helix out. Okay. And a lot of times with suturing, it's really, with ESD or POEM, you're really close to what you're doing. With most of endoscopy, you have your scope close. With ESG or endoscopic sleeve gastroplasty on Helix, it's really nice to be kind of far away from where you're suturing. It just gives you a lot of room to pull in the tissue. It makes things pretty comfortable. You can see the direction you need to go in. Helix out. Actually, stop here. And it allows you just to have a safe space. Oh, Helix out. Yep. Go ahead, for. Okay, there you go. It allows you to have safe space. It looks like you don't have too much there. They kind of. Okay. I didn't do it first. Okay. To kind of work in here. So you can see we're just going through on Helix. Okay. So after we unhelix, what we're going to do is we have our trailing suture at the top. We have our leading suture at the bottom. So we're going to keep that orientation. We're going to close our needle driver. We're going to push our needle exchange catheter here on the scope out until it clicks on. We're going to press the blue button and pull back a centimeter or 2. We're going to open our needle driver, and now we're ready for our next suture. To get that next suture, we're just going to push out our helix. I'm going to touch the wall. I'm going to tell Sean, helix out. He's going to push it out of the catheter. There you go. He's going to turn it 3 to 4 times to the right. Some people may not do helix out. Some people may go with the helix out already there, but I prefer to do it this way, just get a little more tissue on helix. The trade-off with that is if you go full thickness here and you go all the way through the gastric wall, you can theoretically hit surrounding structures, or it may just lead to more pain after this procedure. When I see patients, we often counsel them about, you're going to wake up with nausea. You're going to wake up with some abdominal discomfort. I mean, look at how the stomach looks over here compared to what it looks like over here. This is not, you're not going to feel like $100 afterwards. So I think prepping patients for that and allowing them to understand that you're going to have some of these symptoms when you wake up. We aggressively treat nausea. We give a medication called Emend, which is a strong antiemetic. We give them a scopolamine patch behind the ear. We have them on a clear liquid diet the day before the procedure, drinking Gatorade to keep hydrated. Since it's technically a bariatric procedure, we give a dose of Lovenox subcutaneously, a prophylactic DVT prophylactic dose before the procedure. And we keep them well hydrated with lactated ringers during the procedure.
So, Toby, can you explain to the audience the pattern that you
Yeah.
did during the suturing?
I've been waiting all day for this question.
Yeah.
Deanne, you want to talk about it or?
And you got it. So Toby's on his 4th row. He is doing a straight suture line. So that the benefits of that is obviously you can see that the trailing wire is on top and you have less problems with crossing your wires or crossing your sutures. You can orient yourself better with just going from 12 o'clock towards 6 o'clock.
Shima, there's a lot of suture patterns.
Yes.
And some will be a U, some will be like Dr. Dang just discussed, the straight line suture, which we're doing here. There's a Z, there's a Xbox, All right, next shape. There is an Xbox. And I think one thing we were talking about in the room with Jody from Boston, it's a nice pattern because I'm getting from anterior to posterior, I'm getting anywhere from 6 to 9, maybe high as 10 bites, depending on where we're at through the gastric wall. And I'm not running the risk of doing 14 to 19 bites in a U-shaped pattern, where if any of those bites rip, then your suture line starts to break down. And it kind of allows us the ability to just pull things in, have a relaxed procedure, still use between 6 to 9 sutures to ensure an ideal weight loss, and feel confident we're doing the right thing for the patient. There have been
very nice job.
There have been studies looking at this. Here, let me drop this suture here real quick for you.
Yes,
There have been studies looking at this in around the 2020s, some in EIO and stuff that compared that compared suture patterns. And really, the total body weight loss was minimal between different suture patterns. So what we're going to do now is hopefully we're at the end of the line. So I'm going to walk over the steps if I have time on how to complete the suture. Is that okay? I'm here. Okay.
So to be very nice, please don't finish till we come back to you. I want to go to Sherbini to see how he deployed the mantis, and I will come back to you.
Perfect. Thank you. All right. Let's see the cinch.
شربيني يعني رجعتونا مرتين عشان نشوف القفله وقفلت من غيرنا.
طيب احنا الحمد لله عملنا الدكتور عبد الرحمن بشكره. الديفكت كان كبير، فاحنا حطينا كليب فوق، ريجولار كليب على يعني حته صغيره من النورمال ميكوزا، فده عمل زي ريدج كده في النص، وبعدين ويبوت امانتس كليب فعمل ابروكسيميشن تماما زي ما احنا شايفين هنا. now we are using the second mantis clip. احنا هنوريكم بس فكره المانتس احنا ما بنجيش على 2 edges ونمسكهم، احنا بنمسك 1 edge في الاول، then doing rotation like this manner. I do the rotation to make sure that the mantis clip has 2 hooks. It will be fixed to the mucosa, rotating to right and left, and hopefully it work now. Open Muhammad, please. When Muhammad open, can you see still grasping the first one? Okay, then going back slowly with the second edge. Then after that, pushing, doing some suction, pushing the clip. Yes, close Muhammad, please. Now, fire, please. Excellent. Push back again. Yes, okay. I didn't. Yeah, maybe any catch in the second one.
I believe that when we grasp one edge, we have to open.
Yeah, it's one edge. So we'll try to the lower part. We'll try to the lower part.
ممكن تورينا المانتس نفسه وتورينا السنان بتاعته.
المانتس دلوقتي هنعمله ازاي؟ هنروح للجزء اللي تحت.
عاوز تيجي ده في نورمال
لا هنجيب مانتس عشان فور شور نوريهم. احنا فكره المانتس كليب هو التو هوكس على الناحيتين، فهو بنمسك ايدج، والايدج ده يمسك في one edge of the defect, then to fix the edge, then going and grasp the first edge to the second one.
متهيألي يا شربيني احنا لما نمسك الايدج الاولاني ونgrasp it, we don't open the clip unless we bypass the second edge عشان ما نفتحش جوه.
So the thing is that you have to grab one side, close the clip, and cause the tension against the part that you did then after that, if you open it, Shayma, it should not slip. The most important is just to ensure that you are taking a good part of the mucosa before you are trying to go. Then you apply attention to the other side, then you grab the other side.
Can you open محمد شربيني تفتح الكليبس تورينا، ممكن تورينا السنان بتاعته؟
شكل الكليب
هنا شايفاها هنا.
Can you see the hook?
Okay. Yes.
Okay. Close محمد. So we'll go again to one edge of them. Grasping one edge, rotate Muhammad, please. لف شوية. Open. Going back. FLA. Okay.
احنا بنمسك ايدج واحد ونسحب خالص لغايه ما نتاكد ان احنا عدينا الايدج التاني قبل ما نفتح عشان ما يفتحش قبليه. ايوه this is much better. Yes yes
Yes. Open.
Down, flip, down, pressure, question.
Yes. Close. Let us see first.
You might want to push instead slightly too.
I don't have CO2 now.
Well, this is okay. Probably. What do you think? Huh?
What do you think, Shaima?
It is closed, I believe.
Yeah, this is okay too. I think
What
it's
do you want to see? Huh?
push. Yeah. It's not unemployable to break out there as well.
I think this is the second. Now, because there's a lot of tension and position unstable, so I think it's okay.
Maybe you can fire.
It's okay.
Yeah.
Fire. Yeah. بالراحة.
ورده بالراحة.
Yeah.
بالراحة بس.
Okay.
Yes.
Yeah.
So
Yes.
yes. So you approximate the edges and you can go on with the other edges.
The other two. One here and one there.
So here it's approximated completely. So we choose to close from cecal to oral because the bulb is non-stretchable. Because if you trying to close from 3 to 9 or from 6 to 12, it will be very difficult.
Yes.
So here we can see the a small hole here in the mucosa. So we'll try to catch this mucosa on both sides at this part.
Okay. So we can go.
The microtech clip and the close. Thank you.
Okay, thank you. Can we go to United States first? Can we go to Tubi? Tubi, you're so fast.
No, I'm not. I'm here. How are you? That was a great closure over there. We were watching. Froze? Yep, that's fine. Can you hear me?
So Tubi, we want to see some sutures because you did all the sutures offline.
I was getting yelled at by the nursing team here. They said I wasn't going fast enough. They're going to hit me. So I had to hurry up. Helix out? Oh. Okay, so we're doing some sutures now. We're bringing this back. I think this is our 5th or 6th. And I can walk you through the deployment of the needle and the use of the cinch here momentarily. Okay, on Helix. I gotta say, this Cairo Live, it's a beautiful course, well done. The whole board. We've been watching here from Detroit and are completely impressed by everybody. So beautiful job. Helix out. Okay. Any questions so far about this or?
Yes. So what do you think about the results, Tubi? Because we had a bariatric surgeon with us. He just left. But he says that maybe, of course, it's not comparable to surgery. But what do you think about combining endoscopic sleeve with GLP-1s? Could it stand head to head to the laparoscopic sleeve?
So that's a great question. This was studied. And we actually do this. So she's going to see our metabolic health specialist. Before I answer this question, can I show you something on the screen? So right now, this is what I was trying to tell you earlier. My suture wire is cropped. See how that's making an X there with the sutures?
Okay. So you're now finished? You want to release the cinch?
No. So if I were to release something here, it may not go well.
Okay.
So before I take my next bite, I have to uncross this. Do you see how it's like kind of twisted there, the suture near my skull?
Oh, yeah, you mean the wire is twisted.
Yes, correct. So what we do, it's really simple. You just lift up, thumb down on the big dial. You push out to go around your trailing wire and then loop it over like this and push out some more. And now you're uncrossed. You see that? Maybe I can do it again.
Yes, I can see this.
Okay. So we'll cross here. We'll intentionally cross. So don't do what I'm about to do right now. This is not the goal. Sean, you grab this? I think we're twisted. There we go. Okay, yeah. Yep. So right now, our sutures are crossed. See how it's kind of making like a T or an X?
So you're
Yeah,
manipulating
here.
to get the tissue and
Yeah, so to do that, you just go underneath a bit, roll your hands to the left, push out, and then you're uncrossed. So that's a very common scenario. Now that you're uncrossed, you can close your needle driver, take your needle back on, put your helix out. Oh, go ahead. Okay. And now we can safely and effectively take our next bite. On helix. And now here we are. So what I'm going to do, I'm going to try to get 1 or 2 more bites in here. And then I am going to answer your question, and we're going to drop the suture. The helix out. Go ahead. All right, let's get a cinch. On
any
helix.
questions يا جماعة bariatric?
So, Shema, the surgeon was asking about use of GLP-1s, and there are studies out of Harvard that looked at this, and they found if you give a GLP-1 within 6 months, either on pre or post of ESG, they hit 23% total body weight loss for those patients. So that's why our standard of practice is to send this patient to our medical obesity specialist and have them get started on GLP-1 after this to maximize the total body weight loss. So it's a great question from the surgery team there. So what I'm going to do now is we're going to complete this suture. The first step is to release your needle, and that's what I have on the end of the catheter right here. When you do that, you really want 3 of these concentric circles outside of your horseshoe device, which we have here. You're going to hold down your blue button, and you're just going to gently kind of shake it. You see it release there? You see the needle? It's now off here. That's going to serve as an anchor on one end of the suture line to lock it in place or secure it. You take out your needle exchange catheter. You never throw that away. There's only 1 per box. And what I'm going to do now while Sean is loading up the cinch, that's the other anchor on the side of this. I'm just going to what's called pre-tighten. So I'm going to suction a little bit. I'm going to pull this wire because you can see now there's still a gap. That needle has not touched the mucosa yet. So I'm going to try to get the needle, which now is, I'm going to have it oppose the gastric mucosa. And the way I'm going to do that is pulling on the suture line, suctioning. And once we're in a good spot, I'm going to give Sean the suture.
Okay, so
What you have to do with,
yeah. We'll come back to you. We need to go. Please stay with us. We will go to iScope.
You got it.
Yes, okay. يا دكتورة جهاد.
مع حضرتك يا دكتور شيماء.
ازيك؟
الحمد لله. حضرتك كويس.
Can you present
احنا
لسه ما شفناك يا دكتورة جهاد ده. Yes. Can you present the case, please?
26 years old male patient.
You get the channel.
He underwent laparoscopic cholecystectomy 1 year ago. Then SASI bypass was done 9 months ago. He presented with obstructive jaundice 2 weeks ago. MRCP was done and showed moderate intrahepatic biliary radicals dilation and smooth tapering at the level of junction between common hepatic duct and common bile duct. It was related to the hilum, and it was bismuth type 1, where a defined soft tissue lesion was noted. It was 2.5 times 1.8 centimeters. Also, there was few mildly enlarged peripancreatic and porta hepatis lymph nodes.
Wait.
Then ERCP
Wait.
was done and showed smooth tapering at the level of junction between common hepatic and common bile ducts. And there was intrahepatic biliradical dilation of both right and left system.
Push the wire inside.
Sphincterotomy was done and followed by double pigtail insertion. It was 10 French, 10 centimeter, and there was a good drainage. PET-CT was done and showed TBD stent was noted in place, and there was exaggerated activity related to distal portion. SUV max was 4.4, and the SUV max for peripancreatic and portahepatis lymph node, it was low grade metabolically active, 4.1 SUV max. This is a case of a stricture at the level of junction between common hepatic and common bile duct for cholangioscopy plus or minus biopsies.
دكتور أديب.
Hello, دكتورة شيماء.
Hello, how are you? دكتور هاني معاك ولا مش مسبعك ولا ايه؟
هاني بيه معانا.
أنا موجود يا دكتورة شيماء.
منورين الاثنين. ممكن
طيب احنا طبعا
يعني دكتور ان انت بتستخدم كولانجيوسكوبي جديد يمكن واحنا برضو عندنا حالة سباي جلاس هناك الناحية التانية في مستشفى ناس، فعايزين نشوف الفروقات ما بين ال different cholangioscopies.
Tension the wire. So basically I'm using a Fujifilm cholangioscopy, one of the latest innovation of Fuji devices. It's 10 French device with a very decent working channel, which is around 2 millimeter, which means that we can do a lot of manipulation and intervention. Now we are trying to get inside the common bile duct. I need tension on the wire. I need tension on the wire. La. Tension on the wire. So basically, what I'm doing right now is just the first insertion. Of course, when we are talking about biliary structure, nowadays it's a dilemma that needs to be really tackled. And I guess having the fact of the innovation and the latest, let's say, cholangioscopies, and just to mention that this device, no, I need the tension here. Okay. This will allow me inside. Now I'm inside. I'm supposed to be inside now. Bismillah. So when it comes to biliary structure, we really need to make sure that we're not dealing with a cancer. And المايه مش connected. المايه مش connected. Yeah. Fluoro. The wire is almost out. That's fine. Okay. Here, no?
So, Dr. Adib, can we ask if this cholangioscope diameter, it looks larger from the standard spyglass. So can you tell us about the diameter of this scope and if it is easier or more difficult than the spyglass?
So I think the diameter of the Fuji scope is a bit bigger than the spyglass, but it comes on the account of the working channel, which is actually crucially important as we know that 2 millimeter working channel, it's quite decent. I think that we need to put the wire inside again because it's completely displaced out. Okay. It's a wire again. Yeah, fluoro. Yeah, push. Fluoro. Just push more the guide wire. Yeah. Push more the guide wire. Yeah, I think also. So I'm inside the compound duct now.
Yes.
The most important thing of, I guess the خلاص remove the guide wire for me because it ما هنا it's not injecting side. Yeah, that's okay. Remove the guide wire for me, please. So as you can see here, the resolution of the scope is actually marvelous, and I can guarantee that few cholangioscopes would offer this kind of really clear image. In addition to that, we don't need with this scope basically to go for to have a special processor, because you can just plug it in any device and it can be a portable device, even just to be able to operate the scope. Fluoro. So I guess basically we are now here at the level of the structure.
Yes.
I need to connect the water irrigation. Water should be continuous. Yeah. Yeah. Fluoro. Fluoro. Stop fluoro.
ممكن صورة الفلورو الكونتراست مش باين عندنا. Can we visualize it more?
Fluoro. So now we are in the main left hepatic duct.
Yes.
I don't know if you see the fluoro. Stop fluoro. I don't know if you see the cholangioscopy image.
جهاد، دكتورة جهاد، ممكن نشوف صورة الكولانجيوسكوبي يا جماعة مكان صورة الأوضة؟ عايزين نشوف صورة الكولانجيوسكوبي ونصغر صورة الناس اللي بتشتغل.
3.2 او تدمت.
التلسكوب او التلسكوب
كان الاكبر.
اوكي.
سوى نفس السيكنس.
اوكي.
مش توصلنا بسيكون.
So did you find the structure?
The scope is really flexible. The image, I don't know if you can see the cholangioscopy image. It's very clear over here. Now I'm at the hilum. And I guess here we find a stone. Yeah, this is a stone actually.
This is very strange because the patient had a mass. Yes. But this is good news for him because he's a young patient.
Exactly. So actually it's large stone, to be honest, impacting the whole thing. And probably what we've seen on the cholangiogram initially or the MRCP, it's the effect of the inflammatory fibrosis of the presence of a long-standing stone. So this guy, he's really lucky. And I think with couple of sweeps, he will be fine. I don't think that there is any thing to suggest that he would have a suspicious of cholangio. Here I am at the hilum, Floro. Yeah, we are in the hilum. This is the area where we can say the obstruction, and obviously no mucosal lesion.
So can I ask if there is a stone and there is a stricture? What's your opinion if we should have to take a biopsy to exclude like primary sclerosing, or we just can say this is related to the stone?
Of course, of course. We will not ignore the presence of a stricture, and taking a routine biopsy, as long that we are inside, actually it's going to help us to rule out any underlying malignancy or dysplasia. And as we know, long-standing stone in the biliary system, actually, it could be a predisposing factor to dysplasia or cholangiocarcinoma. So we will definitely take a biopsy, and we will retrieve all of these stone, and hopefully we relieve this patient biliary obstruction. Floro?
You will do a trial of balloon dilation and get all these stones out and this stone out?
Exactly. Exactly. Yeah.
So can we shift back to the United States?
Hi, Shema.
Tubi. Yes.
Yes. We're back.
Yes, I still want to see you.
Oh, all right. It should be coming in a second here. Hold on. All right. We're in Felix out. We're live. Can you see us now?
Yes, yes, I can see you.
All right, we're getting towards the end of the sleeve. You know, we take this to the GE junction. I'll show you. I'm good. I'll show you where we're at this second here. Let's see. So we're just working our line back. Go ahead, Felix out there. This is our 7th suture. So we may try to get in an 8. We'll see what we have here. Let's see what the sleeve gives us. On Helix. But what you're going to see here in a second is right now we're at the GE junction. That's the fundus over there. That's been our sleeve to the visual right. So we're getting close to the end here. As we're getting close to the end, is there anything we can walk through or discuss, help you out with? You accept? No.
So Toby, do you admit the patient for a one-day stay, or you can just release her to home on the same day?
Yeah, so we do on Helix, we do a prolonged recovery, and we keep them hydrated in the post-op unit. We keep them on a liquid diet for a week to 2, then a pureed diet for a week, then a soft food diet for a week, and then onto a regular healthy bariatric diet. Felix out there? We try not to admit these patients because in America, there's really 2 models. One is cash pay. So if cash pay happens, we don't want them to get stuck with a bill, but if we have to, we admit them on Helix. The other one is commercial payer insurance. And we have one of the few commercial payers in the country who will cover this procedure. It's called HAP. And again, we want to make sure that these patients have cause get the benefit from the weight loss therapy, Helix out. So we try not to admit them. We'll keep them in post-op. We'll try to treat their pain. We'll try to treat their nausea. But at times it may need to be done. On Helix?
So can I ask, is there a way to follow those patients, like doing another scope after a few months or volumetry So is there any need for follow-up of this procedure?
Yes, great question. You have to have follow-up. You know, we take a comprehensive approach, meaning most of the patients I see will have first seen a bariatric surgeon. They'll have had a discussion with them. They may have seen a medical obesity, so someone who prescribes pharmacotherapy. And we always send them to behavioral health or psychiatry pre-procedure. We send them to a dietitian pre-procedure. And afterwards, they get plugged into our bariatric surgery clinic pool. So what we look for there is to ensure multiple visits throughout the year. So there's many touch points. So these patients have accountability and frequent check-ins. And with that accountability and frequent check-ins, we know that the total body weight loss will be higher. We don't routinely do a surveillance endoscopy unless there's ongoing symptoms. Otherwise, most follow-up is with our nurse practitioners, our physician's assistants, our registered dietitians, and the bariatric team as appropriate. You can see we're kind of right at our suture mark or our APC mark here. So again, what I'm going to do, we have a little bit of oozing. I'm going to end this suture line here. So I'm going to push out, get 3 circles on, touch the mucosa. And then you'll see my needle is released here momentarily. There it is.
Yeah, so Toby,
So
we'll
once
come
that-
back to you. I have to shift to a
Okay.
case of EUS, but please don't release this. You release the cinch? Now.
Don't release the cinch. Oh, we'll wait for you. All right. I think we got to get one more.
Yes.
Okay. Now we present a case from a NAS hospital. It's a 36-year-old male patient, has a history of recurrent hypoglycemic attacks, for which he was diagnosed as insulin 3 years ago.
Shall I do it as you like?
EUS was done, revealed pancreatic neck focal
أحمد
lesion
مش
1.1.
الصورة يا أحمد، أحمد
1
الصورة مش
centimeter.
ظاهرة.
Can you see it now?
أيوة دلوقتي شايفين. معلش قول من الأول تاني.
Okay, we'll present a case for a 36-year-old male patient with a history of recurrent hypoglycemic attacks for which he was diagnosed as insulinoma 3 years ago. EUS was done, revealed pancreatic neck focal lesion 1.1 by 1.1 centimeter. FNB was done. The pathology was neuroendocrine tumor G1. The patient refused major surgery, so EUS guided radiofrequency ablation was done with significant improvement of the symptoms.
بس من ناحية تانية معلش.
The patient presented to us by recurrence of the symptoms 1 month ago. A new EUS was done. It revealed the small well-defined focal lesion in the neck head of the pancreas, measuring 14 by 11 millimeters. All major vessels were free. The pancreatic duct was not dilated and was not related to the mass. So this is a known case of pancreatic neuroendocrine tumor for EUS-guided radiofrequency ablation by Professor Hussein Okasha and Professor Bin Idea.
بسم الله الرحمن الرحيم. Good morning, everyone. As you hear the history, the patient had severe attacks of hypoglycemia 3 years ago and proved to be insulinoma by imaging. And FNB proved G1 tumor with high, of course, insulin, C-peptide during the attacks of severe hypoglycemia. So the diagnosis of neuroendocrine tumor insulinoma was made, and I did to him, he underwent radiofrequency ablation, and the patient remained symptom-free for about 3 years. But now, and during the last few months, he is complaining now recurrence of symptoms of hypoglycemia, first mild, but after that it becomes more and more severe. CT revealed activity, CT with contrast revealed activity inside the tumor. So we decided to do a second attack. After that severe attacks of hypoglycemia, we decided to do radio frequency ablation. تعالى كده عبد الله.
Do you start by doing FNB before to see if it
Yes,
changes?
FND was done before. Shiri color.
Because it's unusual to have recurrence of G1.
Hey, Dr. Vinay dear.
He left.
I am very happy and honored to work under his very valuable observations. This lesions is well seen from the stomach also.
Right, right.
And here we'll see with a slight inclination. I prefer to do it from the duodenum.
Yeah, it is good from
Because the duodenum is fixed structure. The duodenum is a retroperitoneal structure, while the stomach is intraperitoneal structure. So somewhat difficult to target it from. You stop at the surface of the lesion, and when pushing, the lesion it becomes away from you. It is pushed against the tip of the needle. But I think here from the duodenum as a retroperitoneal structure, so the needle is somewhat easier to go as the lesion is fixed and not mobile. Before doing radiofrequency ablation, we should look at the pancreatic duct. The pancreatic duct this is vessels. حط color كده يا باشمهندس. These are vessels. These are vessels, and this is the pancreatic duct. You see, this is the pancreatic duct, and these are vessels. So it is about 2 millimeters away from the pancreatic duct. When you measure it, yes, please. عندك السهم؟ خليك ماسك كده يا عبد الله. عندك السهم؟ السهم مش السهم مش مشكلة. Yes, this is the mass. These are vessels, these vessels, and this is the pancreatic duct. So when you measure the distance between the pancreatic duct and the mass, you can enter. Yes. It should be more than 2 millimeters. So do you agree with me that it is the distance between the pancreatic duct and the mass? It is about 3 millimeters.
What is this?
Yes.
Yeah.
Okay. See the color?
Yeah, what is that?
Color? This is a vessel, but this is not a vessel. Yes. But given the history that I did radiofrequency ablation before 3 years ago. So, but you are absolutely right. One of the maybe absolute or somewhat relative contraindication is the pancreatic duct should be at least 2 millimeters away from the lesion.
I think we can do prophylactic.
Prophylactic endomyosis.
Yes,
and
yes.
and we
then
did
yeah,
already.
Yeah.
Okay.
So we have already given endomyosis and
Yeah.
hydrate. I think that should be
Exactly. Endomyosis and hydration. Then we'll introduce. This is the needle. This is the RFA needle, EUSRA from Taiwan. We are working by Olympus machine and the newly introduced very nice processor, very high resolution, really very nice resolution. This is a new processor, ME3, EU, ME3 attached to Olympus machine 180 Olympus echo endoscope.
What is the gauge of this needle?
The gauge is 19 gauge. In the past, it was 18.
Yes.
But 18 was very thick.
And can we show them the RFA?
And this is
generator?
This is a generator, the Viva combo.
We can see the body there and we have the camera here. Can we have the camera? The generator. It shows the generator.
ماسك كده عبد الله ها؟ ماسك. تمام. Yeah, this is the Viva combo. This is the Viva Combo machine, the generator, and the device beside it is the pipes to cool the temperature. Because the ideal temperature for ablation is between 60 and 100. Below 60 is sublethal dose. Above 100, two undesirable effect occurs: charring and carbonization. Carbonization prevents spread of heat, and charring will induce sticking of the needle inside the lesion. So the temperature, sorry.
I'm asking, what is the voltage you usually use for these patients?
I always use 50 or 60, not low voltage, high voltage. I use low voltage in palliative radio frequency because the high voltage for a short time spread in a limited area. But low voltage with longer duration spread in a wider, but along a longer time. So I hear
How long?
the second actually to me it varies from 10 to 25.
Okay.
But a very practical way when to stop ablation, either two things occur. First, if there is a hyperechoic cloud extends along the shaft of the needle, then it is now spreading outside the lesion. Then immediately I should stop. This is the first point. The second, if the impedance hikes rapidly, the impedance is 100, 200. If it hikes or jump it to 500, 600, 700, then I should stop. Then I continue ablation counting 1 second, 2, 3, 4, 5 seconds, and stop if one of two things occurs. Spreading of the hyperechoic cloud along the shaft of the needle, or if there is a hiking impedance of a high, and Bashmandis Mahmoud معايا with me, he is telling me that. Then the needle is like the usual needle. This is calibration, and this calibration is the usual calibration of the needle. But here, when طلع دي بقى. The needle here, there is active tip. The heating tip of the needle is about 1 centimeter. طلعها كمان.
يا ريت
Yes,
الكاميرا
this
مان
is
لو
the tip.
سمحت يجيب صورة التب بتاعت النيدل، الكاميرا مان يجيب لنا صورة التب بتاعت النيدل لو تسمح.
Put it again. This it will look good.
بس طلعها شوية كمان يا محمد. طلعها شوية كمان.
شكرا. ايوه كده.
لا طلع دي.
اتفضل.
Yes, so this is insulator. The yellowish one is the insulator.
The gold color.
And the 1 centimeter at the tip of the needle, the most distal part is the active part of the needle.
Are you able to see it?
Yes.
There is yellow part which is insulator. And 1 centimeter, this is a metal tip which the heat transmitted to these metal tips. And there are variable lengths of this metal tip. It is about 1 centimeter, but there is 5 millimeter, 15 millimeter, 20 millimeter. But actually in my country, I use always 10. It is only available. Someone will ask, if the lesion is 5 millimeter, then how I apply 10? I apply 10, it is rather problematic. But we do it. But observe that the lesion is not subcapsular. Because if it is subcapsular and small, 5 millimeter, and you obliged to apply 1 millimeter, you can induce perforation. And one of the studies, the first 2 cases had 2 complications. One of them is duodenal perforation. The last thing that this is a rather not thin needle, it is 19. Sometimes from a duodenum, there is kink or J-shape of the endoscope, which may hinder passage of the needle through the endoscope. What I will do then I oblige now to do it from the stomach. Because from the stomach, the endoscope is straightforward, is not kinky. But in order to go to the duodenum, I should acquire a J-shaped position of the endoscope. So, بعد بسم الله الرحمن الرحيم ومعايا دكتور محمد نبيل القاضي one of my best colleagues and Dr. مصطفى بن عزوز توقفي في الحياة. Measure the lesion, yes. I think freeze first. Measure. No, the lesion.
دكتور حسين مع حضرتك عندي سؤال لو حضرتك تسمح لي.
لا. Yes.
Other side. No, the other side. Pardon. One more.
Yeah, so it's 15 millimeters or 15 millimeters.
15 millimeters. Okay,
Fine.
that is nice.
Fine.
Okay, then we'll start our work. بعد بسم الله الرحمن الرحيم.
دكتور حسين مساء الخير، ازي حضرتك؟
ايوه 00.
انتوا سامعيني في
اهلا
سامعيني؟
زي كوربورات.
دكتور محمد، دكتور حسين، حضراتكم سامعيني؟
ايوه انا سامعك كويس يا كرول.
دكتور بعد اذن حضرتك، هل وجود blood vessels او وجود some larger blood vessel inside the lesion
طب شويه.
ممكن يأثر على الديسيجن بتاع radio frequency؟
لا ال vessels, blood vessels inside do not interfere. Because the heat sink effect is not so obvious, not like the hepatic focal lesion. So the heat sink effect is not so important, but it is important, but not so important like that of the hepatic focal lesion. Okay, now I will get the needle out first, the sheath. Get the sheath out first. Will it go out? Now it is out. Very nice that it could pass through the now I will introduce it, but I should be more yes كده يا دكتور عبد الله. Color first, the last time color. There is vessel inside the lesion, and it is expected because it is a vascular tumor.
Yes, as the tumor is a highly vascular lesions. Yes.
Yes, and now I am now in, but not seen well. I should see it well. I should see the tip.
The middle. Yeah.
Yes.
Yes. Now it's good.
I think it is not. I should. I should. In the middle, but in the periphery. It is. It is the It is in the periphery. Yes. Now it is inside the lesion.
Yeah.
Now
Very good.
sterilized. Now good. Yes. Now I am good inside the lesion. What do you see?
Yes.
Perfect.
Okay. Then we will start. So this is the lesion, and this is in the, not exactly in the center, but it at least it is inside the lesion.
Inside the lesion.
Okay. Then we'll start, and the tip of the needle at the distal part
Of the lesion. Yes.
of the lesion.
Of the lesion. Yes.
I'd like to introduce it again a little bit.
Now it's okay.
Now it is okay. What do you see about that?
Yes.
Okay. And the second application, I will apply it in the upper part. Okay. Start. 550 watt. Okay.
Starting.
1, 2, 3, 4, 5, 6,
Yes.
7, 8, 9, 10, 15. Then stop. Enough. Okay. Now I ablated the right half of the tumor. I change the direction. I will get the needle out. Yes. And I should apply, I think I should apply a second part. I see that most of the tumor now ablated really. But I think there is this part. What you see about this part? Okay. Dr. Vinay?
Yes. Okay, good. Good effect.
But I'd like to have a second application in this area. What do you see? Yes, كده دكتور عمرو.
Yes. I think this place needs more.
Yes, I will withdraw it a little bit and adjust myself. Yes,
Yes.
adjust myself.
Yes, this one is good. This one is still.
Yes,
Okay.
but before
And-
going, I should see the needle.
And again, go there.
Yeah.
Then go there.
Yes, this is the needle. You see it?
Tip of the needle at the right side. Yes, sir.
It's hard.
Yes, I should do like that. كده يا دكتور عبد الله. And then
have too much.
slightly up,
The erector.
slightly up. Yes, I withdraw it. Withdraw, withdraw. Yes, now I am inside this area.
Yes, that's the
Yes.
a little bit. Because yes.
Yes, now I am in the most distal part of the lesion. You see it?
Yes, sir, yes.
Yes, now I am very nicely inside this part of the lesion. Agree with me?
Yes.
We can adjust ourselves.
Really outside. We are, I think that we are inside.
We can adjust ourselves. We can go out and
Yeah.
breathe in again.
Yes.
Just
yes.
Yes.
Better here.
Yes. Now.
Yes, I should be slightly up. I should push,
I would
then
just wait.
withdraw again.
Neither.
Then I think I am inside this
Yes,
one.
now this is the tip of the needle. This one.
What
we
what
did,
what do you see?
But
Nice?
yes.
Dr. Binay?
Yes, I agree.
Agree?
Yes.
I am working under your supervision.
Yeah, this is the tip of the needle.
Yes, this is the tip of the needle.
Yes,
Very
so-
nice.
so you're happy with-
Very
with,
nice. Yes,
so-
start. Bismillahirrahmanirrahim.
À l'intérieur, sur le
On a trouvé.
On a fait le coup de comète. Il y a toujours un
One.
coup de comète qui vient de la ligne. T'as vu? C'est exactement celui-là.
Can
Yes,
you-
very nice.
Yes, yes, it's very obvious.
Okay, stop. Yes, stop. Now, the whole lesion is now, I will withdraw it slowly, slowly, outside. Then I would like to apply maybe
This.
plus or minus third application to this area. What do you see? It's كده عبد الله. Now,
That's
I
is the-
started the remaining part. I used to do 3 applications.
Yes.
2 to 3 applications. So I am now very convinced with that.
Yes.
Yes. Bismillahirrahmanirrahim. Yalla.
لا، لا.
Start.
يعني جميلة جدا.
Start. 1, 2, 3, 4, 5,
بابا تكمل.
6,
بابا تكمل.
7,
بابا تكمل.
8,
كمل.
9,
كمل.
10, 11,
More,
12.
more, أديك.
Yes.
More,
Yes. Excellent. Excellent. Yes. Then, yes, stop. خلاص? Now I am getting the needle outside. Yes, color to be sure that there is no patent tract sign. Then very nice. And you notice that there was a vessel inside.
Yes, now it's
Now
not
there is
clear.
no vessel.
Yes, yes, not clear
There
now
was
this time.
a very big vessel here. There was a large vessel here. Then I will again, yes. And
It's
here
not
there is
clear,
hyper
yes, yes.
cloud inside. And here you notice that there is no color flow signal whatsoever.
Yeah.
In the first time, there is
Vessel.
a vessel, a large vessel here. And you asked
Yes.
me, Dr. Corollos, could we do it with vessels inside? Yes. I will not do more than 3 applications. In the neuroendocrine tumor, the recommended application are 1 to 3. But in palliative pancreatic duct adenocarcinoma, you can do up to 5, 6, 7.
Go in here.
Yes. And this is a vessel, maybe the gastroduodenal artery,
Yes,
maybe the
coming up.
vessel is the gastroduodenal artery, but we were away from it, pushing the appendix. So now I am convinced that it is everything will be going well. The focal lesion will not disappear, but just you notice the color inside. What about the flu? By the most important by the clinical parameters and the lab parameters.
So when do you check? After a week, after a month?
3 months. EUS, CT, MRI, 3 months, 6 months, 12 months. But much more important is the clinical parameters, hypoglycemia, and the lab parameters. In the first day, I'll do C-reactive protein and amylase. to observe for pancreatitis. And after that, I observe fasting, glucose, and C-peptide.
دكتور حسين
I think now
هنستأذن حضرتك دقيقة هننقل على اي سكوب بنشوف الحالة بتاعة
احنا
الكولانجيوسكوبي.
خلصنا خلاص يا دكتور كورونا.
تسلم ايديكم.
We finished خلاص نرجع لنا تاني. Here there is no hematoma, no كذا, and we'll reserve the need for the patient. He may need a second session or a third session.
Thank
We
you
are
very much,
not in
دكتور
a
حسين.
luxury.
هننقل دلوقتي على اي سكوب نشوف حالة الكولانجيوسكوبي.
معانا يا دكتور كارلوس.
دكتور هاني معاكم. تسلم ايديكم. تسلم ايديكم. تسلم. دكتور اديب حضرتك مشرفنا.
تسلم يا حبيبي الشرف لي والله.
ربنا يخليك. So now we have we are now extracting the stones as I believe.
احنا خدنا بايوبسي زي كرولوس بالكلانجوسكوب.
Yes.
بايت وبعدين دخلنا دلوقتي بنعمل سويبنج بالون عشان نخرج الصوت.
To clear off the stone, exactly.
Did
And
we
just
find
for the
any
correction,
any
because there was-
suspicious? Yes. Sorry.
It looks like but with the cholangioscopy, it looks like an inflammatory structure, to be honest with you, due to the long-standing stagnation of the impaction of the stone itself.
Yes.
It doesn't carry a worrisome feature, but again, all possibilities are there, and as long that we have a cholangioscopy tools, it's much better to confirm that this patient doesn't have an underlying dysplasia. So that's why I took a biopsies, and now I'm clearing the biliary tree. Referring to the question that has been asked to compare the cholangioscopy from Fujifilm and the spyglass from Boston, apparently they carry the same size of the outer diameter. Both of them are 10 French. The working channel of the spyglass is 1.2 millimeter, but with the Fujiscope, it's around 2 millimeter. So the diameter of the both of the outer scope working, the scope itself is almost the same. We're trying to clear the cone bile duct, but it seems that those stones, despite that they are small, and this is actually another challenging point. I believe that, I don't know, Dr. Majdi, if he concur with me. This is what we call a difficult stone, because it is impacted in the intrabiliary tree, despite it's not that big, but definitely it will require a laser lithotripsy.
Yes.
We've done CRE dilatation, and we've done a couple of balloon sweeps, but ultimately this patient will need laser lithotripsy or EHL to emulsify the stones and try to get them out. Inflate the balloon.
So we did multiple trials of extraction, yet the stones didn't come out yet.
Deeply. So I guess the lithotripsy is not handy at this point. So we'll just insert another stent to maintain the biliary drainage, and the patient will need definitely another session of cholangioscopy with lithotripsy. Give me a stent, please. Insert the wire. Yes. Yellow. Let's put 10 French 10 centimeter, okay? Great, whatever you have, that's fine. So any question?
Any question from the room? لو مستشفى الناس جاهزين احنا ممكن ننقل عليهم دلوقتي.
معلش سؤال سريع بس دكتور أديب did we
أيوة.
do a balloon dilatation for the CBD?
Sorry, ما سمعت السؤال. What was the question?
Did we do a balloon dilatation for the CBD?
Actually, the outer diameter, there is no significant structure, because the stone is impacted in the intrahepatic biliary area. So structuroplasty is not gonna help in this area, Shaima. This patient would need lithotripsy, whether laser or EHL.
But we can agree, Dr. Adib, that the cholangioscope completely changed the picture. We
Of course.
thought it's cholangiocarcinoma, and now can see just stones.
This is
Yes.
very crucial. At
Yes.
least will give us a comfort sensation that
Yes.
we're not dealing with the malignancy, or we're not expecting a cancer in this patient. It's a stone management, very simple thing that can be done in outpatient setting.
Yes.
Just thank you.
We will, Adib, thank you so much. We will shift now. We will go back to the United States. Can we go to Dr. Tobias Zacelli, please?
Unmuted.
Não, é uma fibra e depois mais.
Okay. A shame the video will be here in a second, okay? Our screen.
Sim, estamos
Should be sharing it now.
não pode.
I'm gonna put this back here.
Tive uma reunião,
Screen should be coming up any minute.
Os outros também não estão falando nada. Já foi lá cima, já tem alta. Não, falou com a senhora que está no repouso.
Hey, Martin, do you want to start sharing now? I think they're want us to go back on. Is it working?
No, the patient.
Perfect.
Vamos entregar isso já.
Fine. Let me text the host to let him know to give us access. Okay. Hello.
Dr. Nunes, do you hear us?
We're unable to.
We can see you.
Oh, I was just trying to look. Hello, Shaima, how are you?
How's everything?
Very nice. Congratulations for this huge event.
Thank you so
Fantastic
much.
demonstrations.
So,
I will be looking at it because I started my work this afternoon,
yes.
and I just saw myself. I just see myself. And congratulations, Shaima. See you someday. Okay.
Thank you so much, and we're really happy that you're joining. Maybe next
Yes.
week you'll be here physically, inshallah, in Egypt.
That will be
So,
great.
I want to hear your comments because you said you have some questions and inquiries. So can you
Yeah.
ask all the questions you like? You are live. We want to see your face again.
Okay. I will just this is I will just start working here at my hospital, and then I will keep observing the live show. Fantastic. I mean, congratulations again for your big effort and all the contribution that you give for the advancement of science in gastroenterology. A big and congratulations.
Thank you so much. Thank you so much.
Bye bye, Shaima. Bye bye.
خلاص ممكن نروح على أمريكا يا دالاس. Can we go to Toby?
Sheva, we're trying.
Yes, share the screen access.
Video access here.
I want to see you again, Toby, please.
Yeah. We're trying to get video.
Shayma, Dr. Shayma is asking us that.
I hear my.
We're talking to Iris now to help out.
Okay.
Toby,
Yes.
can you speak Arabic?
La.
لا.
La teki Arabi shwe shwe.
Okay, we're back on. Thank you, Osama. Thank you. Appreciate it. All right, we're on.
All right, let's see. I think we're live. We got us now?
Yep.
Yes, I can see you now.
All right. How's my Arabic?
Okay.
It was him talking. Omar, can you say hi?
Salmi, marhaba, marhaba.
Marhaba. Marhaba.
Okay. So we are at the end of our procedure. We're at the end of the road here. We've had the sleeve completed, and we just need to put in the last suture. We have the fundus right here. We don't want to suture there for a bunch of reasons. One, there's no clinical benefit. Two, it's a very thin wall, high risk of perforations. And three, we're talking to Jody in here. We were all talking about different aspects. And, when you distend the fundus, ghrelin is released, and you may not be as hungry, you may eat less. So a benefit, and there's always the potential benefit, no one really understands why. But with the surgical sleeve, there's a high risk of de novo acid reflux. With an ESG, there is not. So maybe the fundus is the role. So what we're going to do here, you can also see we're right at the GE junction. So right about there is the top of the gastric folds, right below my scope. So what we're going to do is we're going to have our cinch out, and this is our cinch. It looks like a little white Q-tip or an anchor, and you're going to push this against the gastric mucosa. The cinch goes where your first bite went. So wherever you put your first suture, that's where the cinch will go. You want to see at least 3 of these concentric circles out before you deploy this. You're going to suction down a little bit, and you're going to see the suture there. The suture is sliding a little bit. I have enough tension. I know what it feels like. I can feel it. And I'm going to pull back here, give a little suction. And then we got a sub in. We have Bree with us. So I'm going to tell Bree to go ahead and deploy there. Yep. And this is one of the hardest parts of the procedure, is releasing the cinch. You have to find the strongest nurse possible. They have to use 2 hands, and they have to release the cinch. Okay. So yeah, take that out. Now, an important thing. Close your needle driver before you come near the GE junction. Okay, here's the GE junction, because the needle driver is blind. You can't see it. It hangs out in the scope. So if it's open like this and you come out with your scope, you could create a perforation. So always make sure that that is closed before you move around too much. Now we have our fundus here. I think we could get in another suture there if we needed to, but I'm happy with this. We got in 8 total sutures. And now we have our sleeve. We're going down here. We're going down to where the incisura is. This is the incisura. This is the antrum below us. And now we have our sleeve anatomy. Any questions, Shema? Anything we can walk through? So again, we reduce the capacity of this stomach by at least 70%. And that's the main goal here. And you can see actually our suture comes right near the GE junction right there.
Very, very nice, Toby. This is really an amazing. Thank you. Thank you so much. Thank you so much.
Thank you. Thank you for allowing us to be a part of the course. Beautiful course. Congrats to all of you for running such a spectacular event. Omar's going to conclude with some nice Arabic conclusion. And we miss you guys. We hope to see you all soon.
شكرا لكم وتحية من هنري فورد في ديترويت.
Oh, hello. So, Toby, can you tell us about the post-ESG instructions? Can you tell us about what to do to the patients afterwards?
Yes, of course. So the main thing is going to be when we get her in post-op, when we get her in the PACU, we're going to keep her NPO till I can talk to her. From there, we're going to keep her hydrated. Then the diet is really going to be based on liquids. So we're going to have her on a liquid diet for about a week to 10 to 14 days, depending on how she's progressing. Then we'll switch over to a puree diet for a week to 10 days. Then a soft food diet for a week to 10 days. And a healthy bariatric diet after that. The main things are, our touch points are, one, we will call her tomorrow to see how she's doing, to make sure she's getting enough hydration in, being able to get enough protein in. 2, we will get her set up with a dietitian next week to further ensure that her dietary needs are being met. She'll follow up with our physician assistant in about 4 to 6 weeks in the office. But we'll continue to have check-ins with her, with the bariatric surgery team, because we work in conjunction over the next 6 months. At the 6-month mark, she'll follow up with our bariatric surgery PA, and then we'll track her progress and continue to go from there.
So
2 last things. We'll send her home with liquid Tylenol. I'll send her home with sublingual PPI, and I'll send her home with sublingual Zofran to help her get over the next few days.
Yes. So, Toby, I'm going to ask you a question about the training curve, the learning curve for ESG.
Yeah. So, they've looked at this studies. This is not, it's not my number, but generally it seems to be about 7 to 10 ESGs, and you can 90% of people will obtain proficiency around that time. I'm part of an ASG training committee, and we're looking at, getting ACGME credentials. So that's the official board for a lot of therapeutic procedures we do. And I think, one of the numbers is going to be a little bit higher than that for a program to do per year to maintain proficiency. And in America, high numbers of ESG become tricky because it's not socialized medicine, as everybody knows. So if the patient can afford the price tag of paying out of pocket for ESG, then you can be a high volume center. But in the past, insurances have frequently would not cover the procedure, so it slowed the growth for a vast number of patients throughout America. But now that atmosphere, that climate is changing, and it's allowing more and more patients to get in for ESG now that commercial insurance is paying for the procedure. So I think that number will change. I think it will go higher, but for right now, based on studies, it's around 7 to 10.
Okay, thank you so much, Toby. Thank you so much. It was really an honor. And how is the what is the time now in the United States?
It's 11:40. We got all day. You want us to do another case? We got more.
Yes.
We got a poem next. We're ready here.
Yes, around 7 p.m. now. So thank you so much. And we really appreciate it. Maybe next year you'll be joining us physically here. Thank you so much. Thank you.
Thank you. Thank you for having us. Have a great night. Thank you.
Yes, thank you.
Congrats.
Thank you. So now I believe we have a case from Al-Nas Hospital. Can we start presenting the case in Al-Nas Hospital? ممكن يا جماعة تشوفوا لنا مستشفى الناس بعد إذنكم؟ إيه؟ طيب ممكن حتى يبريزنت الحالة.
دكتور احمد زايد، ممكن تبريزنت الحاله اللي جايه اللي بتعرض الايس دي اللي بتعمل من عندك؟ طب على حد ما مستشفى الناس تبتدي تكون الحاله بتاعتها جاهزه، نتشرف ان الدكتور محمد شربيني هيقدم لنا سيمبوزيوم بوستون ساينتفك.
قعدتوا بالحالات يا جماعة؟ لسه في طاقة اللي واصلة. طب عندكم اي اسئله في الحالات اللي اتعملت؟ طيب نقدر نفيدكم بيها. انا عارف ان طيب انا مش عارف انتم مبهدليني ليه في المؤتمر ده. مش عارف اروح فين ولا اعمل ايه بالظبط. اعتقد انا جاهز دلوقتي. ممكن تنقل يا عم. اعتقد الصوره عايزه تتظبط شويه. طيب بسم الله الرحمن الرحيم. Today, this lecture, I'm honored to present the Symposium of Boston Scientific. ويمكن هي حظي حتى لو التأخير ده حصل، بس هو عشان الحاجات اللي كنا هنقولها احنا شفناها من شوية لايف في الكيس. هو actually ESD هو first established in Japan 2003 for resection of early GI tumor mouse. هي نفس الحاجة. الصورة واضح مش واضحة للناس. افتحها واقفلها تاني بالطريقة المصرية. طيب هي واضحة يا جماعة طيب ولا مش؟ عشان أنا مش عارف. أقفله وأفتحه تاني؟ يعني إزاي أغير أخليه؟ ما هو ده. أغير كل السلايد؟ محدش عارف خالص ولا أي. لا نفس القصة.
شكلها هنا مختلف تماما.
طيب لا هو حد بوظتولي الكمبيوتر بتاعي. ماشي. طيب طيب فهو established الايس دي الاول في اليابان، وكان الهدف كله resection of early GI tumors T1A، وبداوا يتكلموا على T1B يمكن في الاونه الاخيره. طبعا كان ديزاين فور بيجر وكومبلكس ليجن resection علشان يوصل للجول which is M-block resection with safety margin، وهو ده يمكن كان الهدف الرئيسي من الايس دي over multiple او بيس ميل EMR. الستبس اوف ايس دي قلناها كذا مره. It's about characterization of the lesion, then marking around the lesion to make safety margin. After that, submucosal injection and lifting, then circular incision. After finishing circular incision, we go for specimen retrieval, handling, sending to pathologist, then to close or not to close. This is a simple case, as we can see on the first photo. This is a lateral spreading tumor at the cecum. We started to put marks around the lesion using the chromoendoscopy. After that, after performing submucosal injection, we did circular incision going below the lesion and try to dissect in the same plane, in the submucosal plane, until finishing the whole lesion. Here is in the ascending colon in the cecum, we should close the defect. So, is not always easy. Life is hard sometimes. مش دايما الامور بتمشي كده. لو نتخيل ان احنا شايفين such lesion, such circumferential lesion، احنا ممكن ازاي نتعامل معاه؟ هل الكلاسيك ايز دي هيمشي زي ما احنا شفناه كده سهل؟ لا، ازاي نقدر ندايسكت this circumferential lesion in such rectosigmoid region؟ This will be a challenge علشان نوصل للنتيجة اللي احنا شايفينها في النص. وازاي نقدر نعمل الكلام ده؟ مش دايما الايز دي بيمشي so easy زي ما احنا بنبقى متخيلين. واحنا شفنا من شوية very tough case علشان نقدر ازاي نشتغل. دايما مش الموضوع بيمشي كلاسيك. عندنا a lot of challenges in ESD: lifting, how to go below the lesion, how to hinge below the lesion, how to do mucosal flap, stability stable لو مش كويس في لوكيشن عند فليكشرز في جزء زي ديودنم. تراكشن، هنقدر نعمل تراكشن ولا لا؟ ازاي هنبقى below the lesion؟ الكومبليكيشن، can I handle the complication? Can I manage the complication? Can I have the capability and ability to manage complication? And what about learning curve? A lot of methods اتعملت عشان يقدروا يتغلبوا على مشاكل الايز دي او التشالنج. لذلك كان الهدف من المحاضرة how to optimize that. ازاي نعمل optimization للحالات الايز دي عشان نوصل ل the perfect solution. So it's a matter of right decision. It's not a good decision. It's a matter of right decision. How to take a right decision in every lesion. لازم نبقى عارفين من الاول الكاركترايزيشن بتاعنا. انا فاهم يعني ايه بارس كلاسيفيكيشن، فاهم يعني ايه جينيت كلاسيفيكيشن، عشان اقدر اقول هذا الليجن امنيبل فور اندوسكوبيك ريسكشن ولا لا. الاوضه بتاعتي لازم تكون مجهزه باحدث الاندوسكوبي بالالكتروسيرجيكال يونت. المعينين بيناموا بجنرال انستيزيا. التولز، we have a lot of tools. We have to be fully equipped using injector, cap, hot biopsy, and clips. And definitely the knife is one of the major important thing. It's your weapon. ده سلاحك، ده الحاجة اللي انت هتشتغل بيها، ده الحاجة اللي انت هتبدأ تعمل بيها الدايسكشن. من ضمن ان انت عايز تستخدم نايف كويسة زي البرو نايف زي ما شفناها في الحلقة اللي فاتت. You have to know everything about your knife. The lens, and how will you choose your lens according your location. It's in duodenum, in the right colon, in gastric or rectum. Also, you have to check the capability of this knife that it will inject. You need injection manually. This knife is not that good in the injection or not. So it's very important to know all advantage, pros and cons of your knife. Everything is hard before it's easy. طيب خلينا نشوف كيس زي دي كيس في الريكتم. As we can see from start, we'll see that it's two lesions. It's not only one lesion. And here is the first lateral spreading tumor, maybe towards the cecal side. And we have to use your scope with this quality, use chromoendoscopy to assess your lesion before going to the lesion. Then after that, you have to put a plan. Here, start by incision from the cecal side. We can see the beauty of the knife that's very clean, sharp, can do clean cut on retroflexion with the stability of the tip of the knife even after performing retroflexion. So it's very important to choose your plan, to choose your knife before going to such a lesion. Here is a classic ESD, but we prefer to start on the cecal side because here in the rectum it's much more stable to do dissection on retroflexion because the scope is anchoring in the rectum, and it will be much more stable if you're going in forward position. So this was our plan, and then after that we went and we shift to forward view and injecting, and we can see that also that injection is good until we can reach to this clean bed. After that, you have to assess the lesion and then sending this 2 lesion, we remove 2 lesion in one piece to dedicated pathology. Also, we can encounter or face such globular lesion here, we change our strategy to perform ESD using bridge technique. Bridge technique, it's a mix between buckets, tunneling, but here we'll go for 2 buckets. We'll start by performing bucket on retroflexion from the cecal side, and then going on forward view and doing bucket ESD, and then we have to connect both buckets to each other until to make like a bridge or tunnel. This one of the tunneling technique, how to use tunnel in performing ESD. Here we can see the knife can inject very easy. You can manage blood vessel because you have a good clarity. You can manage blood vessel as you can see. Here we formed the bridge. We can see 2 pillars, one on the right side and one on the left side. And here we went through the bridge and doing retroflexion. Now it becomes very easy to cut one of both pillar, then going to the other side until finishing the whole lesion. But also you can encounter such ugly lesion in the fundus of the stomach, maybe on the esophagogastric junction, and as we can see, it's very tough. Here we have to choose a very good knife for your dissection, especially in the stomach with highly vascular organ, and such lesion is highly vascular in that region. Here we choose 2mm knife, and now we are performing dissection on retroflexion. Stomach is a very vascular organ, so you have to do every step during dissection under vision. Here we can see a large blood vessel. Now we are performing coagulation without changing the knife itself because it's very precise that you can move all over along the whole length of your tumor until you finish the lesion. As we can see here, this is a bed after resection, and now its bed is clear. Go for hemostasis, and here no need for closure because it's a very thick part. So it's just do hemostasis, keep your patient for 24 hours. Can you see this such great lesion or such a huge lesion in this difficult part? Also, you can use pro knife in performing duodenal ESD underwater. We can see this lesion in D2 or descending duodenum. Here we start to use endoscopy to assess lesion. We inject a lot of water, switching off the air or CO2 definitely, and starting to inject in the submucosa. Here in duodenum underwater ESD is very challenging because you are dealing in a very thin wall, unstable position definitely, and also you are you have a lot of challenges like what will happen if you have perforation, if you have bleeding, and here you have to close this defect or mucosal defect after dissection, even you didn't encounter any muscle defect. So it's very important to be precise in everything. You have to optimize the whole condition, starting from the scope, from the accessories, the knife itself, and you have to be fully equipped using all closure defect before performing your lesion. Here we can see the beauty of water or the buoyancy effect, as we can call it, because buoyancy make your flap is very easy to go below the lesion, good visualization. I think it's a matter of zooming because of water here until we go to the cecal side, and then we can dissect the last part. After that, we have to close this because in duodenum, a lot of pancreatic juice and biliary juice will come to the resection bed, and you can encounter a lot of complication. So our decision here after that, we have to close this mucosal defect. We didn't encounter any muscle defect. Here is the mantis clip, as I showed you in the last case. This like hook. So mantis clip going to one of the edge and then catch and then do a little bit rotation to right and left to make sure that you catch the edge good. Then after that, grasp the edge and going to the other edge of the defect and then close and then wait. I think with approximation of this edge, no need for more mantis clip. You can approximate such large lesion with one mantis clip and then put a regular clip. But if you encounter a larger defect, you can use 1, 2, or 3 to approximate, then put a regular clip in between, as we can see here in our case. So this is the mantis clip. Also, we can see this a very tough area or difficult location, as we can see here in the splenic flexure. Here is how to apply the clip. Now, after grasping one edge and going to the other edge, you will see the defect, it become very small. So my take-home message: success starts before incision, careful lesion assessment and planning. The right knife, right electrosurgical unit setting, improve precision and efficiency, maintain the correct submucosal plane all the time for safe and correct dissection, secure defect closure, reduce adverse event, and complete a successful ESD. Every step matters. Optimization from incision to closure translate into better outcome, greater safety, and higher confidence. Great ESD is not one perfect move. It's a series of optimized decisions. And thank you.
Any question from the hall? So rapidly we will just هنتنقل على طول على مستشفى الناس، هننقل حالة EOS. دكتور أحمد ممكن تردنا الحالة بعد إذنك. Last 2 cases of the day is a very heavy meal, but خلاص قربنا نخلص. هانت. دكتور أحمد اتفضل اعرض الحالة بعد إذنك. في حالة EOS وحالة ESD, the last 2 cases. دكتور أحمد أنت سامعنا؟ دكتور أحمد زايد سامعنا من هناك؟ تبتدي تتحرك؟ يا شباب مستشفى الناس.
Dr. Kronos, can you hear me? Hello?
أحمد معاك.
Can you hear me, Dr. Kronos?
اتفضل يا أحمد اتفضل.
سامعني؟
اتفضل يا أحمد.
Okay, now we'll present the last 2 cases of the day. This is a 68-year-old male patient that's non-asthmatic. The patient presented by anemic manifestations and weight loss. Colonoscopy revealed multiple angiodysplastic lesions for which APC was done. It also revealed a subepithelial rectal lesion, 2 by 1.5 centimeters, about 10 centimeters from the inner verge. So this patient is a case of a rectal subepithelial lesion for endoscopic ultrasound by Professor Vinay Dir and Dr. Hussein Akash.
Hello. Can you hear me? Can you see me?
Yes, we see and hear you, sir.
Okay, can you get the images? Are you getting the images?
Yes, the images are in a very good quality.
Very good quality. That will be 1, 2 somewhere in the endoscope. Processor, endoscope processor. So we are trying to search this lesion. It is supposed to be at around 20 centimeters. Yeah, so you see, we are going in. This is all scope trauma that you are seeing. This is the lesion. Can you see the lesion?
ممكن نكبر صورة السونار لو سمحت. كبر صورة السونار بعد إذنك.
See, this is the lesion. What here? The submucosal lesion. Depression is not. You can see the lesion.
It is it's below to the right, in the lower right quadrant of the screen.
Endoscopically, yeah.
Yes, yes.
Now let's make the EUS big and put some water. And can we give some Buscopan?
ممكن بسكوبين.
هو احنا we are here giving some water in order to delineate our lesion more and yes.
So it is at a
Yeah.
So the scope keeps falling. You know, this is a EUS scope, not a colonoscope. So difficult to maneuver a bit. So, and there are contractions. So I'm giving Buscopan. I don't know how many of you do that. I give in all my colonoscopy patients.
Yeah.
And it really works very well. So now we are okay. I have reached till about 15 centimeters.
Yes.
So we briefly saw the lesion, and now we have come back again. The scope has fallen. Here is the lesion. See here?
Yes, to the right side of the
Here. Okay. Buscopan given?
Buscopan? Yes, given.
A little more water, please.
More water, يا وحيد.
So we want to see what we are dealing with here.
Yeah. So giving water will help us to decrease or to reduce the effect of air on the image.
Good interface. But as you know, colon, there is a lot of air. So
yes, we now start to see the tip of the lesion. Yes, in such a picture.
Yeah, we are seeing the lesion, but it's not in a very great position.
Yeah.
So we have to delineate it fully.
Changing the position of the patient may help.
Here is the lesion. More water, please.
So we are giving some more water in order to decrease also.
Yeah.
Yeah, we are now standing.
But we are seeing it. It's right at the bend. So we are not seeing it very well.
Also, water irrigation can help us in the duodenal lesion. Duodenal lesion and also our papillary lesion and papillary masses. It will help us also to furthermore show outlines of the lesion.
So this is the sigmoid. You can see this is all sigmoid.
The sigmoid colon, yeah.
Sigmoid colon. See that? Yes.
So now the water, it is gives a very good picture, but it
water makes it easy.
Yeah.
Not seeing very well. There is air.
The patient is fine for you. Maybe the lesion will be inside the water, and that time will take.
Yeah, we can try that. Let's turn slowly. Yeah. Why not? Yes.
Please, the patient in supine position. I will be not if it you can. I will help. Okay.
Sorry. So I am helped by two very big experts, Professor Okasha.
Now
Okay. Let's see.
Check now.
Wait, what is the level now? We are coming down. Endoscope.
It will not is like this.
Okay. Oh, it came out. Scope came out.
Yes.
So we introduce again. No problem, no problem.
Okay, again.
Can we go back? Can we go back to the left lateral?
left lateral تاني
Yeah.
معلش عشان
To put it like this.
There is a pajama there.
Yes, and you will. Okay. Yes, you see. Okay.
Fancy anything.
No, I can do it. But glad I will do it.
ممكن دكتور مصطفى دكتور مصطفى
Yes.
Endoscope. I am not happy here. Give me my left lateral position again. No, it's not the question of jelly, man. He's a very old man.
And the radial probe for this kind of lesion. Radial probe. It needs
To the radial.
down torque.
Fantastic. If we
Okay. We are back in. What is happening now? It's ready to go in. So this has become an exercise in colonoscopy more than exercise in EUS.
طبعا يا دكتورة سعاد طبعا طلعش التطريق بس
لا والله الراديال احسن هون.
طبعا
اكيد استاذ.
لكن احنا ما عندناش
If I have a radial one, it will be
Pedunculated. فبتروح من جهة وتروح من
We are
جهة.
now searching for the lesion at back.
Yeah, can you put it left lateral? I'm not understanding.
the depth until we find.
Can we turn the patient left lateral, please?
Radial?
Left lateral. Okay.
Like this?
Yeah.
And I will now
بيقول لي
on the right.
هتقول بقى ايه
And make the yeah, this is better.
ده مش انا اللي كاتب التقرير ده هي في 14 صح all major vessels are free
Unfortunately, we don't have the radial scanners.
Falling out.
The radial scanner sometimes had been such situations.
It keeps falling. That's the problem. Okay. See, comes and then it goes. So I'm not recommended.
I believe that, as I mentioned, that the radial scopes in such situation will be more beneficial than the
Stable.
yes.
Yeah.
What's EUS radio frequency ablation? EUS RFA was done.
Now we are approaching it.
Process, 3 applications.
Very difficult.
It is around 10 centimeters from another. Now we are approaching to this.
We are approaching, but we are not able to remain stationary there. Can we make the endoscope big? Endoscope. Yeah.
Like this one.
Now see how much trauma we have created here. So now we go here. We go here. Now. But at this point,
So, Professor Vinay, We are so sorry for that because we are running of time. We
Go ahead,
exceed the time by 1 hour, unfortunately. So hopefully we need to close this session, please. Okay.
Yeah, go ahead.
And then we will meet you maybe in 1 hour. Okay.
Yeah.
So thank you. طيب يا جماعة يعني نعتذر لو اتأخرنا شوية عن عن السكادول بتاعنا. ان شاء الله تكونوا استمتعتوا بالحالات ان شاء الله. بكره يوم اخف شويه من النهارده والستارت شاربلي ات 9 الصبح ان شاء الله. عندنا في القاعه دي training course for nurses. It's like master class support by theoretical part واعتقد الاجنده كلها موجوده عند زملائنا. هيكون موجود في القاعة وفي 4 station للنيرسز. They will rotate between all station after the theoretical part. In the exhibition area في المعرض اللي موجود بره القاعة الساينتفك we have master classes, advanced techniques. In the morning we have 4 station and evening 4 station also. It will start from the advanced polypectomy EMR up till defect closure, passing by endobariatric, ERCP, EOS, using hot axios. So it's 8 master classes, 4 in the morning and 4 in the evening. ان شاء الله بكره في 2 لايف ترانسميشن، واحد قبل الصلاه وواحد بعد الصلاه. في محاضرات على حاجات كتيره جدا في المناظير، حاجات جديده يعني، حاجات هتسمعوا اسماء، حاجه زي البوب. ايه البوب في المناظير ده هتعرفوه بكره ان شاء الله. شكرا يعني على وقتكم الجميل. وفي غدا يا دكتور اشرف للناس. فين حضرتك؟ مطعم كده شكله كويس. تراس، بيكاسو تيراس، بيكاسو تيراس. ماشي تمام. شكرا شكرا، نشوفكم بكره على خير ان شاء الله.
ايوه مع صوري بعتها مع صوري بعتها دكتورة هيام يا دلس
Gente, mais uma pausa. A relembrar o passado e outras coisas mais que aconteceram no último ano.